And repeat. Helder Philippe Fumo. Ernest Tsarukanayi Maua. Yes, he's already there. What is your name? Okay, Rebecca. Great. So there's we are waiting for one person so that we can start. Philippe, Saïdou, Jean-Pierre, Albert. They are all absent? So without wasting any time, if the person in charge of ICT, is he ready? No, we don't have interpreters. And we are looking also for the assessors. We have Cephas Sialubanje and Data Karen. Yes, the assessors, the evaluators. Data Karen. And where is the other evaluator, the other assessor? Cephas Sialubanje. Where is Cephas? Is not here? Is that you? And Data Karen. So thank you very much. The two assessors are there, so we can start. The three presenters are here with us, and are you ready? So you have 5 minutes for your presentations, for your posters. And who is going to take the floor the first? Ernest, maybe? Ernest? Ernest, you can take the floor. Ernest, you have the floor.
Ladies and gentlemen, a very good morning to you. I'm Ernest Mawa from Zimbabwe. I stand to present our findings entitled Achieving the 95 Fast-Track Targets, HIV Care and Treatment Cascade, Zimbabwe 2021. This was a secondary data analysis. Zimbabwe is one of the highest HIV prevalence in sub-Saharan Africa at 13%, with about 1.3 million people living with HIV. The HIV care and treatment cascade, or the HIV continuum of care, starts with people living with HIV, having an HIV diagnosis, being initiated on antiretroviral therapy, with retention in care and good ARTS adherence, virus suppression is achieved. The Zimbabwe population-based HIV impact assessment, the ZIMFIA 2020, on the 1990 targets, Zimbabwe achieved 87% of people living with HIV knowing their status, and 97% of them were on lifelong ART, with 90% of these achieving viral suppression. Zimbabwe then adopted in 2021 the ambitious 95-95 UNAIDS targets towards HIV epidemic control by 2030. This study sought to track the progress in attainment of the fast-track targets, identify gaps, and inform the HIV care and treatment program. We undertook a retrospective record review, and our data sources were the District Health Information System, the Electronic Patient Monitoring System, and the Laboratory Information Management System. Frequencies and proportions were generated for the 95-95 targets. There were about 1.3 million people living with HIV in 2021, and 94% of these knew their status, whereas 96% were on lifelong ART, and 93% had achieved viral suppression. Therefore, Zimbabwe achieved 94, 96, 93 against the 95, 95, 95 targets in 2021. There were over 1.2 million adults living with HIV. However, 97% knew their status, whereas 95% of them were on ART, and 94% of them attained viral suppression. Therefore, in 2021, for adults, Zimbabwe achieved 97, 94, 95, 97, 95, 94 against the 95, 95, 95 targets in 2021. For children, there were over 72,000 children that were estimated to be living with HIV in 2021. 73% of these had their status known, and they were all on ART. However, only 79% of these had achieved viral suppression by 2021. The viral load testing cascade shows that there were over 900,000 viral load samples that were collected in Zimbabwe in 2021, and over 500,000 had received their results. 3,456 had their first-line antiretroviral therapy regimen switched to second-line, whereas 227 had to be switched from second-line antiretroviral therapy regimen to third-line. For mortality per 100,000 population for Zimbabwe in 2021, the national was 120.2, and 5 provinces, inclusive of Harare and Bulawayo, had their mortality that was above the national mortality. Our key findings were that Zimbabwe has made remarkable progress towards the 95-95 targets, and this is attributed to several strategies, inclusive of the treat-all approach, index case testing, defaulter tracking, and enhanced adherence counseling. However, children do lag behind, but with intensified case finding to identify more children living with HIV in the growth clinics, immunization clinics, inpatients, and malnutrition centers is pivotal. Public health actions that were undertaken included the dissemination to the Physicians Association of Zimbabwe, where focused case finding among adults to identify more people living with HIV, targeting the first 95, furthermore increasing viral load coverage to those retained in care. The Matabeleland South Provincial Health Information Officer and the Beitbridge District Medical Officer with the Public Health Officer further analyzed the Matabeleland South Province HIV mortality during data analysis skills transfer. Ladies and gentlemen, thank you for being attentive.
Merci Ernest.
Thank you very much, Ernest, for your presentation. I would like to invite now Thomas for your presentation. Thomas, you have 5 minutes.
Good morning, ladies and gentlemen. My name is Mtizwa Mpedziswa. I'll be presenting my findings from the topic Predictors of Time to Viral Load Suppression in Young People in Gwanda District, Zimbabwe 2021. This is a secondary data analysis, and as a way of introduction, globally 1.8 million young people are infected with HIV, and 89% of them reside in sub-Saharan Africa. United Nations member states aimed for 1990 targets. However, Gwanda district failed to meet the viral load suppression average, with viral load suppression young people lagging behind adults and the national goals. Delayed viral load suppression leads to continuous transmission, and it hinders achievement of national objectives. This study determined the predictors of time to viral load suppression. We conducted a retrospective record review from 2020 to 2021, and our variables of interest were categorized into demographic, behavioral, clinical, and preventative therapies that were initiated. We analyzed the data using EpiInfo version 7. Ladies and gentlemen, we managed to review 677 records, of which 60% of them were from female patients, and the median time to viral load suppression was 207 days. We observed significant time differences in the categories of baseline viral load, with those with baseline viral load greater than 10,000 on initiation achieving viral load suppression 15 days earlier. We also observed significant time differences in those who were initiated with cotrimoxazole preventative therapy, with those who were initiated achieving a viral load suppression 24 days earlier. Furthermore, we also observed significant time differences in the achievement of viral load suppression in individuals that were initiated tuberculosis preventative therapy, with those who were initiated achieving viral load suppression 75 days earlier. We conducted Cox proportional regression, and we realized that CPT, non-migrant TPT, and substance use were independent predictors of time to viral load suppression. And of note, preventative therapies had a high effect in achievement of earlier viral load suppression, with individuals initiated on CPT achieving viral load 3 times earlier, and those on TPT achieving viral load suppression 5 times earlier. In conclusion, early hospital presentation and preventative therapy initiation reduced the time to viral load suppression. Drug substance and living outside the country delayed the time to viral load suppression. Our public health actions included that we presented these findings, and a refresher training for sensitization of health workers to increase TPT and CPT coverage was conducted. As a way of recommendation, we recommended improved access to targeted viral load and CD4 monitoring, continuous care, and improved HIV follow-up services, and intensified adherence support for migrants and substance abusers. Ladies and gentlemen, thank you for your attention.
Merci, Tom.
Thank you very much, Thomas. Now it's for you, Rebecca, to take the floor. You have 5 minutes.
Good morning. Okay, cool. My name is Rebecca Kunzire, and I'm a fellow with the Uganda National Institute of Public Health, and I'll be presenting trends in HIV service delivery model utilization among children and adolescents in Uganda 2020 to 2022. In Uganda, progress towards the UNAIDS fast-track 95-95 goals among children and adolescents living with HIV, CAL-HIV, according to program data as of September 2022, was that 83% of CAL-HIV had been identified, of which 73% were on art and 72% had achieved viral load suppression. Differentiated service delivery models, DSDMs, are client-centered approaches to HIV care and treatment. DSDMs comprise two community-based models, that is community client-led art distribution and community drug distribution points. And there are three facility models, that is facility-based individual management, facility-based group management, and fast-track drug refill, FTDR. They are also classified by the level of follow-up and support as intensive or less intensive. The less intensive models are shown in green and the more intensive models are shown in red. Trends in DSDM utilization among CLHIV were not known. We describe the trends in DSDM utilization among CLHIV in Uganda 2020 to 2022. We extracted data from the District Health Information System, DHIS2, for DSDM enrollments by CLHIV during January 2020 to December 2022 to calculate the proportion of CLHIV using each DSDM by quarter. We assessed trends of use in community versus facility models and less intensive versus intensive models for facility models using the chi-square test for trend at national and district level. Among all CLHIV that utilized facility-based, almost all CLHIV utilized facility-based models. There was an increase in the proportion of CLHIV using community-based models from 0% in the first quarter of 2020 to 4% in the last quarter of 2022, but they still represent a very small minority of CLHIV using DSDMs. Enrollments in community DSDMs were low because children were considered unstable and thus not eligible for these models. For CLHIV using facility-based models, there was a decreasing trend in the utilization of intense models and an increasing trend in the use of FTDR, which is a less intense model. The increase in FTDR enrollments shows that CLHIV clients were open to taking up other client-centered models apart from the intense facility models. In conclusion, FTDR enrollments increased from January 2020 to December 2022. The increasing trend in the utilization of FTDR shows that CLHIV are open to other client-centered models apart from the intense models which they were originally assigned to. A small proportion of CLHIV used community-based models because they were previously not eligible since they were considered unstable. We recommend studies to address low community DSDM utilization as it may improve enrollment and HIV care and treatment. Thank you. I acknowledge those institutions.
Donc,
Thanks very much, Rebecca, for this presentation. And I'd like to see if the other presenters have arrived in the room. Daystar, Philip, Saidou, Albert, Pascal, and Jean-Pierre. They are still absent. So we go to the short session of question. The participants, you have the floor to ask your questions. Be succinct. Participants, you have the floor to ask your questions.
pas de questions.
There are no questions?
No, these were excellent presentations. I know these are poster presentations, but to all of them, to all three presenters, any comments about the quality of the data you are getting and issues of quality assurance and also ethics? Number two, to Rebecca, I know you described what you did in terms of the method, but what study design is it? I know you know, but just to articulate that in your poster.
Encore des questions?
Do we have other questions?
Question?
Further questions?
Oui.
Yes.
Good morning. I'm very happy, to listen, this program, and I appreciate it. One question for the Uganda Institute. For example, how should the public health any stigma or, the community, how to engage with, what you can use in, to the people when there is the centers like that. You make the health promotions to that community, to come in, the health facility. How you can use it like that? Can you explain it, that point? You understand, I think. I mean, for example, there is the health centers. The people, they come in that health center, you come, that, how to that engagement?
Okay, merci aux trois
Thanks
présentateurs.
very much for the
Voilà,
three
ma question
presenters.
s'adresse à la
My
troisième
question
présentatrice.
goes to the last or the
Et
third
elle a
presenter.
comparé deux modèles
You compared
selon
two
les
models.
interprétations,
When
le
I
modèle de la
see the
communauté, le
interpretation,
modèle des centres de
community
santé, des formations
model
sanitaires.
and the
Et les résultats
usage
de
of
ces
health
études ont prouvé
centers.
que
And the results
le
of this
modèle de
study
la
show that
communauté a une
the
tendance
community model
régressive,
has a
progressive, c'est-à-dire que la tendance
progressive
augmente.
trend.
Est-ce qu'il y a eu des actions qui ont été entreprises à cet
Did you
effet
have
pour que la tendance au niveau de la communauté
actions
puisse avoir le même
so
niveau
that
que la tendance au
the
niveau des
other
centres de
model
santé? Merci.
behave like the other trend in the health centers?
On va donc procéder aux réponses.
We are going to get responses to the questions. So presenters, it's upon you now to respond to the questions as asked.
On va commencer avec
We are going to start with you, okay?
Thank you for the questions. With regards to the quality and ethics of the secondary data that we analyzed, we did have some concerns with regards to the quality in the regard that we use electronic health records, and there were delays in updating of the electronic health records by the healthcare workers. And with regards to the ethics, we did seek the ethical permission and approval from the Ministry of Health and Child Care Permanent Secretary and from the HIV and AIDS TB Directorate to undertake this study. Thank you.
Thank you. So in our study, we sought ethical approval from the district level, the provincial level, and at national level. And also in terms of data quality, we removed all records which had incomplete data, and we only left with records that had all the variables of interest that we needed. Thank you.
Thank you very much for the questions. One of the questions was about study design. This was a descriptive secondary data analysis. For the data quality issues, we were worried about correctness and completeness, but in Uganda we have DSD dashboard in addition to the DHIS2. So we compared the data in the DSD dashboard to that in the DHIS2, and they were matching. So we were pretty confident that it is of quality. For ethical issues, we obtained clearance from the CDC and also from the Ministry of Health, and also the data was de-identified, so we were, there's a low risk of people being known that for the people that we use being known. One of the other questions, I am not sure I understood, but about engagement at facility, whether I think facility models are not superior to community-based models. DSD models make it more convenient for clients, because one of the reasons why we saw clients defaulting was the long waiting times and also the healthcare workers being overworked. So the idea of DSD models was to bring these services closer to the people so that they don't have to go to the facility, and also helping with the transport costs. So I think that the community-based models are good models because they are bringing the services closer to the people such that, and also there were issues of confidentiality where they don't want to be seen going to the facility. So if you can bring them closer to the people, I think it helps with adherence and retention. Another question was that how could we make other models behave like the community-based models that had an increasing trend. So we saw a decrease in the trends of facility-based models, intense models. So in the intense models, the clients are usually non-suppressed and they require more follow-up, more close follow-up. So we are seeing a decrease in the facility-based models, probably implying that we are improving in viral load suppression, or the children, the caregivers of the children are being more open to these other models. And also, the Ministry of Health, Uganda is planning on expanding the eligibility for children for the community-based model so that it is not dependent on age, but rather on preference and other factors. So I think we are moving towards children and adolescents using the community-based models.
Donc,
I think that we have come to the end of the presentations of posters and questions thereof. And I thank the three presenters very much. And you can get back to your seats. And at this point in time, we are going to the second session of poster presentations if the other presenters have come into the room. Otherwise, thanks very much to everybody. So I invite Jean-Pierre, Albert, Philippe, and Seydou to get to the podium to prepare to do your presentations. I repeat. Elder Philippe Foumon, Saïdou, Jean-Pierre, and Albert. Are they present or absent? I repeat, Elder Philippe Foumon, Seydou, Jean-Pierre, Albert, and Destin. We have 5 presenters who need to come to the podium. Five. Looks like they are absent. I'm going to repeat once more. I'm inviting Destin, Philippe, Seydou to come over here. Seydou, Philippe, and Destin.
We are trying to get 3 more presenters. The other 2, we don't have their posters here. So we're looking for Nikatu Adamasu Dester, Helda Philippe Fumo, and Saidu Hessenberg Masare. If you are in the room, please come to the podium. Else we wrap it up.
Donc, ils sont absents.
They're absent, it would seem.
Je réitère. Desta.
I'm going to repeat their names. Desta, Helda Philippe Fumo, and Saido Heisenberg.
Et donc, on peut donc conclure
So we can conclude this session. We have reached the end of the presentations, the poster presentations. We find that these poster presentations are very relevant and they should be taken into account by our leaders so that they may contribute to the improvement of the state of health of our public. We should therefore clap for our presenters once again.
So we will reconvene at 9 o'clock, so you can switch rooms if you
Nous reviendrons
want
donc
to.
ici à 9 heures. Vous pouvez changer de salle si vous voulez. Les autres présentations démarreront à 9 heures précises. Merci.
Mesdames, Messieurs, bonjour.
Good morning, ladies and gentlemen.
Mesdames, Messieurs, bonjour.
Good morning, ladies and gentlemen.
La séance orale qui vient
The oral session that will follow after the first session will be it will be a simultaneous oral session on the theme preparation for emergencies, investigation, interventions on non-transmissible, non-communicable diseases. I'd wish to ensure that the participants and presenters for that session are all present.
Sorry for if there's any confusion. We're starting by 9 o'clock. You know, you can take this time to switch rooms if you care to. But from 9 o'clock, we are going to be back here for oral presentations. Thank you.
I kindly ask if the oral presenters in room 3 are here. I can call by name. Elizabeth. Elizabeth from Uganda. Are you here? You are here? Very good. Our second presenter, McLean. McLean from Uganda again. McLean, are you here? Maybe, am I mispronouncing? McLean, Ninsima? Ninsima, very good, very good. Then Mata Nidai, very good. Then Zakario, good. Aisha from from Nigeria. Excellent. So I think, ladies and gentlemen, we can start. Since all the presenters are here, the moderator is here, and we have also people who will document all the discussions with us. So, Dr. Rafael, Dr. Rafael, over to you. Thank you.
Great. Thank you very much. Mesdames, Messieurs, bonjour.
Good morning, ladies and gentlemen. I'm Dr. Rafael Bailao. I'm an epidemiologist. I come from the Central African Republic. I'm the program director of SUMWA. As I've already been presented, our session is going to last 1 hour and 5 minutes. And each speaker will have 10 minutes. It's at the end of the presentations that a discussion will be held. Since everything is in place, I would like now to call upon Elizabeth Muhumuza for her presentation on pesticide exposure and associated acute health effects among smallholder farmers in eastern Uganda in the year 2020.
Good morning. Bonjour, everyone. My name is Elizabeth Muhumuza from Makerere University School of Public Health, and I'm going to be presenting pesticide exposure and the associated acute health effects among smallholder farmers in Mbale District, Eastern Uganda. According to World Health Organization, about 2.2 million people, mainly in the low-income countries, are at an increased risk of exposure to pesticides. And here we see that the agricultural and public health workers face the greatest exposure, and this happens during dilution, mixing, and application. Farmers in Uganda mainly use the WHO Class 2 pesticides, and these contain active ingredients such as cypermethrin, permethrin, profenophos, among others. Studies have shown that farmers in the eastern highlands of Uganda have been chronically exposed to pesticides for over 10 years. However, their pesticide handling practices are still poor, as there is limited use of PPE, poor storage, and disposal practices. And some farmers use these pesticides to treat skin infections, such as tinea capitis among children. However, despite the poor pesticide handling practices, the magnitude of the pesticide exposure and the associated acute health effects and other health effects are not fully recognized in Mbale District. We therefore assessed the pesticide exposure levels, the acute health effects, and the factors associated with pesticide exposure among smallholder farmers in Mbale. Our study area was Mbale District, Eastern Uganda, and why did we choose to do our study in this area? It's because the primary economic activity is agriculture, and over 75% of the residents in Bale participate in crop growing. The study design, it was a cross-sectional study, and we employed only the quantitative data collection techniques. Our study population was smallholder farmers, and we included those who were 18 years and above, and also the emancipated minors. And these should have been residents of Bale for over a month. We estimated our sample size using the Kish-Leslie formula, and we came up with 576 smallholder farmers. We used the multi-stage sampling to get our sample size, and the dependent variables were the primary was the pesticide exposure, and the secondary was the acute health effects. The independent variables were the socio-demographic characteristics and the pesticide handling practices. So to do our data analysis, we entered the data into Excel, and then we imported into Starter version 14, where we did the univariable analysis and got the descriptive data, the proportions and percentages, and also we to get the factors associated with pesticide exposure, and it was based on the questionnaire-based deterministic algorithm by Freeman et al. So we got the PPE scores, the exposure intensity scores, and the cumulative exposure score for the last 1 month prior to the study, where the cumulative exposure in the past 1 month prior to the study, we got it as a product of the exposure intensity and the duration of spraying during the last 1 month, which we took in hours. So, and in order to categorize our outcome variable as high exposure or low exposure to pesticides, we based on the DAMO exposure ranking method. And in this method, a score of 22.5 is considered as having low exposure to pesticides. And this is what we adopted. And so those who had above the 22.5 score were considered as highly exposed. Ethical considerations, we got ethical approval from the Makerere University School of Public Health Higher Degrees Research and Ethics Committee. We got permission from the Mbale District Health Office, and also informed consent from the study participant, and we ensured confidentiality of the data. And the results, so in order to determine the pesticide exposure levels among smallholder farmers, we first got the proportion of smallholder farmers that applied pesticides. And as shown in the pie chart, it shows that 71% of the smallholder farmers applied the pesticides. And among these, only 43% of these smallholder farmers experienced high pesticide exposure. For the socio-demographic characteristics associated with pesticide exposure, only sex was significant, statistically significant, and as we can see from the adjusted prevalence ratios, the proportion of smallholder farmers that were highly exposed to pesticides was 55% lower among females compared to the males. The pesticide handling practices associated with pesticide exposure, here two factors were statistically significant, and the use of a cocktail of pesticides and wearing rubber boots. So as we can see from the adjusted prevalence ratios, the proportion of smallholder farmers that were highly exposed to pesticides was 47% higher among those who used cocktails of pesticides compared to those that did not. And the proportion of smallholder farmers that were highly exposed to pesticides were 51% lower among those who wore rubber boots compared to those who did not. The acute health effects due to pesticide exposure, majority, 81.2%, experienced at least one acute health effect. And as we can see in the bar graph, the skin irritations were more prevalent, and also headache, nausea, and dizziness were common. We had a few study limitations. We had recall bias since this was, we were asking your exposure, the farmer's exposure to pesticide in the previous month prior to the study, and then response bias, and also the study was purely quantitative, so we missed out on the qualitative arm. In conclusion, the use of personal protective equipment, such as rubber boots, is not a sole method to prevent pesticide exposure. However, it can limit the exposure to pesticides. And the use of cocktails of pesticides, as we can see in our study, farmers were using cocktails of pesticides. It is prohibited unless it's advised by the manufacturer or it is inherent in the formulation of the pesticide. The acute health effects experienced could be attributed to the poor pesticide handling practices, the active ingredients in the pesticide used. So here we see that majority of our farmers, no, more than half of the farmers were exposed to low levels of pesticides. However, the chronic exposure, even to the low levels of pesticides, may lead to adverse health effects such as cancers, birth defects. Some studies have shown impotence to be associated with the chronic exposures to pesticide, and therefore we recommended the Mbale District Health Office and Agriculture Offices to conduct regular sensitizations and trainings on proper pesticide handling practices and safety measures, and this they have taken it up. They are even having more regular radio talk shows on agriculture, on the use of agricultural chemicals, and to the Ministry of Health and Ministry of Agriculture and Animal Industry and Fisheries to conduct trainings on integrated pest management. And here we can, if this is taken up, there is less use of the synthetic chemicals to control the pests, and we shall be using more of the biological methods and the cultural methods, which are more friendly to the ecosystem and have less adverse effects on human health. And also to the farmers, to pool resources through farmers' cooperatives in order to purchase the necessary PPE at subsidized prices so that we can reduce the levels of pesticide exposure, since in this day and era, the use of pesticides may be inevitable. These are the references. I acknowledge the following. Thank you for listening.
Merci.
Thank you, Elizabeth. The second presentation is on spatio-temporal trends of air quality between 2020 and 2022 in Uganda. The presentation will be made by Maclean Ninsima.
All protocol observed. Good morning, ladies and gentlemen.
Bonjour, mesdames et messieurs. En perspective, je m'appelle Ninsima.
Uganda from 2020 to 2022. Air pollution is one of the outstanding health concerns, the silent killer accounting for an estimated 6.7 million deaths annually. Sources of air pollution have been categorized under domestic energy use, exhaust emissions from vehicles and industries, and the burning of solid waste. Fine particulate matter, abbreviated as PM2.5, is among the health-damaging air pollutants that pose adverse effects to humans due to their small diameter and size, which easily permit penetration into invasive systems. PM2.5 has been recommended as the best measure of air quality due to its prevalence in the environment and broad range of health effects. According to the 2021 World Health Organization Air Quality Guidelines, the 24-hour average targeted safe level of PM 2.5 is less than or equal to 15 micrograms per cubic meters, whereas the annual targeted safe level is less than or equal to 5 micrograms per cubic meters. Based on the 2019 Global Burden of Disease report, long-term exposure to unsafe levels of PM 2.5 increases the risk of excess mortality from aggravated asthma, chronic obstructive pulmonary disease, lung cancer, stroke, diabetes mellitus, and the incidence of maternal and fetal complications, among others. Cities are more prone to poor air quality compared to non-urban areas. This is attributed to high population density, exhaust emissions from vehicles and industries, infrastructure construction, open fuel, and solid waste burning. Based on the 2021 World Air Quality Report, Kampala was ranked among the cities with polluted air 5 to 7 times higher than the WHO annual targeted safe level. Furthermore, ground assessments revealed that poor air quality was observed in Kampala compared to Nairobi and Addis Ababa. Based on this picture, we observe the hazy and clear sky showing the alarming state of air quality in Kampala City. It's upon this background that we assess the spatiotemporal trends of PM 2.5 in Kampala City, Uganda, from January 2020 to June 2022. This is one of the 25 Clarity Node solar-powered monitors for outdoor air quality monitoring in all the divisions of Kampala City. The monitors measure PM 2.5 concentrations per hour throughout all the days of the year. An example of the data generated by the Clarity Node solar-powered monitors is showcased in the projected snapshots. These snapshots show the real-time air quality status in Kampala City at different times of the day. The dots symbolize the air quality index value, which tells you how healthy the air you are breathing is and whether you should be concerned about your health. Red dots symbolize unhealthy air quality with adverse health effects. Orange dots symbolize unhealthy air quality for sensitive populations who are at higher risk of experiencing health effects compared to the general public. The yellow dots indicate moderate air quality with less health concern, and the green dots symbolize good air quality posing little or no health risk. This snapshot on the left shows the air quality status read from the Kampala Capital City Authority website at 10 a.m. on the 27th of June 2022. You can see that most of the dots are red, indicating unhealthy air quality conditions. The snapshot on the right shows the air quality status at 5 p.m. on the same day. You notice there are still some red dots, but generally with orange, yellow, and green dots indicating better air quality on the same day. Based on the data generated from January 2020 to June 2022, this graph shows the average PM 2.5 concentration by hour of the day. Plotted on the y-axis is the average PM 2.5 concentration, and on the x-axis are hours of the day stretching from midnight to 11 p.m. 2 PM 2.5 concentration peaks were observed throughout the day. The first peak was observed between 10 a.m. and midday, whereas the second peak was observed between 8 p.m. and 9 p.m. These peaks were observed after traffic rush hours. Based on the graph, you observe increasing PM 2.5 concentrations during the traffic rush hours, indicating that traffic emissions could be speculated among the biggest contributors of air pollution. The maps show the graduated 24-hour average PM 2.5 concentration across the biannual period stratified by the divisions of Kampala City, that is Kawempe, Rubaga, Central, Makinde, and Nakawa. The darker the shade, the higher the PM 2.5 concentration levels. On scanning through the different maps across the biannual periods, we observe a general decreasing trend in the PM 2.5 concentration. Despite the observed decreasing trend, High PM2.5 concentrations were observed in Kawempe and Central compared to the other divisions. This could be attributed to the fact that these divisions have very many informal settlements, food businesses which use biomass fuel for cooking, and small-scale industries which may not be complying to the emission inventory regulatory guidelines. Overall, the 24-hour average PM2.5 concentration was 59 micrograms per cubic meters in Kampala City from January 2020 to June 2022, exceeding the World Health Organization targeted safe level. This graph shows the 24-hour average PM2.5 concentration per day from January 2020 to June 2022. Plotted on the y-axis is the 24-hour average PM2.5 concentration, and on the x-axis are the biannual periods stretching from January 2020 to June 2022. The red line represents the 24-hour average PM2.5 concentration, whereas the blue line indicates the PM2.5 targeted safe level of 15 micrograms per cubic meters as per the World Health Organization air quality guidelines. As per the graph, there are cyclical variations of PM2.5 concentration alternating between 18 and 182 micrograms per cubic meters. Based on the correlation coefficient and p-value, there is a small but significant decreasing trend indicating a slight improvement in air quality from January 2020 to June 2022. Despite this improvement, we observe the 24-hour average PM2.5 concentration exceeding the WHO targeted safe level throughout all the days of the period. Based on our results, there was unhealthy air quality evidenced by PM2.5 concentration exceeding the WHO targeted safe level, even during times of less traffic and economic activities in Kampala City. Furthermore, there was a slight improvement in air quality evidenced by the decreasing PM2.5 concentration trend from January 2020 to June 2022. However, the reasons for the observed decreasing trend are unknown. It is possible that there could have been behavior changes and less traffic on the roads that led to improved air quality over time, which may or may not be related to the COVID-19 pandemic period. As an evidence-based institution, Kampala Capital City Authority has utilized the available data to develop the Kampala Capital City Clean Air Action Plan. This plan specifies several interventions spanning from individual responsibility to the roles of different stakeholders to improve air quality in the city. Initiatives to improve air quality cannot be confined to only Kampala Capital City Authority, hence the need for multi-sectoral collaboration to achieve the mandate of the Kampala Capital City Clean Air Action Plan. It is also important to conduct studies to understand the major contributing factors to poor air quality in this city. Thank you. I acknowledge the following institutions.
Merci. La troisième présentation portera sur les facteurs associés à la vaccination contre le papillomavirus chez les filles de 9 à 13 ans scolarisées au Sénégal. Elle sera faite par Matar Ndiaye.
Bonjour tout le monde, c'est Dr Matar Ndiaye. Je viens du Sénégal.
Ndiaye from Senegal. I'm an intermediary graduate of FTP, and I have the honor to present the study that we did in one of the health centers in Senegal to understand the factor associated to the vaccination which contributed to the papillomavirus among girls from 13 to 15. These are our plans. As introduction, we are going to say that This is an infection which transmitted sexually and is the cause of most cancer. According to WHO, 500,000 of women are affected by uterus cancer, and 90% of deaths are within the developing country. So in Senegal, we had 1,500 cases every year. The WHO recommended that we do the vaccination against the virus. And Senegal, from 2018, now we are among us the first country who have launched the vaccination. However, despite all these efforts in our country, we can say that the factors which are associated are very still unknown. That's why we want to do the study so that we can identify within the school children, girls. And our overall objective is that we want to study the factors which are associated from November 2022, and we would like to study the demographic factor and the environmental factor so that we can understand how to do the vaccination cover. So it was done, the study was done in Eurofula, south of Senegal, with more than 4,000 kilometers square cube, and we have about 29 schools in district. So we did a overall study during 5th to 30th November 2022, and we also talk with the student and their teacher. So we use the Schwartz formula so that we can assess the sampling, which is supposed to be at 228 for the teacher. It was exhaustive choice for the mothers, and those people are keeping the children. So we had an exhaustive inquiry. So data collection, we did have consultation with a vaccination card. So we came up with two questionnaires, one to the parent and the other questionnaire was to the teachers. And the data which was collected had helped us to characterize on demography and age and sex, and also linked to the uterus cancer, which is the vaccination and other vaccination. So we have stated that the confidence level was at 82%, and so this is help us to come up with this result. On 2028 mother, we have been surveyed, and they were less than 36 years, and 27 teacher, and 24 of them were men. So the girls were estimated at 64.9. So we noted that most of the mothers who are surveyed were married. So when it comes to environmental characteristics, 62% of women say they knew about uterus cancer, but most of them, they didn't know what are the factor which caused the uterus cancer. So to the teachers, most of them, they didn't know about the risk factors on the uterus cancer, yet they knew at least the prevention through the vaccination, HPV. So for treatment within the health center, most of the women say that they are happy of the support they receive, the care they receive during the vaccination, and also this was contrary because most of the teachers say that they are not happy with the vaccination campaign within the school, and they say they didn't have enough information neither. So they studied that we did show that women who know about uterus cancer had 2.5 chances of vaccinating their children compared to those who didn't have any information. And the women who had who had knowledge were able to have their children vaccinated compared to those who didn't have enough knowledge. Equally, the women who visited a health center, they were more likely to have their children vaccinated compared to those who say that the time was too long in the of taking care was too long in the healthcare. So I will say that the factor is linked to the knowledge of about uterus cancer. So this study was being done by Bulajai and back in 2021, and then the quality of care was taken into account in our study, and the result was the same with the study which was made by Simon in 2014, which means that the vaccination factor was subjected to the knowledge that the parent have. So most of the person who are happy with the vaccination and the implications. So the result that we got from our study is almost similar for what you and Lee had done in 2013 in China. And we can see that the institutional capacity can discourage a teacher in order to prepare a vaccination campaign within our school. So our result is that we should also include the informal education institution to have more coverage. So recommendation, we say that we need to come up with communication activities so that we can consolidate sensitization, mobilization of parents, and also guide a teacher on this vaccination, and then have a good collaboration with the head of school before we can launch a vaccination campaign. So in conclusion, we can say that uterus cancer is a real issue in our country, but vaccination will help us to fight it. So the low coverage is maybe due to the fact that parents and teachers don't have enough information. So we want to consolidate the capacity of parents and teachers so that we can improve the coverage of vaccinations. Also, we need to improve care and implicate more schools so that they can accept these vaccination programs. So we are going to conclude with this picture on this side. Thank you for all the people who have participated in this study. The fourth presentation will be done by Zakario Umar.
Ladies and gentlemen, I am from Nigerian Field Epidemiology and Laboratory Training Program. I'll be presenting to you the result of our study on the topic, the determination of dioxin levels in cattle hide process for human consumption using different fuel sources in Sokoto State, Nigeria. In Nigeria, about 90% of cattle hide produced in our abattoirs are processed for human consumption. These hides are usually subjected to flames to burn off the hairs from the skin. In this process, a lot of unhygienic substances are used to sustain the flames. The combustion of these unhygienic substances emit chemicals such as dioxins. Dioxins are referred to as highly toxic organic substances that are well-known environmental pollutants and carcinogens. More than 90% of human exposure to dioxins is through the food supply, mainly meat, dairy products, and fish. Dioxins are considered as human carcinogen at certain exposure level and a potential cause of non-cancer-related health events. In Nigeria, there is an overall increase in cancer-related morbidities, and the exact reason for the increase in cancers are not thoroughly investigated. We set out the following objectives: to determine the baseline concentration of dioxins in hide of slaughter cattle in Sokoto Central Abattoir, and also to determine the effect of smoking of cattle hide using tires, plastics, and firewood on the level of dioxins. The study was conducted in Sokoto State, which is located in the northwestern part of Nigeria, Specifically, we conducted a study in Sokoto Central Abattoir. We conducted a quasi-experimental study design, and our study population was cattle slaughtered and processed in the abattoir. We calculated a sample size of 160, and we collected our samples using systematic random sampling, in which the first sample was taken at random, while the remaining was taken at an interval of 12. A 5 by 5 centimeter length of height sample was collected, which were divided into two, the control and the test. The control was processed by scraping using knife and subjecting into hot water, while for the test, we subjected them to smoking using either plastics, firewood, and tires to remove the hairs on the skin. The height sample after smoking were then taken to the lab, where they are thoroughly washed and then grinded using an electric blender, and then centrifuge at 3,000 revolutions per minute. The supernatant were then collected, which was analyzed using the dioxin ELISA test kit, which uses the principle of antigen-antibody reaction to detect dioxins. Our findings were the main concentration of dioxins in the tire group before slaughter, before subjecting to smoking was 0.679, and after subjecting to smoking was 26.3. For plastics, the mean concentration before subjecting to smoking was 0.26, and after smoking was seen to be 2.3. And for the firewood, the mean concentration was 0.50, and after subjecting to smoking, it was 8.8 respectively. We conducted a PET test to see if there is a statistically significant difference in the mean concentration of dioxin before and after processing. We discovered that only those height samples that were processed using tires were seen to be statistically significant at a p-value less than 0.05. We also conducted a one-way ANOVA to see if there is statistical significance in the mean concentration of dioxins among the three groups. We discovered that it is statistically significant also with a p-value less than 0.05. With ANOVA, we cannot really ascertain which of the group really differs from the other in terms of the mean concentration. We decided we then went further to conduct a post-hoc test to see which of the group have really statistical significance in the mean concentration. We found out that those height samples that were processed using tires and plastic keep on becoming statistically significant at a p-value less than 0.05. In 2007, WHO and FAO developed a standard for dioxins developed a standard toxic equivalent quantities to be within the range of 0.001 to 1.0 part per trillion. And the baseline concentration we got in this study was seen to be within the normal range set up by WHO. The concentration of dioxin that was found in this study was seen to be extremely higher than the set-up standard by WHO and FAO, and it agrees with the findings of Oko et al., who conducted a similar research in northern Nigeria, specifically northeast, and the concentration of dioxins in height process using plastics and nylon were seen to be slightly higher than the set-up standard by WHO, and it agrees with the findings of Anyanwu et al., who conducted a similar research in 2003 in the southern part of the country, even though their research was slightly different from ours, in the sense that they concentrated more on the polyaromatic hydrocarbons than the dioxins and furans. The concentration of dioxins in bovine head process using firewood was also found to be higher than the set-up standard by WHO, and it agrees with the findings of Hang Zhanggu in China, who conducted a similar research in 2017. We concluded that cattle hide process using tires have higher dioxin content compared to other methods and is potentially toxic to human, animal, and the environment. We recommended that public health practitioners and relevant stakeholders should work in synergy to discourage the use of the habit of processing cowhide using trash of tires and polythene bags. We acknowledge the contribution of the following organizations. These are my references. Thank you for listening.
La dernière présentation porte sur le renforcement.
The last presentation is the capacity building on the evaluation of curriculum, which should be harmonized in the ECOWAS region. The presentation will be done by Aisha Okola.
Good morning, everyone. I'm Aishat Usman from ECOWAS Regional Centers for Surveillance and Disease Control, West African Health Organization. The title of my presentation is Strengthening Capacity at Points of Entry and Evaluation of the Harmonized Curriculum for the ECOWAS region. I'll be using the following outline. The point of entry staff plays a crucial role in provision of emergency response during public health threats and also management of each travelers at the point of entry. Several studies have been conducted in the ECOWAS region to highlight some of the gaps that we have at point of entry. Also, the WHO Joint External Evaluation conducted revealed multiple gaps at our point of entries in the ECOWAS region in terms of the indicators for points of entry. Some of these gaps have been documented as shown in the previous slides, and most of the recurring ones there are no formal legal framework for point of entry in terms of having a strategic plan for point of entry, bilateral agreements between countries, also insufficient capacity building, inadequate infrastructure, inadequate funding, and having most of our points of entry understaffed. In line with the vision of West African Health Organization strengthening the capacity of member states to respond to public health emergencies, WAHO, in collaboration with US CDC, Africa CDC, and West Africa Economic Monetary Union in 2021 developed an harmonized curriculum for points of entry staff in the ECOWAS region. This curriculum has 6 modules. Module 1 looks at the IHR core capacity for points of entry. Module 2 looks at the means of surveillance at our point of entry, be it airport, seaport, or the ground crossing. Module 3 looks at the consideration for different types of point of entry in terms of regulation, looking at International Civil Aviation Authority and also International Maritime Organization and guidance from WHO on ground crossing. Module 4 talks about what are the standard operating procedures that we're supposed to have at points of entry. Then Module 5 looks at planning for emergencies, response, especially when you have a sustained emergencies going on. And Module 6 looks at non-health workers training, because we know that at our points of entry, it's not only healthcare workers. We have other staff that are working at points of entries that are not healthcare workers, and they can also help in the identification or notification of ill travelers. So this curriculum was tested as regional training of trainers. First was in 2021 at Naomi, and the second regional TOT was in Lome in 2023. So the objectives of our evaluation of this curriculum is to assess the status of this cascade in member states, and also want to know how informative is this curriculum is to the POE staff in our region. To achieve our objectives, we developed an assessment checklist, and this was sent electronically to all people that have been trained to obtain information and also to know how relevant this curriculum is to our POE staff in the region and how informative it is. This map shows the number of countries in the ECOWAS region that have cascaded this curriculum nationally. In total, we have 7 countries out of the 15 countries that we have in the ECOWAS region. We have Burkina Faso, Niger, Gambia, Guinea-Bissau, Togo, and Cote d'Ivoire. In terms of number of people trained, in total, we have trained 330 points of entry staff in the region. Out of these, 300 are health staff, while only 30 were non-health staff like customs, immigration, the border police. In terms of socio-demographics, we have 78.8% constituted number trained, with slightly half of them having 5 years experience at the point of entry, and 1/3 of them are community healthcare workers, followed by nurses and doctors. Looking at the most relevant modules to the participants, the modules on means of surveillance at point of entry was found to be most relevant. This module looks at how to screen participants as they pass through our point of entries in terms of taking temperature, what are the appropriate personal protective equipment to put on, how do you conduct risk assessment, whether primary assessment or secondary assessment, whether a passenger will need to move on, continue with the travel, or may need to be isolated. Also, in terms of how informative the module is, most of the participants find all the modules very informative, but specifically Module 2 and Module 3. Module 2, which talks about the means of surveillance, and Module 3, which look at specific consideration for different types of points of entry that we have. For member states that have not cascaded the curriculum, we seek to know why, and majority of the response falls between lack of funding to conduct the training. We also requested for what are the support that will be required, majorly funding, followed by funding and technical support. So in our conclusion, we'd like to say that the harmonized curriculum contributes to strengthening the skills required by point of entry staff to detect public health emergencies and response at our points of entry in the ECOWAS region. And we would like to recommend continuous cascading of this curriculum, training of more non-health staff, non-health POE staff. Also, the leadership of our member states that have not cascaded should make available funds for the national cascade of the curriculum. And WOW as an organization should continue to provide coordination and technical support to member states on point of entry activities in the region. I would like to acknowledge the following organizations. I thank you all for your attention.
Nous sommes à la fin de nos présentations. Ça va être la séance de...
We have ended with our presentation. We're now going to go to question and answer session. So those of you who have a question, comment, this is the time to do so.
Allô? Voilà.
Good morning, everyone. I would like to congratulate the different presenters. My questions is to the presentation for the Ugandan presentation. Are you interested during the peak of pollution, especially in the clinic aspects, in terms of increasing of pulmonary diseases? Maybe I didn't really understand very well, but I would like to congratulate you for the subject that is very important. Thank you very much. Thank you very much. I would like to congratulate all the presenters for the good quality of the presentations. I'm going to start with the presentation on pollution. I would like to know what is the precision and sensibility of the tools that you use to measure. And for the presentation on pesticide, I find it very interesting. In terms of recommendations, I would like to know, we know that farmers are mostly getting their produces or their products from the black market. So what do you recommend? Because at that level, that's where we have the biggest challenge. What do you plan in the future? Do you want to do some investigation, especially for the pesticides that are obtained in the black market? I would like also to know, are you planning to come up with a study for the presentation as far as the usage of pesticide is concerned? For example, if there are farmers that are using a particular kind of pesticide, do they know that these pesticides really works? So we need to know more about that, and it can really help the country to move forward. And for Mata, for the work on the mapping, I would like to know, do we have some constraint? For example, I've seen that many people didn't want to get vaccinated. Is it the same situation for you, and what are you proposing to tackle that issue? For the work on the toxin of the livestock, have you worked on the sampling of these cows and what are the various substances that are not good for these animals? That's what I would like to know. Thank you very much.
My name is Dr. Shibajita. My first question goes to McLean. Thank you for that excellent study. However, I noted that there was a great, how do you explain the drastic improvement in the air quality for Makindye division in January, the last period, Jan to June 2022, compared to all the other divisions? For some reason, it moved from red to white. And given the worrying air quality that you've just shown us, what recommendations do you make to the public? Because I think that's where the action needs to start, so that at an individual level, people know what to do. Then I also have a question for you, Dr. Aisha. Thank you for that excellent presentation. You highlighted that one of the barriers to cascading to the training was lack of funding. So I'm wondering whether you've costed the cascading so that countries know what amount of figure they need to be looking for in order to do this. Thank you very much.
Okay, good morning. My question goes to Dr. Aisha for the point of entry curriculum in West Africa region. My concern is about the only 7 countries are implementing this curriculum on the 15th of the ECOWAS region. And I don't know exactly what is the process for the country to implement this curriculum. And also, according to the geopolitics of the area, presently, we know there is many instability in the region according to the politics. I don't know what is the effort as WAO is effort in the area to push the countries to implement this important activity for surveillance. Thank you.
Okay, merci.
Thank you. I would like to thank all the presenters. My concern is to the presenter of Senegal on the associated factors. I do believe that you preferred the high ratio instead of using the prevalence report because you are doing a cross-cutting and analytic study. So I would like you to explain to us why did you use a high ratio instead of the other one. Thank you. So, well, now we are going to move to the answers, to the responses.
Thank you very much for those questions. A question that was directed to me was about the farmers getting most of the pesticides from the black market. That's very true. However, in Uganda, we have some regulations, such as the Agriculture Chemicals Control Act. However, the implementation of these regulations that are in place is still poor, and therefore we further recommended, still that was one of our recommendations, that the government should make sure that these regulations, the laws that are in place, are really implemented so that we can regulate the registration, the sale of these pesticides, and this would reduce the pesticides on the black market. And when it comes to the more studies on particular types of pesticides, yes, we look forward to going in and carrying out more studies on a particular class of chemicals, so that, and also further sensitizations of the farmers on these particular different types of chemicals that they use, and also look forward to doing more passive sampling technique studies, such as the use of silicone wristbands in order to measure the pesticide exposure, the residues of pesticides that farmers are exposed to over a period of time, and that would give us more, it would give us a more meaningful measure of the exposure. Thank you.
Thank you all for the questions. I think the question that was directed to me is on, did I sample cows? Yes, I conducted my sampling on the cows. In our study site, we have a place called Plenary where all the cows that are intended for slaughter are kept. So, and are taken one by one into the slaughter home. So we conducted a systematic random sampling. So the first sample we took was at random. So we calculated an interval of 12. All the remaining samples were taken at the 12th interval. And we took about 260 samples. I hope I've answered the question again.
Thank you very much for those who are interested to our presentation. We have two questions. The first question was from Evariste that was asking if COVID that interfere from our work, especially because of this weaker cover. Yes, it was actually shown by our study, but the most important point that our study shows, it was an issue of communications with the population, because I can tell you that the study showed that the mothers and the people keeping the children had no knowledge about colon cancer and other diseases, and the issue was really communication. That's why we needed to strengthen the awareness campaigns and the communication so that they can have more information about this point. The second person asked me a question about the report, the high ratio report. Here we use the high ratio so that it can really help us to understand the signification and the importance of this study, and it gave us a good result. Thank you very much.
Thank you very much for the questions. The first was about the accuracy and sensitivity of the monitors. So in Uganda, we have 3 BAM stations so far, and those are reference stations. We have one at the US Embassy, the other at Makerere University School of Public Health. Then we also have one at Makerere University owned by AERCO. So the monitors are utilized for this very study, the Clarity Node solar-powered monitors, were collocated or calibrated against the US Embassy reference station to make sure that they get or the data generated is accurate based on the location of the different monitors. The second was about Makinde compared to the other divisions. For those of us who know Kampala, Makinde is bordering the Lake Victoria, so we think that could be explaining why it has lower PM2.5 concentrations, but also that might not be definitive because we noticed that across the different maps, there was a decrease in the general trend for PM2.5 in these different divisions, across all the divisions. And we think because this period had our COVID-19 in between, we had lockdowns, specifically the first lockdown, which was very effective with so many measures, and also the second lockdown, we had less traffic on our roads, very few people getting to the central business district. But also, despite the different lockdown periods, we did not at any point achieve the WHO safe level across the different periods or across the different days of the year. The last was about the public health actions. So based on the available data which has been generated over time, the Capital City Authority has taken an initiative to develop the Kampala Capital City Clean Air Action Plan. This plan has several interventions. Some of them should be instituted by the individuals, but also you notice that improving air quality cannot be a one-man's or a one-sector responsibility. We have so many institutions, and in the plan we have specified what institutions should do, from the different ministries and development agencies to academia. Thank you very much.
Thank you. I think I have 2 questions. One on the budgets for the curriculum, and the second one bordering around security challenges that we're experiencing in the ECOWAS region. So for the budget to cascade this training is very minimal. There's no actual figure, but you can actually cascade this training with less than $10,000 because the number of participants is dependent on each country. It depends on the number of people you want to train. But basically what you need is just a space for training, the food during the training. And what we have done as WAHO, as region, is for us to have trainers across all the 15 member states, so that if you want to cascade this training, you don't need to look for an external facilitator. Yes, we support as WAHO to go if a country is cascading, we support to give, but basically we have people. I'm sure that in each country, we do not have less than 3 people that we have trained who are supposed to help in facilitating the national training. Then on the issue of security, yes, we have some challenges in some countries, and ECOWAS Commission has a security department that are looking at how some of these things can be resolved. And also, one of the things that we have done is to host this curriculum on the WAO website at www.waoas.org for an individual, anybody that is interested to access the content of this curriculum and go through it, even though I know that we have some practical sessions, but this can be done on a small scale. Even if it doesn't happen at the national level, we have regions, we have districts, and some of these people that we have trained are from the regions or district. We can have a smaller scale training. Thank you very much.
Ladies and gentlemen, we are at the end of our session, and I request you to applaud the presenters for these rich presentations.
Up to the stage. We have two panelists who are here in person and then two who are joining us online. So Dr. Ibere and Mr. Sekpeb, if you could come up to the stage, we'll go ahead and get started very shortly. Thank you.
Thank you very much, and good morning, everybody. Can we show me where my... Aha. So is it set on slideshow? So... Fantastic. Okay. I shall assume you can see my slides, because I can't tell. No? Yes. Great. Thank you very much. So, first of all, it just occurred to me that the bio that you have is about 10 years out of date. I haven't been working for PHE for a while. PHE actually doesn't exist anymore. It was abolished in the middle of the COVID-19 pandemic. So I am, as The moderator said I'm the CEO of Africa Public Health Foundation, and until recently I was an advisor to the then director of Africa CDC and a health advisor at the Tony Blair Institute for Global Change. And as he mentioned, APHF was established to mobilize resources, develop partnerships to support Africa CDCs and the African public health priorities. So it's, thank you. It's a pleasure to be here. I have been involved with AFENET in various forms for a very long time, and I'm filled with excitement and optimism as I look around the room and putting in a plug for the next panel session, especially looking at the gender representation in the room. So thank you to the organizers for inviting me, and this will be short. I won't take very long. If this works. Aha. So I am really just going to go through very quickly a few comments on the topic, because I think that resource mobilization is a whole program of study on its own, and we're not going to do it justice in 10 to 15 minutes. It's a complex area that I would not claim to fully understand myself, and so I'd like to start with a few simple definitions, questions, just to ensure that we're on the same page as we move along. Then I'll skim through some of the headlines on how and where we mobilize resources for health security and explore the challenges. But because I know we're all filled with stories about the challenges of everything that we do in public health, I'd like to focus on the opportunities rather than challenges. So what is health security? So this definition is one that I like, although I recognize that it is a little narrow. Health security is the existence of strong and resilient health systems, public health systems that prevent, detect, and respond to infectious disease threats whenever they occur or wherever they occur in the world. Now, we do tend to include within health security environmental hazards as well, chemical incidents, and one would argue that there are also non-infectious epidemics and pandemics that are worthy of being considered as health security threats as well. But what I particularly wanted to do is, first of all, before I continue, is to apologize for the graphics, any graphics that or images I used during this talk that I haven't referenced the source. And that was because due to a communication failure, I actually only worked on these slides this morning. So this image that you can see, yes, you can see, I chose this image just to show the complexity of the actors, the architects, the systems and processes that contribute to health security. So when we talk about resource mobilization, we are referring to all these actors, these systems, these players, structures, peoples, policies, processes as the recipients of the resources that we mobilize, but also as sources of those resources that we use, and they in themselves are resources for health security. So, primarily, health security is a national responsibility. You all know about the international health regulations, and the responsibilities defined under IHR, even as they're updated today, are very squarely placed at national and state level. The ongoing conversations around a pandemic treaty or accord also focus on national responsibilities. Therefore, if we're talking about mobilizing resources for health security, we should really be looking at what happens at the national level. But there are many reasons why states alone cannot be responsible for health security, and why they also sometimes fail to deliver on this responsibility for health security. It might be because there's limited income, underinvestment in health, people or systems operating outside the control of the state, the national authorities, or general global limitations in capacity and capability. But in addition, we have a plethora of players and influencers and drivers at supranational level and non-state actors that play a role and sometimes actually take over the roles of government in health security. So this picture, again, borrowed off the internet, I like it because it just shows it's an example, and it's not even complete, the complexity of the systems and architecture that contribute to health security, and therefore the complexity in the sources of resources, the suppliers of resources, as well as the aspects of health security that will require those resources. So we recognize that health security requires transnational cooperation. I don't need to remind everybody. In fact, if I started the sentence that Dr. Tedros repeats every time, I'm sure you can all complete it. So we are not safe until everybody is safe. Right, so that means that in considering health security resources, we need to be looking beyond the nation state, looking at all how the interface between nation state and global system operates, and to do that, to make it simple, because I'm not a finance person, I'm just a bog standard public health physician, I've borrowed a framework from my brother, Dr. Alex Coutinho there, which sets aside these geographical boundaries, and I've called it the P's, just because everything starts from P. So, in mobilizing resources for health security, we need to consider the people, the experts, leaders, citizens, service providers, service users. The service users, in my view, should be central because they are the reason for which we do what we do. How do we effectively leverage people as resources for health security? And wrapped within resources, within people, of course, is first and foremost, it's community. We often overlook the value and importance of community as not just the recipients of the efforts that we maintain for health security, but also as part of the resources for health security. How are you leveraging intelligence from your communities? Who is informing your event-based surveillance systems? Do you only tell? Do you talk to? Or do you also listen? Partnerships. Now, this is part of the new public health order that the African Union has recently articulated, and I believe there was a session that was talking about that earlier this week, so I'm not going to go into detail about that. But partnerships should be mutually beneficial, respectful, and equitable, so that voices, all parts of the partnership are contributing to the solutions that we're trying to achieve. How are we mobilizing the partnerships for developing developing the systems that we want to have in place? When did you last build a partnership with your neighboring state? Too often, we look at partnerships as global north, global south. So everybody wants to have a partnership with the US, with the UK, somewhere in Europe. But we miss out on opportunities to actually develop partnerships with our next door neighbors. AFENET is actually a model of one of the things that works in looking at local partnerships. The networks of field epidemiology training programs where countries have supported each other and trained together is an example of the sort of partnerships that we should be seeing as critical to the resources we need for health security. Processes and policies. Too often, policies are imported, not based on evidence of local reality. So we need to do more to generate the evidence base to inform the policies that lead to the structures and systems that we have in our own continent. So we can't assume that what works in New York will necessarily apply in Mombasa. We need to generate local data to inform those policies. Prevention, preparedness, health security depends on understanding what is, what could be, and mitigating against that which we don't want to happen. So while I started by saying that health security is a nation-state responsibility, it does require cooperation between public and private sectors. And we'll talk a little bit about the role of private sector in a minute. So going back up a little bit to what governments do and how governments mobilize resources for health in its broader sense and health security more specifically. These are some of the examples, and I'm sure that you can all come up with a lot more. I think I've sent you the wrong slide, but this is some of the examples how domestic resources are mobilized for health security. So ideally, we would like to see budget allocation that is very specifically assigned to health priorities. And we all know about the Abuja Declaration, which proposed that 50% of annual budget should go towards health. Not only have very few African countries ever hit that target, but what gets defined as health priorities that has access to that percentage, whatever it is so varied and vague that you can't actually be certain how much of it generally goes to what we would consider public health priorities in the countries that we're talking about. There's general taxation. So in countries like the UK, the National Health Service is predominantly funded through general taxation. You can have hypothecated taxes where a proportion of the tax is dedicated to the health system. More recently, we're seeing much more innovative taxation, such as sin taxes, where taxes are placed on products and activities that the government wants to discourage, so like gambling, or more recently, for example, alcohol, sale of alcohol, sugar-enriched food and drinks. Windfall taxes. Nigeria, for example, has a petroleum fund, which is supposed to be used specifically for government priorities for nation building, etc. You can have industry-specific levies as well. And so there are various ways that governments can generate resources for health programs. But when we look at the non-governmental sector, there's a whole swathe of areas that we're significantly under-investigating for supporting health security agenda priorities. So we tend to talk about philanthropy and overseas assistance, of official development assistance as major providers. But we don't actually, there are whole sectors, particularly on the African continent, that we don't consider. How much are our private sector players who benefit from the economic growth that follows health security? How much are they contributing to developing the systems that are necessary to ensure that health security? How much are the public even aware of what you're doing for health security? How do we know, if I asked everybody in this room to name billionaires, we'll all know the North American and European ones, but we do have African billionaires. So how engaged, or how much are we engaging those high net worth individuals in conversations about contributing to the health security architecture which their businesses benefit from? So I think it's really important to show this image, because we always talk about the biggest funders for public health, generally health security in particular, being either official development assistance or philanthropic giving. But if you look at the amount of funding that actually comes into public health, into the broader health system, this data is actually a little out of date. Remittances from Africans living in the diaspora is a significant amount of investment. And private sector contribution is infinitesimally small compared to that. So we need to ask ourselves, how can we optimize the effectiveness of diaspora remittances? And then how can we expand the contribution of the private sector into investing into the health system? So, innovative financing mechanisms is kind of flavor of the month at the moment. We talk about them a lot. And again, so that we're all on the same page, I've put a definition there that I use. So innovative financing mechanisms, and they are mechanisms, are non-traditional applications of traditionally official development assistance, joint public-private mechanisms, and flows that either support fundraising by tapping new resources or deliver financial solutions to development programs on the ground. So that's what fundraising is about in general. Isn't that what financing for health is about in general? But some of the new approaches, such as I've shown on the examples on the slide there, results-based financing is becoming increasingly popular. World Bank does use that a lot. And that is where it's a payment for success, essentially. So you deliver, you succeed, then you get paid. Catalytic funding, again, not that new. That is actually what Gavi does and UNITAID does for assuring that they could provide accessible vaccines at affordable costs. So you actually prime the system by putting some funding in the hope that it becomes commercially viable over time. Public-private co-funding, using pooled funds, using revolving funds where the investment yields a dividend that you then use to reinvest for the next initiative. So these are just some of the examples and are nowhere near exhaustive. So I did say I wasn't going to talk about challenges, even though that was the title that was given, but I wanted to focus on the opportunities. And those of you who know me know that I talk about the pandemic dividend a lot, and that's when I'm feeling particularly optimistic. I think that there is a dividend in the understanding of what we do as public health professionals globally as a consequence of this particular pandemic. We have unprecedented access to data and evidence driven by the digital revolution. We should use this to ensure that we know what we need, what works, and how to use it. The fact that everybody is now an epidemiologist is a good thing. So I don't think epidemiologists in this room should feel threatened. The fact that you can now have a conversation with a politician and he knows what an R0 is a good thing. Use it. We now have a common language to talk to finance ministers, to politicians, to get them to understand what we mean when we require them to invest in our systems. Partnerships are particularly continental cooperation. Led by Africa CDC, we've seen an unprecedented level of continental collaboration. With the creation of the Africa Medicines Agency and implementation of the Continental Free Trade Area policies, opportunities will abound to make our resources go further. Again, we need to remember that the people for whom we are here and ensure that their voices are heard in articulating the priorities and implementing the solutions. So while we explore new funding sources, let us ensure that it is about additionality and effectiveness. We need to be doing more better. So what can you, as epidemiologists and health security practitioners, do? Evidence-based practice also applies to financing. Build strong investment cases. If I was your Minister of Health, if I was the finance director of a foundation, I need to know that you've thought about the value for money and the impact that you're expecting to have for the money you're asking me to invest. So just telling me that the mortality outcomes will the number of deaths will reduce, monetize it. We can and we should actually speak the language of the people who control the budgets. Measure impact and demonstrate value for money. Monitoring and evaluation is critical. And I want to make a particular appeal, as I am now sitting on the other side of the fence in a fundraising position, to please, please, please share impact stories. If we don't know how successful what we've invested in has been, and I don't mean just in bold numbers, when you have an impact story that shows an individual with a story, that has far more impact on the people who contribute to those foundations, who raise the money that will then go to your next program. So as you go out there implementing your programs, help us by taking a little bit of time to talk to the recipients of that intervention, get their voice on record, get a narrative, get a story, get a picture, because those things go a lot further in trying to demonstrate the evidence of what the money has done than just numbers on in an Excel spreadsheet. And I say this because I'm not really a fan of Excel spreadsheets. So when we have the evidence, build investment cases, measure impact, and share impact stories, then funders will know that what you're doing will make a difference and they'll be more inclined to invest more. And I'm going to stop there, and thank you again for the time. Thank you.
Thank you, Dr. Aberi, for that very enlightening presentation and for staying on time today. That was really good, and I want to echo her call for high-impact stories. I know we are also always looking for those stories, and I want to encourage you to also include in that ask, when we think about stories, the stories of the things that didn't happen. When you did something good out there and the disease didn't spread, the outbreak didn't move across borders. Sometimes we don't think about those. So I think that was an excellent way to end that presentation today. All right, so do we have our online panelists with us yet? Do you know if they're online? Okay, well, that's okay. We're gonna move now to our next presenter, who is with us up on the stage today. And then what we'll do is we'll take questions for the first two panelists. Both of their presentations have to do with resources and. Oh, excellent. Okay, great. We do have welcome. We'll introduce you following our next speaker. So. We're very happy next to have joining us Mr. Raphael Sekbeb. And Mr. Raphael has over 12 years' experience working with the National Health Insurance Authority in Ghana. He has played various roles as Director of Operations, Northern Belt, Director Research, Policy, Monitoring and Evaluation, and Director of HR and Administration. He holds an MBA from the University of Ghana Business School and a law degree from Mount Crest University College, and his first degree in social sciences from the Kwame University of Science and Technology. He has extensive executive education from the Harvard School of Public Health and Harvard Kennedy School of Government in Boston, the Gali International Management Institute in Israel, Ghana Institute of Management and Public Administration, and the University of California, Los Angeles. Mr. Raphael chaired the planning committee for the Maiden Regional Conference on Financing Universal Health Coverage and Health Security under the theme, Overcoming Financial Barriers and Providing Financial Risk Protection. So without further ado, I'll ask Mr. Raphael to join us to come and give his presentation, Attaining the Triple Billion, the Role of Healthcare Financing Towards Universal Health Coverage. And I believe you're going to just be presenting no slides today, which is great. I'm sure we've seen plenty of PowerPoint presentations this week, so please.
Thank you very much, and good morning to everyone. I bring you warm greetings from Ghana and from my Chief Executive of the National Health Insurance Authority, the Honorable Dr. Bernard Okoboy, who should have been here, but for schedule clashes is unable to do so. He extends his regards to everybody here. Let me say I feel greatly honored and thankful to AFENET for the invitation to us to make a presentation here on the attaining the triple billion, the role of healthcare financing towards universal health coverage. It is a fact that Africa's health challenges have become increasingly complex by the day. The continent is beset with a growing number of disease outbreaks, including the COVID-19 pandemic and the dual challenges of communicable and non-communicable diseases. On the backdrop of these challenges, coupled with the weak health systems, we cannot continue to do business as usual. And thus, reiterating the importance of the theme for this conference, which underscores how good health for all, including ensuring health security and universal health coverage, is central to the development of the continent. The COVID pandemic brought us all face to face with the consequences of dwindling investment in resilient health systems and the consequences of years gone by from policymakers and decision makers. A commitment, therefore, to UHC means a commitment to address these barriers. The colossal challenges caused by the COVID pandemic required sustainable health financing mechanisms in place to address these widening inequalities that have further been exacerbated by the COVID pandemic. On the subject matter of this keynote address, the triple billion targets for the WHO seeks to improve the health of billions by 2023, ensuring that 1 billion more people are benefiting from universal health coverage. Again, another 1 billion people are enjoying better health and well-being, and another billion being protected from health emergencies. As the foundation of the WHO 13th General Program of Work, the triple billion function both as a measurement and a policy strategy to align with SDG targets, to reduce country burden and data collection, to streamline efforts to accelerate progress towards achieving key targets. The attainment of the triple billion as a giant step towards UHC is impossible without sustainable healthcare financing mechanisms in place. That is why we at the National Health Insurance believe that the promotion of a predominantly public finance healthcare system, investment in primary healthcare, including health promotion and prevention, and thirdly, leveraging technology and innovation are key. In the first place, how countries pay for healthcare is a critical factor in advancing healthcare coverage. Health financing systems affect the availability of services, who is able to access them, and whether people can afford them. Is more than just the availability of funds for healthcare. It includes all of the mechanisms from resource mobilization, funds pooling, and health purchasing. A well-functioning health financing system ensures that people can access health services they need without suffering financial hardships and the resources that are used and equitably. That is why there is a growing consensus around the world that countries should publicly finance their health systems if they are to achieve universal health coverage. Thus, the road to UHC requires solidarity financing models that rely heavily on the country's capacity to increase public expenditure and reduce the proportion of out-of-pocket spending. Government, especially in Africa, should avoid fragmentation derived from creating separate pools and health coverage schemes for the rich and poor populations. The problem with fragmentation is that it fuels existing inequalities instead of addressing them. The rich are covered by formal mechanisms of social security, insurance agencies with more funding and better quality care. The poor, on the other hand, have to make do with underfunded schemes, receiving worse care, but for high costs. To achieve UHC, the continent's health systems need to transform from hospital-centered and illness-based to a person-centered and health-based systems. As a means of achieving UHC, there is the urgent need for countries in Africa to have an integrated, community-based, people-centered health service that guarantees and promotes equitable access to health services. By this, we ought to ensure that first level of care should become increasingly closer to where people live, especially in the communities and where they work. At the same time, services will have to move from the current dominant focus on treatment to encompass a range of promotive, preventive, creative, and regenerative interventions for well-being. Thirdly, leveraging technology and innovation. The post-COVID-19 future of Africa's health systems demands a paradigm shift with a focus on technology and innovation. Governments, policymakers, and health managers must therefore embrace technology and leverage the power to bridge the gaps in healthcare delivery, particularly in the underserved areas. To remain relevant in the global health space, Africa must keep pace with changing dynamics in the health industry and begin to take interest in and advantage of modern technologies, including artificial intelligence, telemedicine, electronic healthcare records management, and data-driven approaches that can transform the landscape of healthcare and empower both healthcare providers and patients alike. Therefore, investing in health, either directly by central government or through health insurance schemes, can catapult the continent to attain a UHC by 2030. While there may not be one-size-fits-all approach to financing UHC, all Africans stand to benefit from comparing experiences and identifying common threads of success. This is why, at the commencement of the 20th anniversary celebrations of the National Health Insurance Scheme of Ghana in just October last month, the NHIA and the WHO organized an African Regional Conference on Health Financing, utilizing Ghana's experience on the basis of regional learning to explore innovations in financing healthcare under the theme Overcoming Financial Barriers and Providing Financial Risk Protection. The conference provided a platform that supported sharing lessons, learned experience, disseminated good practices, and contributed to capacity and institutional development relative to health financing, and discussed Africa's health insurance systems and their role in advancing UHC and health security. One objective of the conference was how to finance the increasing number of infectious diseases outbreaks, global pandemics, and health security threats in general. Sadly, This remains an unresolved challenge in terms of making funding available and accessible for effective preparatory actions and for rapid and effective response everywhere within all countries. As is often said, we cannot afford to let perfect be the enemy of good. Rather than waiting for a foolproof UHC financing formula, government can and should begin working towards UHC, drawing from other countries' experiences. On this note, please permit me to share with you Ghana's experience on healthcare financing towards universal health coverage. At Ghana's independence in 1957, healthcare services were free and was financed through general tax and donor support. However, due to the economic slowdown of the 1980s, the government of the day introduced a user fee system, which was christened cash and carry. According to several empirical reports, the cash and carry system contributed to inequitable health service access and utilization between different socioeconomic groups and between poor rural and rich urban dwellers. In fact, it was estimated that out of the 18% of the population that required healthcare at any given time, only 20% of them were able to access that. That means 80% of people living in Ghana who needed healthcare could not afford to pay out of pocket at the point of service use. This resulted in delays in seeking healthcare, non-compliance with treatment protocols, and premature or avoidable deaths. To address the problem of the financial barrier to healthcare access, the government in 2001 began discussions towards the introduction of a social health insurance scheme as a humane approach to financing healthcare. By 2003, a passage of the National Health Insurance Law established a nationwide, semi-autonomous, and community-based mutual health insurance schemes as a mechanism for removing financial barriers to access healthcare. The vision of the government in instituting a social health insurance scheme in the country was to assure equitable and universal access for all residents to an acceptable basic package of essential health care that adequately covers every resident in the country. Financing for the NHIS was secured using three main sources of funding. One was the ad valorem tax of 2.5%. The second source was a 2.5% from workers' social security contributions. And the third was a graduated premium from informal sector that contributed about 5% of the total inflows into the National Health Insurance Fund. By the law, every district had a district-wide mutual health insurance scheme with membership open to all residents under the National Health Insurance Act. Provisions were made for exemption of the poor and indigent. This has since been expanded to cover maternal care and people above 70 years of age. Today, Ghana has made substantial progress in its quest to attain universal health coverage since the introduction of the health insurance scheme as a financing model exactly 20 years today. Thus, for the NHIS has 17.2 million active membership, representing 55% of the total population. And this year, as we celebrate our 20 years of existence, we intend to achieve 20 million people of Ghana being covered under the NHI. Going by our experiment at health financing since independence and the speed with which various funding mechanisms were implemented and discarded, the operation of the health insurance scheme for 20 years represents a significant progress in our quest to attain UAC. Over the years, an orientation towards primary health care for efficiency gains, strengthened governance, and coordination of multi-sectoral actors and investment have taken center stage in ensuring our populations have timely access to quality basic health services, irrespective of ability to pay at the point of use. As part of Ghana's UHC agenda, we have prioritized health investment and reorganized service delivery to improve quality of care at the lower levels of service delivery. This seeks to strengthen the organization and capacity of primary health care at the sub-district level through reorientation of the health financing functions as amplified in our revised strategy for financing service delivery as fundamental to a strong and resilient health systems. The NHIS operates a benefit package that extensively covers non-communicable diseases, including stroke, hypertension, and diabetes, which are common in most health facilities. The Ministry of Health has recently developed an essential service package and currently conducting an actuarial study for the inclusion of essential services to reflect the needs of the population in our National Health Insurance Scheme benefit package. In the area of cancer care, the NHIS has covered breast cancer and cervical cancer from inception in 2003, and in recent times added 4 childhood cancers. Coverage of these conditions provide the needed social and financial risk protection against the cost of healthcare for the citizenry, especially the less privileged in society. It is in the same light government has reacted quickly to direct the consideration of prostate cancer, mental health, and dialysis for inclusion in the benefit package due to the public outcry over the cost of treating these ailments. It is a mark of the public's confidence in this financing model that there are constant claims for the inclusion of one disease burden or the other that are outside the benefit package. In conclusion, Mr. Moderator, health financing is critical for the attainment of the triple billion and subsequently UHC. The key requirements of resource mobilization, pooling, and health purchasing make it an imperative for a predominant public financing mechanism to be deployed because the government is the only authority that has the capacity to mobilize and pool funds in the manner that is required for a healthcare intervention of this nature. I thank you.
Great, thank you for that presentation, and I think really brought home the importance of the linkages from financing, innovative financing mechanisms to ensure universal health care. And I think that links to primary health care. And I know it wasn't the main thrust of the presentation, but I think important in that is the message made at the beginning of the talk on that linkage to accessing care to health security. So there's many reasons that universal health coverage is so critical. As moderator, I'm going to take my prerogative to change my mind. I originally said we would take questions for the first 2 presenters now, but while we have our other panelists online, I want to take advantage of that and go ahead and move to our next presentation, who is coming to us online. So let me introduce the next presenter, please. Dr. Bernard Langat, who is a public health and M&E expert with extensive experience in program management, health and community system strengthening, and communicable disease control. Dr. Langat is currently serving as the acting head director of digital health policy and research in the Ministry of Health of Kenya. He has more than 20 years experience in program management, health and community system strengthening, TB, HIV, and malaria control programming. Also, he's a former program director, disease control, prevention, and management, and lead Coalition for Health Research and Development, AMREF Health Africa in Kenya. Dr. Langat is a former team leader for KPMG Managed Global Fund LFA program in Sudan and Eritrea, and Government Sanitation Fund, Country Program Monitoring Services in Ethiopia. Dr. Langat served in the health sector in different capacities: Senior Program Officer at Global Fund Program Unit of the National Treasury, Sectional Head in charge of Planning, Policy, and M&E Research at National TB Control Program. So with that wealth of experience, I would like to turn to Dr. Langat online for his presentation. Thank you. Apologies, let me give you the title of his presentation. Dr. Langat will be speaking about Universal Health Coverage Program in Kenya. Do we need technical support? Is he? Is Dr. Longat with us? Oh, he's not? Okay, apparently our panelist is online, but we're not hearing him. Dr. Longat, if you're there, if you could ensure that you're unmuted. Should we try our fourth presenter while we're sorting out the technical difficulties? Okay, let's just confirm our fourth panelist is Dr. Abdulaziz Mohammed. Dr. Mohammed, are you with us online? If you could confirm.
I'm online.
Okay, excellent. We hear you. So we'll go ahead.
Can you hear me?
Yes, we can hear you. Can you hear us?
Can you hear us? Can you hear us? Yes, I can hear you, but with an echo.
Oh, goodness. Okay. Can I get some IT help? I don't know why there might be an echo. Let's see. Do I need to use the microphone from his side?
And can you see my screen?
We'll do our best here. I'm going to go ahead and introduce Dr. Mohammed. Dr. Abdulaziz Mohammed is the head of Disease Control and Prevention at the Africa Centers for Disease Control and Prevention in Addis Ababa, Ethiopia. He holds an MBBS and Master of Public Health and Field Epidemiology. Dr. Mohammed is a Foundation Fellow of the Africa CDC Africa Union Fellowship for Leadership in Public Health in Africa and a Fellow of the West African College of Physicians. He is a graduate of the Nigerian Field Epidemiology Training Program and a Commonwealth Fellow. Before joining Africa CDC, he was Chief Consultant Psychiatrist in Nigeria and worked in integrating mental health into primary health care and psychosocial support for internally displaced persons in Kaduna, Nigeria. He has public health experience working in West and Central Africa, including being the coordinator for Africa CDC's first health system strengthening project. So, Dr. Mohammed, I'm going to turn it to you for your presentation, Africa CDC's strategy for tackling mental health challenges in Africa. Thank you.
Thank you so much, Chair, and I hope, is my slide on?
Yes, we can see your slides.
Thank you, colleagues, and really, it's a great pleasure to be here to present the Africa CDC strategy for tackling mental health challenges in Africa, and my sincere appreciation to AFENET for giving us this opportunity. I listened keenly to the last three presentations, and I will just build on what Dr. Ebere and the last presenter have discussed. We all know that mental health is first, non-communicable diseases are neglected, but mental health is the most neglected component of non-communicable diseases. We know, I've been hearing of people talking about universal health coverage, but we all know that in some parts of Africa, the treatment gap for people who require treatment for mental health diseases, disorders, can be as high as 95%, meaning 95% of people who require treatment do not get it, based on the current arrangement we have in some countries in Africa. What are the challenges we have in the mental health system on the continent? First, it's a low government priority for mental health. There is non-existent or poorly implemented mental health policy legislations and funding. And when this funding is available, it is mainly in government hospitals in big cities that are not accessible by 90% in some cases. Some series says between 70 to 90% of people who require treatment because they are really not accessible. There is lack of equity in the distribution of the mental health care workforce, and a lot of shame associated with the disorder, stigma and discrimination. And even in the whole space, there are a lot of issues of human rights abuses. And of course, like we've said, the lack of adequate number of mental health practitioners. And this is worsened by the brain drain we're witnessing all over the place with them leaving Africa for the wealthier countries. Even among the non-communicable diseases, you can see that mental health takes about the largest chunk of the DALYs when it comes to the non-communicable disease. But again, it's mostly neglected. Why should government invest in mental health prevention and control? This shows clearly that the highest peak for mental health disorders is in our youth, the most productive age. You can see between 15 to 25, that's when the largest peak of people falling ill with mental disorder occur. And if we do not intervene at that point, it becomes something that continues throughout life, and with a lot of economic loss, not to talk of the humanity component of it. We also have unequal distribution of resources. While the 70% of the global burden of mental disorder is located in the low to medium income countries, including Africa, 90% of the resources for mental health prevention and control is in the high income countries. So this just demonstrating that. The majority of people with mental health disorders globally do not receive treatment. I've talked about that because of the treatment gap. If you see a woman with depression in a village, maybe 200 kilometers or 300 kilometers from maybe Abuja or Nairobi, to get treated with a medication that will cost less than $20 per month is impossible. But if you can treat that patient can be able to contribute to the society and continue to do the work she's supposed to do. So these are some of the issues we need to see, some of the challenges that needs to be done before we can really change the narration on the treatment gap. And for all intents and purposes, we cannot be talking about universal health coverage when 90% of people requiring treatment do not get it in the space of mental health. And you can see for developed countries, it ranges from 35 to 50. For developing countries, 76 to 85%. We know some recent data shows as much as 90% do not get those treatments. For workforce, we are losing some hospitals in Nigeria, where I come from, have lost more than 40% of their mental health nurses in the past 1 year alone. I want you to digest that. And also, many doctors, many psychiatrists that have been trained on the continent of Africa are all moving out. And this is compounding the issues we are having. So these are some of the things we really need to look at and see how we can solve some of the problem. And basically, issues again of human rights abuses. You can see the kind of sometimes the pathway to care does not really start with the hospital, does not start with the traditional, with the orthodox treatment. It goes through other form of treatment, and even in some treatment facilities, you see some of these kind of human rights abuses. And then came COVID-19 that made a lot of things worse. Of course, the prevalence and incidence of mental health disorders like anxiety disorder, even some psychotic or schizophrenia have been shown to increase because of, due to the temporal relationship with COVID-19. We've seen probably because people could not go to the hospital and get treatment, the anxiety There are all risk factors for either relapse or also not getting treatment as you're supposed to get. So this led us in Africa CDC to work to see how can Africa CDC really support our member states in strengthening their mental health system to respond to all of these things that we've talked about. So one of the things we did first when the Division of Disease Control and Prevention was set up was really to develop a strategy to use to support our member states in the areas of non-communicable diseases, injuries, and mental health. And we wanted to use some of the best practices we learned during the outbreaks, response to COVID-19, like to really see how we can use it to strengthen the mental health system, like having strong African institution, public health institution, local production of vaccines, even drugs in the space of mental health. How do we ensure that the drugs, either through pool purchasing, are always available in the general hospital, even in our PHCs, in strengthening public health workforce, and then, of course, trusting partnership. One of the key things we are doing that form the key cardinal point of the strategy to strengthen mental health is we want to use want to strengthen mental health and psychosocial component of emergency preparedness and response. And this for two reasons. We've all seen what the Ebola did in West Africa, and of course in parts of Central and East Africa. And the COVID-19, we know that mental health component is very important. If we are to respond resolutely to these emergencies, whether it's an outbreak or a pandemic. And it's really important that as we're strengthening that, we take some of the learnings from this response back into the normal mental health system and use it to strengthen it like a build back better situation. So this is part of what we're doing. And to address the issue of the treatment gap, we all know that how some of these resources can also be used to support integration of NCDs, injuries and mental health, into the PHC. Of course, we will want to also strengthen the laboratory systems that support mental health and develop and implement sustainable and scalable tax shifting models. We all know the image gap for WHO, and we want to really support that moving forward. We've just recently launched the multi-sectorial task force, the African Union Multi-Sectorial Task Force for the Prevention and Control of Non-Communicable Diseases, Injuries, and Mental Health. And this task force, we really want to harness all the resources available at the different departments of the African Union and other partners, everything together, and see how our ministries will be able to respond in that regard. So this was launched, like I told you, just last week. And I'm happy to announce here that Africa CDC will be launching a mental health leadership program. One of the things in our consultations with our member states when we discovered was that for mental health lack public health specialists that knows mental health and public health. And that is why it's difficult to make an investment case for mental health. That is why it's difficult to find mental health practitioners sitting on the table when decisions are taken by the ministers of health and of course the ministers of finance. So bringing some of these, working on developing a curriculum based on the work that's already been done, and training a core team of mental health specialists in the highest leadership program on the continent, we feel will go a long way in really mainstreaming mental health into public health also, so that we can be using public health solution to mental health system problem, because we cannot just depend on the traditional schema I think we can be able to reach 95% coverage of those who require treatment right there in my village in Nigeria. So this is really important, and we're very proud of it. We'll be launching it January next year. We finish all arrangement. We have the funding for it, and we'll really appreciate if any person is interested, you can reach out to us, and we'll give you more details on how this program will be done. We've also, a cardinal point of what we're doing is advocacy, mental health advocacy, because we know we have to advocate and get the highest level of our political leaders to advocate for mental health. As you can see in this picture, the former acting Director General of Africa CDC, and then the current deputy chairperson of the African Union, all coming together to advocate for mental health. We know we need to do this because we need to bring down stigma. If we it's not just even getting the health workers to the community. If we don't get rid of stigma and discrimination, we will not be able to get to where we want to get. And this is very important to us in Africa CDC. We need to change the laws, some of our archaic laws that govern our practice in the mental health. If you see some of the laws in some African countries still refer to hospitals as asylum, to talk about parole, really almost criminalizing and discriminating against people who have mental health diseases or disorders. So we are working very hard. We've started with Sierra Leone, and we're using countries that have already done this, like Nigeria, that have updated and passed their mental health law into force, and now removing all of those pejorative terms, we now want to use a kind of peer mechanism to support other countries to really change this narration. We cannot be using 1920 mental health policy in 2023. In conclusion, the COVID-19 pandemic has shown that the continental action on mental health is timely and urgent. We really need to support mental health system. And I like to say this, even for a emergency facing public health institution like Africa CDC, it pays to invest in mental health, because it is the health workforce that is responding to high burden diseases like TB, HIV, malaria, non-communicable disease injuries, and mental health that we can quickly convert during times of national emergency, like the COVID-19 pandemic, to respond to the pandemic and other emergencies. If we do not have this critical workforce and health system ready, then even our emergency response will be faulty. Thank you, and back to you, Chair.
Thank you very much, Dr. Mohammed, for this presentation and highlighting this really important topic. I also want to thank AFENET for bringing this topic to a plenary session. It's really important, and congratulations to Africa CDC for taking the leadership role on this topic. So I'm going to try one more time for Dr. Longat. Are you online with us? Okay, I think he is maybe not online anymore. He did provide, I think he may have anticipated a potential challenge because he provided us with a recorded presentation. So we will proceed with his recorded presentation now and on efforts at universal health coverage in Kenya. Thank you.
My name is Dr. Berat Langat. 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 Minister of Services as the acting head for the I was given a topic on universal health. I'll try to do justice to that. We have tried to crack our heads on what would be the best way to deliver UHC. And in that conceptualization, we have distilled it to 4 pillars built on one foundation. So the 4 pillars basically is addressing human resources for health. And we know that the health sector is quite very big on human capital. We understand the concerns around the numbers, the right mixes, the right skills at the right place. We are also aware of the many challenges around managing, motivating the staff and the industrial relations. So as one of the key pillars is how to make sure that we have the right motivated human resources for health. And there are a number of initiatives that have been made to make that work. Recently, we did have a declaration with a number of unions and bodies representing our healthcare professionals, just to commit to say that in the next 2 years, we want to have an harmonious way of doing business. And we have already set up some structures like the Kenya Health Human Resource Advisory Council, which ideally is supposed to assist us in understanding what is going on within HRH, the problems that you are facing and how we can address it. So therefore, HRH is a critical component of our UHC. The second component that basically we think we need to address, and we have already started addressing, of course, is commodities. Anytime you go to a hospital, especially the public sector, one of the reasons why our citizens are not frequenting the public facilities, of course, is the fact that when you go there, you are given a prescription, you can't get the medicine. So one, as a government, we are looking at, first of all, assuring that commodity security. Secondly, is that we make the prices relatively cheaper to the public. And not just the public facilities, even the private sector. Remember, when you go to a public hospital and you miss a prescription, you are going to go into a chemist just outside the presence of that facility. And the likelihood is that you are going to buy a medicine almost 4 times the price that is coming from the factory. So the thinking around commodities is how do you, for example, pool procurement, both to support the public and the private? Is there any way in which we can consolidate the consumption that we see, be able to focus and negotiate and provide some minimum pricing that both the public and the private can enjoy? We want to make sure that there is traceability of the commodities, visibility of the commodities from the manufacturer through the supply chain provider all the way to the downstream, which is the health facilities, and of course even at the dispensing. That pillar addresses digitization. And probably for digitization, that is, of course, within my directorate. You are realizing when you talk about traceability, visibility of the commodities, there's a connotation of digitization in that. Do we have the proper logistic management information system that is able to give track of those records? Even for human resources, do we have the right digitization that allows identification of the provider, the facility? So digitization for us is to make sure that we have as a government, we do our business. This is basically provide the standards. Make sure that facilities are able to talk to each other, systems are talking to each other based on standards. Make sure that reporting obligation is actually enforced. So the commitment of the government is that we are going paperless, we are digitizing from the community, and we have already done that, providing almost 100,000 phones to the community health promoters, the primary healthcare facilities, a movement of a minimum shareable records, and therefore, if you are referred to a facility, you don't need to carry paper. You just appear and your records is available. So digitization is a very critical agenda that we are hopeful that in another 2 years maximum, we should be having all our primary healthcare facilities, all our facilities largely going paperless and fully digitized and being able to interoperate based on standards that have been provided by the government. The last part of it is the financing, which is sustainable financing for health. And basically, we are looking at a situation where, as a government, we are financing the primary healthcare through the exchequer. We also know that the population really suffer a lot, especially for chronic conditions. Our constitution is providing that emergency services is supposed to be offered by all our providers. So we know that the private sector, even the public, when there's an accident, they are able to evacuate, they are able to resuscitate, but then they don't have anywhere where they can recover their costs. So we are also providing what we call a critical emergency or emergency critical and chronic illness fund that is also financed by the central government. But the rest of the services that you are going to acquire in this country is based on a financing arrangement, a mandatory scheme, the social health insurance. And that means every Kenyan, even if you are a resident, there's an expectation that you contribute into that social health insurance schemes. So all those four pillars will work if, of course, we strengthen our primary healthcare services. So at the moment, you are saying the key focus is primary healthcare services, preventive and promotive services. As I mentioned, we have already started with community health promoters. We are organizing our primary healthcare facilities into what we call primary care networks, what we call the PCN. So it's a hospital managed by a multidisciplinary team, sub-county hospital, that is supporting both the health centers and the dispensaries, and of course the community. So roughly a PCN is serving a population of 150,000, give or take. And for all those pillars to work, the second phase that the government, after thinking through that, was to make sure that we have the necessary legislative environment or the legal basis to make sure that this works. And recently we managed to bring into existence 4 bills, which are now acts of parliament. The President actually signed on 20th of October. So for social health insurance, the primary health care fund, and the emergency critical illness and chronic care fund, that has been captured in what we call the Social Health Insurance Act of 2023. And that is going to establish a social health authority, which is taking over from National Health Insurance Fund. That law, at the moment, you're actually working on the regulations, and we believe that at the beginning of the year, we want to start seeing the social health authority being established and is taking over the mandate from National Health Insurance Fund. The second bill that went through Parliament was primary health care and community health services. Bill now is an act of Parliament, and basically it is organizing primary care services through the PCN, ensuring that there are necessary committees that manage those PCNs, but also is recognizing the community health promoters as that they can provide preventive and promotive services. The counties have been struggling on how they are going to pay stipend to the community health promoters. We have now anchored that in a law, and we expect that the national government and the county government will be co-sharing the payment of a stipend. We are also providing them with a digital gadget. We are also providing with a kit. So that law now is enforced. The third one is what we call Facility Improvement Financing Act of 2023. And basically that legislation, traditionally, I mean, if in a public facility, yes, you collect let me call it fees or cost sharing. And that money normally goes directly into a central revenue fund at the county level. And rarely does that money get back to the facility. So probably it's generated, it goes to build roads. Sometimes it goes to do operations and maintenance within the larger county or within some time reallocating the facility. So what that bill is trying to bring into being is let the facility generating the money retain that money. They are empowered to do a budget based on their needs, and they are able to use that money to improve services in the public facilities. The private sector, I mean, is understandable. They generate the money, so they're able to reinvest, they're able to buy commodities, and therefore you see a lot of traffic of people getting into private sector. But then we want the public facilities to also enjoy that they can reinvest that money. If they need a human resource, maybe a short timer, somebody to do locums, they're able to provide that. The fourth one, which is basically sitting on my directorate, is the Digital Health Act of 2023. That act is actually establishing an agency to manage a comprehensive system. It is setting basis for us to set the standards, enforce and certify those systems, so that whenever as a Kenyan you buy an application or a system, that system must meet certain standards, so that each patient and each client is able to access their records. You move from one facility A to facility C, you don't need to carry paper. You only need to present yourself in that facility. Because you have already been uniquely identified, there is a minimum shareable records that you must share. It is a must, it's enforceable. So that digitization then, we believe, is the one also that is even going to address issues around claiming from primary healthcare fund. Problems around fraud. Because the future is for you to get reimbursement for primary healthcare services. That patient must be identified uniquely with a client number, registration number. That client must have been seen in a facility that is in the system. It must be seen by a healthcare provider that is in a system. You generate a minimum record, and that forms part of the claim. So it is the digitization that is going to connect. But we also know these are just 4 bills. For it to work also, we need to get 3 other laws to come into being. The fifth one is around quality of care. And so we expect, and in the past actually we have seen insurance provider both is the one who does the assessment of the facilities, does the certification, as does the registration. What you are now saying is that we are going to get another law to establish what we call a quality of care services authority. We also want to come in with a law, as I mentioned. There are issues around health products and technologies, so there will be another law that is going to address that. Thirdly, we also want to make sure that our regulatory body, especially pharmacy and potions board, becomes autonomous. So there will be the 7th one that is actually creating what we call the Kenya Drug Authority, which is taking over from the pharmacy and potions board. So you can see there's a thinking around UHC, there's the legislative environment that enables the delivery of that. But then, as a government, you're also saying, it is not about the health sector alone. So we want to push everyone into a one government approach. For digitization, you need the Ministry of Information, Communication and Digital Economy. You are talking about preventive and promotive. What will be the role of the Ministry of Agriculture, for example, the role of schools, Ministry of Education. So there is that really push to have a one government approach. But more importantly, we are talking about a one ministry approach. So there will be no secretariat running UHC. So with that, we think that we are cracking it well, and we are hopeful that with these laws, with these commitments, we'll reach somewhere. And I want to end by saying, I think it's really critical for AFENET conflict attendants that you also spend time and learn your voice, learn your expertise in supporting the government to realize this agenda. Once again, thank you for that opportunity, and it has been a pleasure speaking to you.
All right, another important presentation about universal health coverage, and in this case, the underpinning of digital health, digitizing health and health records as an enabler towards maintaining and modernizing access to healthcare. Okay, we have a few minutes for questions. Unfortunately, I don't think Dr. Longat is with us online, but this session is now open for questions. Yes, please. We'll take 3 or 4 and then allow for responses. Please come to the microphones in the. Okay, I'll just go across the room. We'll start here.
Thank you to the presenters. This goes to Dr. Ebere. So I have 2 questions for you. As we think of the economic downturn that we are having, it becomes more increasing to think of the domestic resource mobilization as you've talked about. But how do we incorporate, because the talk around the African countries is more on domestic resource mobilization without discussing the efficient use of resources. And it doesn't matter how much we put in if we are not getting out anything of value. So we have, for example, costly mix of staff or an inappropriate mix of staff. We have high cost of drugs. And given this, we will need, for example, to bridge a bit with the development assistance for health. But as the fiscal space gets constrained and the budgetary space, we see the development partners or the partners in health are increasingly asking for the value for money. So on the prevention side, for example, if I think of Gavi, as they are providing support for vaccines and immunization programs, they also have a very systematic way of evaluating which vaccines had to be funded that bring the highest value for money, so that if the resources increase, we are able to prioritize. How do we start this conversation when we are thinking of preparedness? So that we can know, as the resources increase in preparedness, this is what we can start prioritizing it as we move forward, because not everything can be funded given the constrained fiscal space that we have realistically.
Okay, thank you. I think we'll have to limit everybody to one question. I'm sorry, we don't have much time, and there's many people who have questions for our excellent presenters. So thank you. So please, if you could move directly to your question, your one question, and for our presenters, so we can get in. There's lots of people that would like to ask. Please, on this side.
Thank you very much. I think this mic isn't working, or is it? Oh, yes.
We hear you.
So thank you. My name is Dr. Vincent. I'm from the AFENET office in Rwanda. My question is for the second presenter, our colleague from Ghana. Thank you for your important talk on financing of UHC and sharing the Ghana experience. You've informed the meeting that you in Ghana have gradually introduced programs that cater for care and treatment for chronic illnesses and cancers under UHC. We just wanted to hear a little more about some of the financing strategies that you have used in introducing these programs, knowing that regionally a lot of the ministries have been a bit apprehensive or fearful of introducing these wider programs for chronic illnesses and cancers within UHC in fear of catastrophic health expenditures. Maybe you can share a little bit of some of your financing strategies that you have employed. Thank you.
Okay, thank you. We'll go to this microphone.
Okay, c'est Joseph Ochudi.
Joseph Ojudi, FETP, Côte d'Ivoire, AFENET. My question is about the health, mental health rather, of Africa CDC. The question of mental health in Africa, I think it's all about beliefs on traditions. And we think that these are bad spirits And I have the impression that the actions that we are doing in sub-Saharan Africa on mental health, they are medically underpinned. We need to put more emphasis on sensitization of the population first and foremost, to accept that mental health, this is something that can be done medically and not to have psychologists. So we need really to sensitize the population beforehand before we can deal with this problem. I thank you very much indeed.
Let's go back to the middle microphone here.
Okay, thank you very much. I'm Dr. Skosana from Zimbabwe. I have a question for our colleague from Ghana on universal health coverage and national health insurance scheme. Just wanted to check, I mean, one of the major objectives, obviously, you said was towards achieving UHC. I'd like to know what metrics you have put in place in order to measure progress to your ultimate goal, and also how have you been dealing with issues of moral hazard for your scheme? Thank you.
Okay, I see that we have 3 more people at the microphone. I will allow these questions if we can make them very, very brief, and perhaps our presenters will be able to kind of consolidate their responses. Let's go to this microphone.
Good morning. Thank you very much. My name is Yaya Disu, FETB graduate. I work with Nigeria Center for Disease Control. My question goes to the first presenter, Dr. Iberi. How can we optimize the benefit of resource mobilization at the subnational level, particularly in the communities, considering that most African countries now have a top-down approach to governance system in all our countries? Thank you very much.
Okay, thank you for being direct with your question. This microphone.
Thank you, Kip. My question is to Dr. Abdel Azouz Mohammed in CDC. Very quickly, one of the issues you mentioned was shortage of human resource in terms of psychiatric nurses and psychiatrists. To what extent are you in Abuja being able to lobby our governments there? In 2001, they talked about 15% for health budgets for health in the Abuja Declaration. And then secondly, you talked about having a course for leadership in psychiatry, which is good. But in Zimbabwe, where I come from, there is also what's called the Friendship Desk, where a psychiatrist, Dr. Dixon Swanda, has been able to coach grandmothers to handle basic psychological issues. Can you also incorporate that? Thank you.
Okay, thank you. Last question, if you could, just one question, please.
Thank you very much. My name is Linda Nyashakanzara, and I am from Zimbabwe. My question goes to Dr. Mohammed, who presented on mental health. It's quite refreshing to see mental health being incorporated in issues relating to emergency preparedness and response. I would like to find out to what extent you have incorporated our sociocultural context into account in terms of involvement of traditional healers and leaders. I say this mindful that in our context, a lot of our people tend to, their first line of care where mental health is concerned is in the communities and the traditional leaders. So just in terms of community engagement, advocacy, and research, to what extent is that being done, and how best can we maximize this? Thank you.
Okay, thank you for your questions. I'm going to start with Dr. Mohammed online. There were several questions for you, Dr. Mohammed, if you're there, if you're going to try to address those all together. Thank you. We're not hearing you.
Hello, can you hear me?
Your microphone appears to be
Hello?
muted. Now we hear you.
Can you hear me?
Yes, we hear you now.
Hello, can you hear me?
Yes, we hear you now. Or can the IT folks give him a thumbs up that we can hear?
Perfect. So really, my gratitude to the excellent questions from the floor really shows the message was well received. I like the question on beliefs and tradition, bad spirits. This is really the prevailing view of most Africans when it comes to mental health diseases. For instance, a child with depression, talking about being the cause of a road traffic accident. People will believe him literally. And if you have that kind of belief, it also goes to your etiological thinking, and it goes from etiology to your pathway to care. So these are very important things that Africa CDC's mental health policy is taking into account. And we want to support our member states in knowing the best way to sensitize the population, knowing to work with what they have on ground, because you cannot change, it's people's beliefs and think you cannot change it in a day. But if you continue to work with the health system for risk communication and mobilization, using the available resources, maybe community health workers instead of using doctors or nurses, I think we'll be able to change that. We have a great problem of shortage of human resources. And I sit in Addis Ababa. I'm reaching you from the new building of the Africa CDC in Addis Ababa. That's where the headquarters of Africa CDC is. What are we doing? This is one of the reasons why we are launching the Mental Health Leadership Program. We need mental health professionals who can translate evidence to resource mobilization, who can talk to the Minister of Finance and tell him why he should increase funding to mental health. And that in itself will help us to reach that 15% target, the Abuja Declaration that you talked about, which is very key. Most of our countries have not reached that target. So there's an opportunity for us to get there. I also want to talk about the friendship desk. I know of the friendship desk in Zimbabwe, an excellent program. Africa CDC is supporting processes, mechanism for tax shifting and tax sharing. We all know, because of the lack of workforce, we have to do tax shifting and tax sharing and use ingenious ways that can get treatment to the population. However, we also want to ensure that those tax shifting and tax sharing and other ingenious ways also take quality treatment to the level of the community. The last question, you couldn't have said it better. We need to do socio-cultural contextualization of whatever we're doing, because our people, the way we interpret, the way we even, the socio-etiological thinking of mental disorder is a bit different. And if we are supporting the integration to emergency preparedness and response, we have to put all of this into consideration. What we are doing in Africa CDC is that we've supported 3 regions of the continent in a theory of change process for integrating mental health into mental health and social support into emergency preparedness and response. But we are very thinking of the fact that we don't just take tools, we have to contextualize it to the African format. Africa CDC supports member states. We do not implement directly. So all of these, we are working with our member states, with our focal points to ensure that we are able to positively influence the mental health system going forward. Thank you. Back to the chair.
Great. Thank you very much. Appreciate that. So I'm conscious that we have gone over the time allotted for this session, and I want to be respectful of the next session. I know people are very eager for that one. I'm going to give Dr. Iberi and Mr. Raphael just a brief moment to respond to the questions, but let's be conscious of time and respectful of the next session, please. Thank you.
So thank you very much. And I'll take the response to both questions. I'll put to me together because I think they're linked. So you asked about how we prioritize and bring in efficiencies to extend the impact of our domestic financing. And you also asked about how we can optimize the use of the resources mobilized when we have top-down systems. And because of the time, I'm going to respond in a couple of sentences. So what I'm calling the Ds: data, digital, democracy. So bottom line, we have data that should inform prioritization. We should use digital tools to bring in efficiencies into how we, both in terms of how we gather information, analyze, interpret it, and use it, and also how we deliver services. And the democracy there is that most of our countries are democracies of some sort. Part of how we bring in the citizenry into decision-making for priority setting and using the resources is through supporting civil society as the representatives of the electorate who we're there to serve. So if it isn't saying it that simply makes it sound simple. It is complex, it's long-term, but it is absolutely critical. And then the one final recommendation I'd make to that is actually to move from vertical to horizontal. We have efficiencies that we can make if we actually, like Dr. Abdulaziz mentioned in his talk, like, rather than having community health workers who do polio only, who do surveillance only, who do immunizations only, if we start to look across at across the whole system and translate some of that investment in vertical programs into more horizontal streaming, our impact actually with the same amount of resources would go further. I'll just stop there. We can talk more at the break.
Okay, thank you. The first question from AFENET Rwanda asked about the strategies for financing chronic diseases that are included in the National Health Insurance Benefits Package. Like I indicated in my presentation, 92% of our funds come from the tax that is collected. So if you arrive in Ghana now, you sleep in a hotel, anything that you purchase, 2.5% of the ad valorem tax goes to the National Health Insurance levy. Okay, so we had another 5% that comes from graduated premiums that the informal sector pay for when they register or subscribe for the card. So clearly, these are the funding mechanisms. Of course, recently we've added road accident fund is also contributing something to the National Health Insurance Fund as well, because we realize that when you are involved in an accident and you are rushed to the hospital, you have to be taken care of immediately without having to pay anything. So we're getting some money from these funds as well. So these are the funds, and of course, we have investment income from the funds that come in that we do not use to pay claims immediately. So those investment incomes also give us something. But by and large, if all the collections that are made by government on behalf of the National Health Insurance Authority was remitted to us as a whole, we should have no problems. We often get maybe between 65 to 70% of what is collected on our behalf. So if we got all that, we shouldn't have any problems funding. So this is how we're dealing with the ailment. So like I said, cervical cancer, breast cancer were included from inception. Of late, we're adding mental health, we're adding renal dialysis, and we're adding prostate cancer as well. And we believe that once these are added, the decision makers talking about government will be able to at least increase what comes to us to enable us deal with this. So the funds will be available if the political will is there and government is prepared to release everything that is due us. Now, the second question from Zimbabwe talks about moral hazard and measurement metrics. Now, Ghana at present, we consider about 16 regions across the country. If we look at registration and membership across the country, some regions do as much as some regions will do 50%, others do 80%, others probably do 90%. Now, our measurement is that if nationally we're able to do 80%, we would have been achieving UHC. Again, moral hazard is a big issue, and it's always been there. That is why, when the National Health Insurance started in 2003, it started with community mutual district, community-based mutual health insurance schemes. Good to add that the director of AFENET sitting here was a director of was a chairman of one of the board of directors of the district mutual health insurance schemes when he was in Ghana around 2005, 2006. Now, what we realized, the moral hazards became a big issue because with these community-based mutual health insurance schemes, with their separate board of directors, interoperability became a problem. That if you move from one district to the other, it was a big issue, and it could not nationally be applied. Second, you had issues of people who were in particular communities doing health shopping. They go to hospital A, complain of headache, get medication, go to hospital B, C, and that kind of thing. And they go into and self-medicate. These created issues. And for the public physicians, all of you, I understand the challenges with that kind of system. So that was why in 2012, the law had to be changed to nationalize it and then to centralize the operations of claims processing, because you had situations where the community-based mutual district insurance schemes did not have capacity of the clinicians to vet the claims and ensure that people were not gaming the system. When we nationalized it in 2012, moving forward, we had situations where medical superintendents of hospitals were jailed because they were, recycling claims. Claims were submitted from one facility, another facility picks it and go to process it and submit as claims. And people are still serving jail time for trying to game the system. It is not easy. We can't be 100% correct, but at least we're making progress. Thank you.
Great. Another round of applause for our presenters. And Dr. Mohammed, thank you so much for staying with us online. Okay. Now as we transition, one advantage that we have is the next panel will be led by Dr. Ebere, who is already on the stage. So I am going to excuse Mr. Raphael and myself and turn it over to Dr. Ebere to invite the other panelists for this next panel, which is sure to be very interesting and exciting. And maybe while we're doing this, people could stand up and stretch their legs. Thank you.
Thank you. Thanks. Thanks. Please do stretch and shake off the... Excellent. While you're stretching yourselves out, I'll start by introducing the session a little bit. And it's my honor to be your moderator for the next hour. We are running a little late, but we will hope you'll crave our indulgence because this is really an important section for this conference. So in introducing the next session, a couple of panels, we had so much interest that we are actually split this into two shorter panel discussions to give opportunity for people who have something to contribute to talk on this topic. So there's strong evidence in written and oral history about the role of women as leaders in pre-colonial African societies. Women have been actively involved in politics and religious life and in health as health providers for as long as we can trace our oral history. So the current prevailing view amongst some traditional and conservative groups within African societies that leadership roles for women are contrary to African culture is actually not based on history. And we think that is this belief that has actually contributed consequently to the, combined with the recent colonial experience, that has led to this Eurocentric view of the role of women being dormant and the role as women as not having leadership responsibility becoming dominant and adopted as the African view. In Africa today, women are underrepresented in education at all tiers, and particularly in science, technical and engineering and medical education, and are disproportionately expected to deliver care for family, which affects their career progression. Women are given opportunities in times of crisis, but subsequently dismissed and or unsupported. There are reports going on at the moment about called the Great Resignation, where a significant proportion of women in the health workforce are actually resigning from their roles. Across research, and other health sector related activities, women are asked to design interventions, but when they're successful, the management of their implementation is taken over by men. So although improvements have been made, women remain underrepresented in STEM in Africa. Educational attainment of women remains low. Women are more likely to drop out of formal education early under economic pressures. However, when women are given opportunities to access education, there is strong evidence that they perform at least as on par with their male counterparts. So an effective health system needs to recognize the needs of all its users, from recipients to providers to leaders. Across the world, healthcare is delivered by women, but led by men. There was a WHO report called Led by Men that goes into detail on this. And we know that the statistics suggest that 70% of global health workforce are female, yet only 25% of those leadership roles are held by women. Women are missing from decisions related to healthcare, including policy making, budgeting, and it's no surprise that the health issues of women are often underfunded. As a consequence, lives are being lost. Over 800 women die every single day from preventable causes related to pregnancy and childbirth, and more than half of these deaths occur in Africa. In Africa, adolescent girls are 3 times more likely to be infected with HIV compared to boys of the same age. So we cannot afford to wait for existing systems to course correct at the current slow pace. We have to do things differently to recognize and address the effects of gender discrimination that are holding women back. And as we hold women back, we actually hold back our own development as a society. We therefore have 2 panels who are going to share some experience of how African countries are addressing this challenge and how we can learn from each other and share best practices when it comes to promoting women's leadership in public health. So my call is that it is time to step away from business as usual and set our sights on higher ambitions. And so with that, I would like to welcome my first group of panelists to take their seats as I introduce them. So I have and I'm hoping that they're all in the room, I have Dr. Gladys Kalema, who is the founder and CEO of Conservation Through Public Health. I am not going to give their full bios because you have access to that in your programs, and I'm conscious of time. So please, Dr. Gladys, come on to the podium. Have Dr. Rebecca, Resident Advisor, Togo Field Epidemiology Training Program. I have Dr. Shiba Gita, Managing Editor of the Journal of Interventional Epidemiology and Public Health. And finally, for this first half, I have Dr. Wangechi Gatei, who is the Director of the Division of Global Health Protection, overseeing global health security portfolio in CDC Tanzania. Please welcome them. And please, I think Dr. Rebecca will probably prefer to speak in French. Yes, so please make sure you have access headsets if you need them. I do. But I'll start with Dr. Gladys first. And what role are women playing in integrating? Dr. Gladys, your particular area of interest is One Health. So what role are women playing in integrating the One Health approach to promote the dual goals of improving public health and conserving natural ecosystems?
Thank you so much for inviting me to AFENET conference. I got to know AFENET early on when the National Ministry of Health was establishing national disease task forces. Actually, at the time that I joined the task force, our organization, Conservation Through Public Health, joined the task force. We're dealing with an anthrax outbreak in Queen Elizabeth National Park. People were eating hippos. Some of them were dying of anthrax, others were getting sick, and tourists were scared to come. So this is a typical One Health scenario where you needed to have people, the wildlife sector, the human sector, the livestock sector getting involved because people are getting anthrax from eating dead hippos or from their cattle that graze with the hippos. I would say that my One Health journey began working as a first veterinarian for Uganda Wildlife Authority. We investigated a skin disease, a fatal skin disease, in the then critically endangered mountain gorillas. It turned out to be scabies, and one of the gorillas died and the rest only recovered with treatment, and was traced to people living around the national park who have very little health care. Gorillas were going into their gardens to eat their banana plants, picking up dirty clothing on scarecrows, touching it, and picking up the scabies mites. So a few years later, we founded Conservation Through Public Health to improve the health of people and the wildlife together. And so when we founded Conservation Through Public Health, we found that people are very unhealthy. They had very little health care, especially because it's right in the rural areas, 10 hours drive from Kampala, bordering with Democratic Republic of Congo. So they had very little health care. And when we met with the communities, they said they wanted health services to be brought closer. And so one of the programs that we have at CTPH is to work closely with community health workers. We train them to do conservation work. Half of our volunteers, community volunteers, are women and half are men, which is very exciting. And this came about by accident, actually. It wasn't something that we necessarily planned to do. But when we spoke to the local leaders at the beginning, before the village health system reached Bwindi, we asked them to select people who can read and write in the local language and who are trustworthy members of the community. So they eventually picked half of them men and half women, because we started off with couple peer education. And so in the process, we're finding that women are more engaged in conservation and natural resource management, which is very much a male-dominated field. There's hardly any women working in conservation, and I'm glad to say that it's improved over the past 30 years or 25 to 30 years that I've been in conservation. But also another thing that we found is that men were getting more involved in healthcare and family planning. As much as this discussion is about women empowerment, there are very few male community health workers, and it's very important that both men and women are equally represented in this sector. And one thing that we found is, when we started out, when I went out and spoke to the communities, when I was working as a first vet officer for the Wildlife Authority, Uganda's first wildlife vet, I went with three men, community conservation ranger and warden, and a district health assistant, to talk about how gorillas got sick and how we can prevent it. And people came up with much better suggestions than I had to offer. But the women were whispering to each other, let's educate our daughters. Look at her standing up. She's a woman leading a team of men. Later on, when we started the NGO, because of our work, many women are standing up in communities, giving talks, presenting flip charts about improving public health together with conservation. Some of the things they talk about is good hygiene and sanitation. In the communities we've worked in, people started off with 10% with hand washing stations, and now it's as high as 75%. Family planning, we started off at 22%, below the country average in rural areas of 30%, but now it's 67% in the first parishes we worked in, above the country average of 45%. Now that the family size has reduced from 7 to 4, which is something we're very excited about. Lower than most places in Uganda, in Kanungu district where the gorillas are found. And they also promote good health-seeking behavior. People have to go and refer themselves for TB, HIV, scabies. They also promote sustainable agriculture and nutrition. They talk about homes visited by gorillas and get the gorilla guardians to hold them back, human gorilla conflict team. They talk about how they can access tourism revenue, and they talk about the dangers of poaching because they can pick up diseases from duiker, bush pig, and other animals. So we're very excited that through our approach, women are leading efforts. We currently work with over 400 village health and conservation team members, reaching over 7,000 households with over 40,000 people. And half of them who are doing this work are women. So we're very, very excited about this.
Thank you.
I have to say also that I wrote a book called Walking with Gorillas, which there's a whole section on One Health, which talks about how we set up our One Health approach, and I hope you get to read it. Thank you so much.
Thank you very much. Thanks, Dr. Gladys. So, Dr. Rebecca. So, Dr. Gladys actually just gave us a perfect example there about how you model the leadership that you want to see. Just by seeing her in that leadership position, more women wanted to get their daughters to get access to education, to have similar roles. So that is one of the approaches we take to increasing women in leadership positions, being visible. So I wanted to ask you how Togo is actively promoting women's leadership and involvement in building resilient health systems. What specific policies or initiatives are being used in the country? What can we learn from Togo?
Merci. Thank you very much. I should say since 1983, Togo has adhered to the Equity and Gender Convention, and this helped the country to start by introducing and nominating women as the head of our institution. We should say that the policy that we have adopted has shown that through the Prime Minister, who is a lady, the head of Legislative Assembly is a lady, and we also have more than 12 people in our lady in our government. But we should say that during COVID-19, the UN Secretary General had made a call, and we have been nominated to make sure that we take the lead on this public health action. So this had helped Togo to be well prepared before having our first case. But I should say that I was not the only one in that function. I have other ladies together who worked with me so that we can set up the main document. So we should say that during the pandemic, we work with the ministry so that we can support them in explaining the epidemiologic situation of the country. That was done every day. And we also came up with guidance for dealing with the pandemic. So we had to go beyond the pandemic, which took pretty long. So today we should say that in our country, the epidemiologic surveillance is done by a lady, is chaired by a lady, and the National Institute of Hygiene, who's the reference laboratory, is also headed by a lady. And one of the main department of our health ministry, responsible of research and planification, is also headed by a lady. So we should not lose sight that even for our FATP program, the program director is a woman. So we should say that from 2016, we did train people. We have trained only 10% of women among our graduates. This is because the profile that we use to unregister women, it was such as that women were not really represented. So we still have work to do on that strategic plan that we are formulating so that we have a systematic quota to make sure that women are represented. So we want to have an advocacy where women will help us to solve to close the gap. So I should say that women as actors in public health and also women as beneficiary of public health. So we are working on these two aspects. So the women, in fact, make sure that children have education through free education, and these policies will help us to close the gap among students who have access to education. Beyond that, we also have initiated some project in order to reduce child and mother mortality. And we launched 2 or 3 projects which are being implemented so that we can reduce, and so far results are good. So we can see that women today within our country has shown that they can take their proper place in health, public health. For sure that we need more work to do, more mobilization, so that we can break barriers and allow women to take their right place in public health. Thank you.
Thank you very much. Dr. Rebecca. So you touched on the fact that you have very good visible women leadership in politics and in the leadership of the health systems, and yet you found that some of your instruments for recruiting were actually not identifying women to entry points for your training programs. And so I'm really pleased to say that, to hear about the intentionality to actually review those systems to ensure that you can attract women into those positions where you're not currently seeing them. And that brings me quickly to the question for Dr. Sheba, who you lead the Journal of Interventional Epidemiology in Public Health, and that aims to build culturally specific evidence to drive public health policy. Something that we mentioned is really critical for financing, is that we have culturally and locally relevant evidence. So what approaches is your journal taking to ensuring that the voices and the views and experiences of women are included in the evidence that you disseminate to inform African health policies? Because we know that at the moment, women are underrepresented in research, scientific institutions. They're underrepresented as subjects of research. Most of the drugs that we all take were tested on men, and then they're either given to women or women are excluded from having opportunity because they haven't been testing them. So what is your journal doing to broaden the representation in the evidence that we learn?
Thank you very much, and it's a pleasure to be here today. So just to set the stage, as we've heard through the days, Africa bears the brunt of the disease burden, and we talk about evidence-based decision-making and policy-making. And I think as AFENET, we are in a privileged position because the field epidemiology training programs are all about generating evidence. Every graduate has at least 4 outputs of work that have the potential to be published. And again, based on the presentations we've had through the days, I think there is a fair distribution, gender distribution of the ladies and the men. The onus is on us to ensure that these outputs make their way into journals. So AFENET has taken a deliberate effort to invest in a journal. And with this particular journal, we do not charge article processing fees. So we've eliminated that barrier, which oftentimes is the issue, the cost of getting your paper published. So with the Journal of the Intervention Epidemiology and Public Health, that bill is being picked by AFENET, the publisher. So we've eliminated that barrier. Secondly, AFENET has 3 official languages, English, French, and Portuguese. Unfortunately, my language center never developed, so I speak only English. But over the years, I've mastered how to work with people who speak other languages. But recently, as a journal, we brought on board a French editor to support me bridge that gap, because I struggle, and many of the journal articles we're getting were from our French-speaking countries. So again, that's another effort we've taken, and Ernest works with these authors. Again, most of the authors that submit articles to us are first-time authors. So one of my lifetime missions is to support everyone to be able to publish at least a paper. So unlike other journals where they are quick to reject your paper, that is something we rarely do in our journal. Instead, we hold your hand, we build your capacity, and this increases our turnaround times, but I want to set the stage that that's what sets us apart from the other journals, because we realize that somebody needs to build the capacity of Africans to write. Because we need to tell our stories, they are best told by us, and again, AFENET has invested in this. We work with scientific writers in many of our programs who mentor the residents to be able to write. We don't have writers in every country. I wish we did. And I'll take the opportunity to appeal for this investment to be made, because it will make life pretty easy. If I was to share the statistics, countries that have writers tend to publish more than those countries that don't have writers. So those are some of the interventions we are taking. And again, the fact that the residents work on different topics, I think we are able to capture the voices, the cultural sensitivities in the publications that come from our residents. So thank you very much.
I'm going to just push you on one quick question there, because I really want to know what your gender balance is with these innovations that you've described. Are you getting more women submitting as first or last authors? I put you on the spot there.
That's a nice one. I don't think I have run that data, and partly it's because I'm in denial. I don't want to see that all these efforts are not favoring the girl child, but I think that's something we'll do and probably publish on how this is turning out. However, many of our writers are females. The editorial team, they are more females than men. So I think we are modeling to the ladies that this is possible. So at least at face value, that initial barrier that this is predominantly for men, I think it's different in our context. There are more women out there than the men.
Thank you.
So, thank you.
Thank you very much. So, our last speaker in this half of the session, Dr. Wangechi, is the Director of the Division of Global Health Protection that oversees the Global Health Security Portfolio in CDC Tanzania. She has a long history of experience working in the health security space from when she joined CDC over 2 decades ago. And so I want to ask Dr. Wangechi to actually share with us some example of women-led solutions in your areas of work that you feel demonstrate the value of inclusivity and gender equity. Because it's important that we're not saying we want more women involved just for the sake of it. It's because we believe it improves the health outcomes that we desire, improves the quality of the services we offer. So I'd like you to perhaps share 1 or 2 examples that you think demonstrate this.
Thank you very much, and thanks for being a member of this panel. Maybe I'll just give 1 minute of my personal story, especially for the young women here. When I went to college many years ago, we were in a class of 96, and we had 10 girls out of the class of 96. This was in veterinary school, and now I see we are 2 veterinarians sitting here on the stage, so things must have changed. And so that is to say, my policy has always been, I don't see barriers, I see opportunities. I went to higher education through scholarships from newspapers, because it's not my job to stop myself. Somebody is paid to look at my CV and stop me or hire me. But don't be the one saying, oh, I don't think I make it, I don't think I can do that. That's not your job. Your job is to apply, your job is to go for your opportunities, your job is to stay curious so that you can keep moving. So in terms of the work that I support, we have seen that we are all moving towards preventive medicine, towards public health, and towards early warning. And I wanted to give an example about the early warning systems that we are all striving to do, because the most important thing is to identify threats as early as possible, because that's where we can have the highest impact of intervention. So in Tanzania, at least in the beginning of the COVID, one of the ones where we really, one of the things that I felt was really tragic was we had a small outbreak of meningitis. And a lot of women, because of the fear, many of the women did not come forward with the children, and we lost a number of children, not because bacterial meningitis is not treatable, but because there were delays, and there is nobody who is assuring you that a kid with fever or showing convulsions is a very big threat, and you should go to the hospital. That's part of a failure of us giving the right information to the carers. On the flip side, I want to give an example about the recent outbreak in Marburg in Tanzania. We have been investing a lot in what you called the event-based surveillance. This is where we enlist community members to be on the lookout for alerts. And most of our community healthcare workers are women, although we do have the men also who are also working out, because the idea is whenever you leave one gender or one ethnic group or whatever you're doing, you are missing out. So we are not saying you exclude men, we are saying enlist balanced population. So the first case had happened and they had gone to the hospital. Unfortunately, they didn't make it. They passed away. They were released to a friend of that person also became sick, and they went to the hospital. And nothing against the doctors, but doctors are overwhelmed. They are seeing so many patients. They are seeing so many cases. So they really did not connect that this person was as a friend or was related to the first person that had passed away. And while it was a hemorrhagic fever, it doesn't always present in the classic way. So again, the patient was sick. But around that time, the community healthcare worker in the village had the rumors that this patient who is sick is a friend of the one who had passed away a week earlier. And not only that, there were members of that household who were unwell. So she raised the alert and she sent a message through the event-based surveillance, electronic event-based surveillance that we've been training them on. And that triggered the initial investigation. And by then, we even had healthcare workers who had been exposed, but the medical fraternity, our systems in the laboratories had not yet picked this disease. It is these ladies and also one of the border riders who actually raised the alarm to say there is a cluster of people, friends or family members who have this infection. And once that was picked up, the rest is history. There was a quick assembly of a response, a very effective response, and I will say kudos to the government of Tanzania. The disease was controlled within about 72 days. We did not have any spread outside the region. The region borders Uganda, and it's a very high traffic region, but the government was now able, jointly with partners, to mount an effective response. When you look back at that incident or event, the lady who is the healthcare worker, you can imagine what impact would have led to and how many sectors it would have affected. The tourism sector, the commerce that goes around there, the commercial and travel and farming and everything. You know, there were 200 healthcare workers who were under quarantine because of the exposure. But the fact that she brought in that alert, you can just see the impact. However, you know, we don't, fortunately the government of Tanzania has recognized her, but I just want to say that it is that small alert, that small report that comes from a community healthcare worker who recognizes a cluster, who recognizes two people in the same family that triggers this kind of early warning. And so I would say that we have to, we don't have a choice. We have to enlist the community healthcare workers. We have to ensure that mothers can know about some of the early warnings and early signs that where they need to take their children to work. I do want to say finally that maybe I would also give a shout out. Our Minister of Health is a woman. The President of Tanzania is a woman. And maybe there's something to say about that, because there is a lot of good things that are going on. 2 weeks ago, Tanzania actually passed the universal health coverage in Parliament, so now it's a law in Tanzania. Thank you.
Thank you. Thank you. One of the lessons that did emerge out of the COVID-19 pandemic was that there was actually some difference in response to the pandemic when there were more women involved in the leadership, in the governance of the society. So what we're trying to say here is not that men aren't relevant or that we're pushing men out and bringing women in, is that we need to broaden the frame. There's more room. There's enough room for both genders. So because of time, I'm going to take our second panel and then we'll take questions for both panels together. So can you join me in thanking this first panel while I introduce our second panel. So we have 4 more, I hope they're all here, ladies that will be joining me up here. I've got Ms. Sisi Juru. I've got Dr. Cynthia Sema. Please come on up. I've got Jolie Kasombo, and I've got Dr. Ndi Waziri. Please join me up here. Thank you very much. Like I said, please look online, look in your programs for their bios. So they're all very, very accomplished women, so I don't want to spend too long reading out their bios so that we can actually get some questions to everyone. So thank you. Please make yourself comfortable. So we've had some of the broad examples there, and I in my head, I call this section of the panel glass ceiling. What glass ceiling? We're breaking the glass ceiling. And these accomplished professionals here are going to tell us some of what their achievements and what's going on to break those glass ceilings that we hear about so much. So if I may, I'd like to start with with Ms. Sisi. So I wanted to focus because Africa is a young continent. We are the youngest continent in the world, and there's all this recent news about the world is going to be African, and that's because we will dominate the population in terms of young people in the workforce in the next decade or two. So how are young women in particular leading the public health agenda in South Africa? And what can be done across the continent from your successes there?
Thank you very much, Dr. Ebere, and shout out to the young ladies in the house. So thank you very much. I think it's a pleasure for me to be here. And indeed, young women are taking the space in leading the public health agenda in Southern Africa and beyond Southern Africa. And one of the ways I think they're actually doing that in many different ways, which is not exhaustive, but in advocacy, in training, in leadership and mentorship, policy development and governance. And if we want to look at those things in more detail and just giving examples, starting with advocacy, which is very important in ensuring that there is representation of young women in the public health space. There is no denying, as you have highlighted earlier on, that we need to fill up the space as women. Men are the ones who are dominating that space, and we need to have a lot more women in that space. And one of the ways in which we are doing that, just by being here and sitting here and all the other women watching across the world, that is advocacy in itself. It's showing the young woman, the young lady, that you can actually do it yourselves. And that being said, it brings me to the issue of training. I myself am very passionate about training and lecturing, and I've been with the Zimbabwean program since 2016. And I have overseen the training of over 90 epidemiologists, and I'm happy to say that amongst those, about 49% are actually women. I had to do the math yesterday and go through the graduation list. About 49% are actually women, which is commendable. And not to negate, there are also other young women in this house who are also doing lecturing and teaching. That is also our contribution. We find means and ways to communicate with our own at our very own level, which sometimes the older generation may not be able to get to us, if the young people know what I mean. And related to teaching is also the aspect of leadership and mentorship. We cannot overemphasize, of course, that there has been some progress that has been made in making sure that we have women in leadership position, but that in itself is still not good enough. If I look at where I'm coming from in Zimbabwe, if you look at the president, we've never had a Zimbabwean president who is female. The Minister of Health, I don't think so. The chief directors, currently, they are all male. But then when you come, of course, to the permanent secretary, we've had a permanent secretary, Dr. Agnes Mahomba, who is also now the advisor to the president. But also in this room, there are also other many women which I look up to. and who raised the flag for young women. We have got the director, Namibia FETP, MELC. We've got the director of the hosting country, Josephine. Right in front of me, we have Suzanne, the director, FETP, Uganda. I think we are trying in terms of leadership, but we can certainly do a lot more. And I know others out there will start questioning, okay, what is her contribution in terms of leadership? I've had the opportunity of being tasked or given the opportunity to coordinate the program, the ZIM FETP program, as I highlighted, that has seen the graduation of over 100 epidemiologists. And related to that, because I oversee all of the processes and training for the program, we have now been reaccredited with distinction and merit, and that is something that I hold on my sleeve. And I always say to Prof, well, women bring an element that sometimes men don't bring. We bring quality, we bring a level of empathy. I don't know whether you'd have gotten the distinction, Prof, but I think I can take that belt for now.
Yeah. Thank you very much. Yes, that is one thing that we women need to do more often. Speak about our own successes. Well done. Thank you. And I'm just going to move really quickly to Dr. Waziri. So you've talked about how you're amplifying women's voices in leadership. Can you share some of your lessons and what we can learn from your successes?
Thank you. Thank you very much, Dr. Ebere. It's really an honor to be seated here this afternoon to talk about the role and amplifying women's voices.
I'm just going to interrupt for a second and say that I am noting the men leaving the room. Please continue.
Women deliver, is it working? Okay. Women deliver over 70% of healthcare services, like you rightly said earlier, but they lead only 30% of the roles, of the leadership roles. I've been privileged in Nigeria to lead the National Stop Transmission of Polio program. It is a program with over 300 staff that has been pivotal to Nigeria's eradication of wild polio virus. When we started in, okay, let me go back to history. I recall that at a point where my former boss, who was also seated in this room, when he left and I was deputizing, so the position became vacant, and I wanted to apply. A few of my mentors told me, don't go for that position. And I'm like, why? Is it because I'm a woman? And some of those that told me don't go for it are also seated here in this room. So I said, is it because I'm a woman? They said, no, but what if you're not giving? I said, you try. If you don't get it, you move ahead. So as a woman, you have to be a go-getter. We have to be intentional in what we do. When we talk about giving women opportunities, no man is going to give you that opportunity. You have to get it for yourself. So we have to be intentional, we have to go for it, and we have to speak about our successes. We also have to ensure that we create the environment to mentor other women. I'm very passionate. Somebody told me, Andy, you prefer to recruit women. If you come to my team and you're a man and a woman and I need to choose, I'll choose the woman.
Absolutely. Why not?
Absolutely, I'll choose a woman. So we need to be able to hold our hands and carry ourselves together. We need to move together. We can't wait for the men to move us. So when we shout about equity, it's not going to happen by chance. We have to push for it. We have to fight for policies that encourage women into leadership. We have to ensure that women capacities are built, because capacity gives you the opportunity for leadership. Without that capacity, you cannot be in leadership, no matter how we shout. So we have to develop ourselves. We have to develop programs, mentorship forums. We have to carry ourselves. We have to build ourselves. We have to encourage ourselves. We have to mentor ourselves. We have to think of opportunities where women build the younger ones. For instance, we talk about women deliver. We talk about things like community of practice for women in public health. How do we build such opportunities so that there's passion for women to join, and also not just join and deliver, but rise to leadership? So we have to talk about our successes. I'm very proud of where I've been able to lead my team and the successes. If you come to Nigeria, there's nobody that would talk about primary health care, immunization, and polio eradication without mentioning the National Stop Transmission of Polio program, and without mentioning AFENET in Nigeria and in the entire African region. Thank you.
Thank you very much for that. And I think it's important to put the evidence base, because we're all scientists in this room. In that preference for women selection is not just because they're women. We know human resources research has demonstrated that for a woman to apply for a post, she aims to have 90 to 100% of the criteria listed, while men will apply for the same post if they hit 40% of the criteria. Therefore, if you've got a woman that gets to the interview, she's qualified. Moving there, you talked about some of the initiatives that that we can use to get women into leadership, and I'd like to extend that question to Dr. Cynthia Sema from Mozambique to ask what specific measures, again, can we put in place to address the sort of gender disparities, both in terms of not just women in leadership, women in working, but the gender disparities in health outcomes. How do we ensure that women have an equal opportunity to contribute their expertise, but also to be heard by the health system?
Thank you, and thank you for this invitation. I hope that you are able to understand me, because I'm from Mozambique and Portuguese is my official language. I'll just give some briefs. I think in terms of innovation, we don't need to talk about innovations because we know the things. We just need the courage to put in place the things that we know that need to be in place. We just need to have the courage to do it. I'll give 3 points or 4 points. One of the things is that in all institutions, health institutions or even other institutions, it's important to provide some support for females, for example, through maternity leave or any things related to their need as a mother. I'll give one example that happens with me. A few years ago, we had an emergency in Mozambique. It was a flood that affects thousands of people, and we need to deploy field epidemiologists. But at that time, I was in maternity leave. My son has less than 2 months, and I was breastfeeding. I remember that my director, he called me and he said, "Cynthia, I understand that you are in maternity leave. I understand that it's a very crucial time for you, but I need you here because this is being a mess, and I need you to support us because you need to coordinate the teams that go into the field." And I said, "Okay, I understand this need, and I'll support." And he says, "I'll give all the support you need. You are not going to work full-time. You are free to work as a part-time. You are free to bring your child if you want. But I really need you." So it brings me this sensibility that in leadership, he was very support to my need as a mother at this moment. So I think it's one of the things, because we need to create this space to women to be women, even when they need to act in their field of work, especially those who are here, who are field epidemiologists. I know that most of you face very similar situations. I also would like to congratulate AFENET. The board of directors has always been very sensitive to have women presence in the board of directors. So I think it's another way to show how different institutions need to put women in leadership position. So the board of directors from AFENET always was very sensitive to put women in core operation roles. And hopefully next board director maybe will be a woman, I hope so. I'm just challenged. One another thing is that I think my colleagues talks very well that women used to work well with women. Although people don't agree and says that we talk too much and we are very sensitive and everything. So last week, I was able to publish a paper. Unfortunately, we were not going to be able to find in PubMed because it was not published in an index journal. It was published in the Mozambique National Health Journal. And the title of the paper is Mozambique Field Epidemiology Training Program Accreditation, a process led by women. Because we were only women that works through the accreditation. And I remember when I talked with my director and say, we are going to submit our application for the FETP accreditation. He said, but are you sure? And I said, yes, because I have a strong team, I believe. So I published this paper. And I also encourage all of you that are here also to publish and to promote the lessons learned, the good practice that women face. We also have here some partners, some funders. It's also important to leverage the research funding for women because we are really underrepresented and we face challenge to balance the life between being a research, a public health specialist, a mother, and a wife. So bring more opportunities because it's not that we are competing with men, but it's that really we have more things to coordinate. So bring more opportunities in terms of research and public health initiatives targeting women. And also to complete, because I know that you are now just thinking about the lunch, just to complete, one of the things is that mentorship and support, it's also another very important. We try in Mozambique to implement this women mentorship through another women. It's something that I also do. I'm mentoring a lot of women, and women can also leverage another women by mentoring. Dr. Shibesi was one of our pioneers. She was one of my mentors through these years, and I learned so much with her. So please mentor other women. So to finalize my speech, I don't think that we need to innovate things. We just need to have courage to implement things that really works.
Thank you. Thank you very much. And I'm just going to say we did start almost half an hour late, so we actually are within time. But I am conscious that we're between you and lunch. So I'm just going to ask, we will take 2 questions from the field. So while our final speaker is speaking, if you could just come up to a mic, then we'll take a question for you. And with that, I'll go to my final speaker, Jolika Kasonga, who is from Guinea, and she's going to talk to us about how we ensure we create a pipeline for others to follow. Welcome to the panel.
Okay, merci beaucoup.
Thanks very much. I'm going to speak to you in French. I'm very happy to be sitting beside great women. When I listen to their stories, I know that these are women who have succeeded in what they are doing and they are proud of it. I know to get there, they have gone through a lot of challenges. When you hear them speak, there are difficulties that can be on our way, but as a woman, we need to be proud of ourselves. There is a time I read a sentence that says, if you doubt your force, you become doubtful. If you don't have trust in you, as a piece of advice, trust yourself, say, I can do it. Because I remember in Guinea, I was a coordinator on the ground, and the resident advisor found another job. As I said, if I take up this post, can I make it? Can I be an advisor, resident advisor? Because she was taking a lot of her time working more than doing anything. The life of the resident advisor was home, work, home, work. I said, I have children. I have a husband. I've got to have some time for him. Can I do it? But at some given point, I said to myself, I can. Today, I don't regret because I'm saying to myself, what I'm doing now is because I trusted myself. And if I was doubtful then, I could not really get to manage the program FETP in Guinea. Beyond that, I could advise women to consider the fact that as a woman, we need to have the family to our side as well. We manage a lot of stuff, a lot of things. As an epidemiologist on the ground, you need to see that there is balance. We need to balance things with the family, with the work, in a way that you don't fall. If there is a side that is not working, our side will not work as well. This is what I could advise to women who want to be leaders, taking the leadership role, to say, I can. And beyond this, you need to pray. God is there. Before I came, actually, Rachel wrote to me, said, God is with you. Go there. I really loved this because this is something you don't have to doubt. God is there with us. And if God is with us, we can only succeed. This is the piece of advice I could give. And I had as well Cynthia from Mozambique who talked about mentorship. Sometimes I get inspired by women. The last time when I was speaking to a woman who also advised me, I saw that person going ahead. What did they say to me? Beyond what you can have as other things, do your work calmly. Don't look to the left, to the right. What is important is that you do your maximum and do it well. The other things will change later. So this is the piece of advice I could give, to say that beyond all this, we need really to speak to ourselves, because ourselves, we are important as well. If we are with ourselves, that is to say, we are going to succeed. We are going to go forward. You need to look at the environment, the family, the force that you can have from God. This is what I have as a piece of advice. I thank you. Merci beaucoup. Et je ne vois pas qui que ce soit au micro. Nous avons deux personnes, deux questions peut-être.
Panelists here, or the previous panelists could answer from the floor. So we'll start with the gentleman there, and we always welcome male allies, so please. Just a brief question so that we don't keep two people away from their lunch. Go ahead. I'm looking at you. Go ahead. Oh, there's no microphone. Oh, you're standing there. Sorry about that. So while he is getting the microphone, I'm just going to summarize the recurring theme from these two panels. One is we need to role model. We need to model what the change we need to see. One that we're seeing is the importance of mentorship. And the importance of an employer, an organization that acknowledges and recognizes the value of women and therefore enables women to engage. And I think we should take the opportunity to give AFENET a round of applause, because there has been a consistent positive feedback on how supportive they are of women, both in their training programs and as their employees. So we recognize the importance of mentoring, the importance of modeling. We heard loud and clear here that there is no need for innovation. The solutions are there. We just need to go out and implement them. So I think it's really important that we capture that and recognize that we need What we have, what we need, we already have. We just need to be, and as individuals, as women, we need to be bold. Message to men, you're allies, you need to be there. We're not pushing you out. We're just saying make more room for all of us to be there. And I'll take the first question. Please introduce yourself and your question quickly. If you want to direct it to any particular person, then please do so. The mic's not on.
Thank you very much. My name is Derek Masogoere. Thank you very much, Women in Public Health, for the enlightening submissions. My question goes to Ms. Tsitsi Juru. What are your thoughts on the quota system for women in public health training and also in public health leadership roles? Thank you very much.
Good question. We'll take a second question, then we'll get the response. Go ahead.
Thank you very much. Once again, my name is Linda Nyasha Kanzara, and I am from Zimbabwe. I'm happy to say that I have benefited from the mentorship of Ms. Tsitsi Juru in the Zimbabwe FETP. I have two questions. My first question goes to the panelist from GIF. I just wanted to find out whether there has been any active effort to encourage women-led researchers, both in the implementation of the researches as well as the publications. In your submissions, I noted that it was more general and trying to create a balance, but there is no denying that we still need to bridge the gap that exists between the men and women in science.
One question.
Okay.
One question. Thank you very much. So we'll take that. Tsitsi, the first question is to you. And Dr. Sheba, will you be able to take your question? There you are. Okay.
Thank you very much for that wonderful question. I think maybe it's coming from the fact that in many universities now they have the quota system where they say a certain percentage is to go to women, and I suppose your question is how do we feel about that as women? I think it's a good idea to start with when you have a great inequality and in accessing training or even getting jobs in the workspace. But at some point, I think there has to come a point where we also have to compete for those spaces without the quota system, where we are taken on board based on our competencies and what we can do. The danger with the quota system in the workspace especially is that women may be looked at in such a way that, oh, she got in because of the quota system, and not look at us that we are well able and capable of actually doing the job. So it has its own advantages and disadvantages. It has a place for it where there is a lot of inequality, and where there is some level of equality, I think women should show up and show off and take up the space and compete for those roles and spaces. I'm sure even other women here can respond to that very same question.
Yeah, I'm sure we can, but we're conscious of time, so let's just take the second question, and then there you are, and then we'll wrap it up. I'm afraid we're not going to be able to take a third question because we're well over time, and I don't want to keep people from lunch, you know. Food keeping warm for too long, and you know, gastrointestinal infections and such. Please.
Okay, thank you very much for that question. So, as I mentioned, as Jeff, we've not put out any specific interventions that targets the females. However, if anyone has worked with me, I think you'll notice I have a natural inclination to mentoring the ladies more, and I'm always available to support both the males and the women. But in any case, it's always the women who always come for help. Rarely do the men come up to ask for help. Yeah, but that's something I'm taking back, and we'll try and figure out how to create a space to support the female scientists in writing.
Thank you. Thank you very much. And with that, I'd like to thank all our panelists, the ones on stage now and the previous set. Thank you very much. I have one final recommendation from AFENET. I've had the privilege for the third year in a row leading a track on women in health for the Conference for Public Health in Africa. And we started as a side event for 1 hour, and we are now a whole track. And if there's anything we're learning from this session is that 1 hour is not enough. So I am going to task AFENET to say your next conference, can we have a little bit more time to address women leadership issues? So with that, I'd like to thank all my panelists, thank AFENET for inviting me to participate in this very important session. Thank you all very much. I think you can now go for lunch. Are we staying for pictures? Can we get the first set of panelists back as well? Thank you. Can I have the first set of panelists back up for the official photos, please?
It's about One Health and laboratory strengths initiatives. For this session, we have 3 presenters. And the first presenter is Professor William Bazeo, who is going to talk about building the One Health workforce for announced global health security. I think most of you know Professor William Bazeo. He's a retired professor from occupational medicine. He has a master in medicine, a doctor in philosophy, and is an honorary doctor of science degree. He has an honorary doctor of science degree, doing the recognition of his service to humanity in public health in Africa. He's also a certificate in authentic leadership development from the Harvard Business School. Professor Bazeo served at Makerere University for more than 25 years in various roles. Currently, Professor Bazeo is the Chief Executive Officer in the African One Health University Network. He also the Chief Party and Laboratory Director for Resilient African Network and Director of Africa Centers for Tobacco Control. He leads a network that brings together 19 universities in 10 countries in East, Central, and West Africa. These networks works together to develop a workforce with disciplinary barriers and through its regional platform. He also serves innovative training and research service to the whole African. Professor Bazeo also serves on several national committees, and he also won a number of awards. He was awarded a Lifetime Achievement Award by Heroes in Health Award for leading efficiently and in responding to the community health emergencies. This award is a gold medal, highest civil honor of Uganda by the President of Uganda in 2018. He also is the winner of African Continental in Education and Training Award by the CEO Global Titaniums in 2018. And he has also won the award of Country and Regional in Education and Training by the CEO Global Pan-African in 2018. So in addition, Professor Bazeo is also known as one of the leading founding members of AFENET. He's a physician, public health specialist, a researcher, and he published more than 100 papers in several areas, including occupational health, healthcare, financing, leadership, and One Health. Welcome, Professor Bazeo.
Good afternoon, all of us. I want to, since most of us are still at lunch, I'm going to have a very short, quick presentation, so that those who come, they find I'm done, because they enjoyed the other session. But I'd like to start by thanking the AFENET leadership for putting this conference together. Thank you very much, Simon and the team. And I think give them a clap. Because if I don't thank you, you may not be thanked by anybody. Because we have been enjoying, at the end we shall finish and say bye-bye. I want to thank the previous speakers. those that I attended since yesterday. The message has been very clear, it's loud, and it is very encouraging that we are moving in the right direction. Most of the things I had prepared to say have been said. I don't re-emphasize some of them, but I add in some few to remain as our challenges as we leave this place. I'll give you a small brief. When AFENET started, we thought it was going to be very small, but we had a larger vision. And I think Simon and Tim, and I have told him, they have lived that vision, and we have no doubt. Many of the things that were said yesterday and today, people keep talking about challenges, and they're the same. In research, in institutions, in AFENET as a whole. But I have one question, which I want to first give you so that you answer as we leave this place. Why do we have challenge of funding? Why? The answer is very simple. The funders are not with us. We are now talking science, we are talking our findings, we are talking what we are. But the funders are not here. So looking at what Dr. Ebere said, we need to go and find them in their boardrooms and we go on the same table. We will be uninvited guests. And I can tell you, they will accept us when we go. There is a book I want all of us to read. It's a small book, you can read it, I think in about 16 to 20 minutes. It's called Ask Without Fear by Mark Pittman. How many of you have read it? Ask Without Fear by Mark Pittman. You can Google and buy it on Amazon and so on. That book says, why do people not give? Why are these governments not giving? Why are philanthropists, as Dr. Berry said, not giving? It says, nobody gives unless he or she is asked, either verbally, in writing, or by gesture. You don't walk around and you meet somebody and you say, this one needs money for lunch. When you have money outside this hotel. No. You must see something in that person that you want, that is asking. So now that the problems are many, because we have not gone on them head on, that's why we come here to lament. So the topic they gave me, since most of it has been said, why do we need a One Health workforce? When did we start needing that One Health workforce? Is it from the beginning? Did we know? Did our other predecessors know? Yes, they knew, but they didn't know what it was called. And they was thinking of multidisciplinary research or something of that nature. I want to take you back when we used to do research, write proposals, and people would say, at the end of the proposal, they are scoring how you are going to do the M&E. If you remember, M&E was always written at the bottom, at the end of the proposal. Now it is at the beginning. Things have changed because now we have more knowledge to know what do we need, how do we monitor it. You can start writing a proposal right from the budget. In the past, you'd start with the proposal, then at the end, then you go back, paragraph, this will need this much. Things have changed. So we have the mega trends, and please, I will not read what is on these screens. We have the mega trends. They are very clear. The mega trends have caused those impacts. The complex health challenges, the epidemics and pandemics. And what we are going to talk about is what are those implications? Those are the ones that have caused us to look at the One Health workforce. When you look at that screen moving, we have been talking about population change. The population is increasing rapidly. Somebody was here saying that they have reduced the numbers of people to have 4 instead of the normal 7. But then we have now increased on the number of people who are getting pregnant when they are much earlier. So when you look at that, you see that by 21, 2100, 5 world's 10 largest countries are projected to be in Africa. But you can see how the things are moving. Where in the population in Africa is low, it keeps moving. It is as if Africans were being put on a fattening diet to deliver as fast as possible, as if we are trying to catch up with China. But don't tell them, because some of them may not like me. So these are the countries that we are going to have that are going to be among the top 5. We must plan for them. And when you look at them, those countries already have problems, and they are here. They are represented here. If you didn't know, if your country is among those which are circled, you already have a problem. But then the percentage of babies, as I said, Gladys was talking about children. If you look at the percentage of children, 2100, half of the babies born worldwide are expected to be born in Africa. And we say that we have reduced them. You can see Asia was high, it is coming down, and Africa is going up. But this is the most interesting graph that all of us know and have seen, and you have seen it elsewhere. All these diseases that you see have been coming and killing people, but the population is not going down. So it means we must do something, because the population will continue going up. Even COVID came, many people died, but the population is going up. We are not going to have to call in COVID-19 3 times to reduce the population. We must continue to plan. But before that, there is I wanted to show you the last ones where there is question mark. I think your machine is not working the way I wanted. What are those diseases that we are going to have? Can somebody predict? Somebody yesterday said they will be zoonotic. No. Yes, that's okay. We are talking about monkeypox and polio. This could be our next problem. This could be our next problem. Some of you who don't believe in artificial intelligence, you Google there, you go to and ask what is coming next. You try. People don't want to go there because they say, I don't want to be influenced by this thing is a sham. It's not. That artificial intelligence, that, I apologize, that is a busy screen. But those small things that you see around that artificial intelligence, Google them, you'll find them there. And now, when you go back to yourself, you say, global health. Global health, you are looking at the public health, you are looking at climatic change, you are looking at biodiversity, you are looking at the water and security, air and weather. These are the things that we need to plan for. AFENET has been there, and I've been telling Simon, we need now to start strategizing. How do we develop, grow a culture of bringing out graduates with skills and competencies to address these? You look at them, you think that, oh, maybe they were there, but they were not there. So the vision for One Health as a game changer. I know, and some of you may know, that the first person in USAID to talk about One Health, I don't know how many of you know him. He was called Dennis Carroll. And he acted, you know that he was the one. And he's the one who acted that film which predicted COVID. Correct? It was, some of you watch those films. But when you want to use One Health as a game changer, what are you looking at? You are looking at inter-coordinated, systematic, multidisciplinary, transdisciplinary, sustainable, comprehensive, holistic, total health. Many people want to stop at statistics, others want to stop at epidemiology, but for us to be able to save our communities, we must look at all of them. Social scientists, vets, wildlife, public health, we must do the same thing. We must involve the communities to know that there is a problem. So that when we talk about community diagnosis, they know, they can tell that this is anthrax, this is that. And that's what I'm talking about here. That we must unite all of them. Whether we are in Dubai, where there are those skyscrapers, we must talk about one health. We have had these recent global events and all of them, and I will not go through them. But what have they taught us? The Ebola in West Africa, Zika virus, COVID-19, what have they taught us? Many people don't want to talk about global health because when you say global, they say maybe it will be in China. No, global is you. Global is Mombasa. And these things, when they happen, they affect all of us in air, in water, and environment. And we must plan for them. And scientists who are here, don't come here for the sake of coming here. What is it that you have learned that you're going to embed in your own programs? What does a One Health workforce look like? The technical competencies, having cross-sector competencies that a social scientist, a nurse, should be able to make a diagnosis. Not to say that you wait for a physician. These diseases that we have been suffering from, this hypertension and so, they are going to go down because the other ones are going to increase so fast that we need to look at them. So at AfroHome, we are talking about these three things. You need the people, you need the right environment, and you need the right approaches. So quickly I'm going to say, what have we done to prepare for global health security using One Health? In-service professionals, those who studied long ago, must they know what is current? Yes. So we have developed programs to train in service. And these programs, if you Google, you'll find that we have a One Health Workforce Academy, OHWA. This academy is opening its windows. We've been training quietly. We have now more than 1,400 people who have applied for training that we will do free, that is sponsored. But after that, we are going to have real paying so that you learn, you get certificates, you get diplomas and degrees, because our academy has been accredited in Uganda, in East Africa, and internationally. And we will now be training. So your people, prepare them so that we train them. That's why you see the platform where we have put those materials. The academy program is accessible to the wider population. At the beginning, it's free for those programs, and I want to encourage you. Please go on and register. Get your students, get your colleagues to register. These materials will be available. We have academia to run this program all over Africa. From the 11 countries, we have trained academia that have the skills and competencies to train people. Please do encourage people. Those are the areas that they'll be looking at. We have accelerated training, we have research, we train for community practice, we train on One Health, experiential learning, we have sites that we have accredited in the different countries, and they have facilitators. And we have the student One Health clubs. If you come from a university, please apply and become a member of AfroHun so that your students and faculty can benefit from this. Students from HAS, students from MOI, students from DRC, Kinshasa was there 3 weeks ago. They talk One Health. When they go to the field, they talk One Health. They are not necessarily from the School of Public Health or School of Medicine alone. The other thing we have trained, and I've said it in passing, trained the faculty and trainers. Preparing for the global health security, we have more than 1,300 faculty trained for a long time that they can deliver these materials to the students. We have done retouring for them. We have done instructional design training so they can actually design their own programs, and we have curricula that has been accredited. We have the pre-service. Those are the students that are in school. And we have, through these universities that we work in, though that we support, looked at their curricula. How do we influence it? How do we change? They have, some deans are here, they will tell you that they have actually revised their curricula to integrate One Health approach. We have also some small grants that we give students to do research and some faculty, junior faculty. This is all courtesy USAID. But we have also quietly acquired, as a way of sustainability, other partners that bring in resources. Right environment, you all know. Those are the things that you need. Real-time workforce capacity. Now, when COVID came, we hadn't prepared for it. So it was, if you remember, and in some countries, our One Health graduates from our program are the ones who did work in the COVID, in the countries that we are in. And we are grateful that ministries at that time, when we contacted them, they brought them on board because they were well trained. We have approaches that deliver those results, and I know I'm not doing very well in time, but strategic engagement of top university leadership. Ladies and gentlemen, don't run whatever you are running as a project. Every time you are doing a project, look at it as a program. Therefore, introduce it to your leaders, the university top leadership, that this is a program. Because a project ends, a program doesn't. So when you start a project and you make it a program, you are more likely to get funding from even your own country or even your university. But if it is a project, it has ended, close the show. AFENET started as a project and immediately became a program. That's why people put in intersector coordination. No vet boss wants to go in a meeting called by a public health specialist. They all want to be big. Yes, they are big, but they are big in other things, but not in disease. So you need to find a way. How do you bring them together? Resource constraints, I've talked about gender. We make a small presentation. The next time we go back, they say, they said this, and they'll help us. But if we send a paper there, it means nothing. AfroHun has engaged ministers at East African Community. We have engaged ministers at the AU, and now East African Community has given us a whole chair to desk, they call it chair or desk for One Health. We hope to get one in the African Union so that we dream for every country in Africa on One Health. Sustainability, community engagement. How do we involve the communities? We have now a program that we have prepared. I have one more slide. Risk, communication, and community engagement. This course is to train the community leaders and the professionals so that they're on the same page. And we have done that for 2 subjects initially. For rabies, you know why? Because any time we shall have an outbreak of rabies, I don't want to say where, but we know that it's coming. And the other one is for COVID, although some people don't want to talk about COVID, but COVID is like any other viral infection that is going to come and cause us problems. Data sharing. Many countries we've found in AFROHUN don't want to share their data with others. We have tried to manage that. When you share, because you share a border, supposing the disease is at the border and you hadn't shared data. We have this as the last but one, but this is the questions that answers the next one. Call to action. Is the sub-Saharan One Health vision aligned with the future? We have been talking about what we are going to do, what we are doing, but is our One Health aligned? What skills does the future require? What resources do we require? That's the last slide. That's the last box that was with a man who had questions in his head. The answers are there. For One Health to make any meaningful contribution to our countries, we need a holistic approach to solutions. We stop segregating ourselves that this is a CDC project, this is funded by GIZ or World Bank. All these programs, let us put them together. As Simon, I know you have projects funded by different organizations. Let all of them talk the same language. Interdisciplinary collaboration. We need every discipline. We need the gender. In AFROHUN, we are, I think, very fortunate. The largest number of participants is females. And it was by design. So they call me a female what? But I know that you like it, but it's okay. One Health research and innovation. Many people write proposals for funding. Put in One Health research. Involve everybody. Policy and advocacy. I've talked about AU and the East African community. We have a meeting with ECOWAS soon. The ministers will be there. And please bring everybody on board. Lastly, we have the transdisciplinary and capacity building plan that we train you, skill you as you are. Whether you work in the community, whether you work in the city, we train you and make you a One Health convert. Ladies and gentlemen, I want to believe that what we have had this whole week, if we put it together and we make that as a lump sum One Health, we will do a lot better to alleviate the problems of our communities. Thank you very much.
Thank you so much, Professor William Bazeo. I know that we have questions for Professor Bazeo, but I would like to request to hold the questions we are going to make at the end to save time for the entire sessions. Our next presenter will be Dr. Eliseus Rutemberwa, who is going to present the linking field epidemiology to laboratory biosafety and biosecurity, going beyond the cause of outbreak to the intention. Professor Eliseus is a professor of health system management in the Department of Health Policy, Planning and Management at the School of Public Health at Makerere University. He holds a PhD from Karolinska Institute and the Makerere University. He has been a field coordinator for Masters of Public Health, where he also provides support training in Kenya, Nigeria, among other FETP programs. Before he joins the university, he works as a medical officer and hospital director in one of the rural districts in Uganda. He was involved in the implementation of the decentralization policy and was one of the first head sub-district directors when the policy was being implemented. At the School of Public Health, he has worked as a consultant for WHO, European Union, USAID, CDC, Ministry of Health, and other national and international organizations. He has coordinated district-based research for many years and has been involved in action research on how information from research is translated into policy and practice. Professor Rutenberger has been presented AFENET on the Global Partnership Initiative, Biosecurity Academy for Control Health Threats, a biosafety and biosecurity capacity building project led by the Bernhard Nocht Institute of Tropical Medicine from Germany. Professor Lizeus, welcome.
Good afternoon, ladies and gentlemen. It is a pleasure to meet all of you. Some I have known for decades and others for a few years. And let's see what we can share. My topic is as you see it, and those are my names. So what you see on the screen is what is called the Museum for the Future. It is in Dubai. And what is written on in Arabic are three statements, and one of them is that the future belongs to those who can imagine it, design it, and execute it. Please note that they don't say those who can dream about it. So it is imagining. And imagining, you draw an image. So these are my 4 take-home messages. 1, we must prepare for outbreaks beyond natural occurring events. The outbreaks we receive nowadays may not be those we have been used to. 2, we need to build resilient systems which go beyond detecting, responding, and controlling to predicting and preventing. And 3, and this has been echoed many times, there is high mobility, rapid urbanization, and a demand for research laboratories, which should make us do our training differently. The training we received 20 years ago is not the training you residents should be receiving now. And lastly, we need to go beyond ourselves. In fact, beyond even the academia and include the biosecurity organs. So some of you have seen this rainbow type of colored thing. Now, it may not be very visible to you, but it is actually a spectrum for biosafety and biosecurity. So the first 2 boxes talk about the naturally occurring outbreaks. And those are the ones we have been mostly dealing with. Once in a while, we have also dealt with the accidental ones, like laboratory accidents and maybe those of lack of awareness. But we need to be prepared that in the near future, or those of us who have been more advanced, we have also seen those outbreaks which are intentionally caused. And that is what will not escape. So to build a resilient system, we need to do 6 things. 1, we need to do prediction. That's why we do surveillance. We need to prevention. That's why we have biosafety, and that's why we have barriers. We need to do detection. We need to respond and control, and for those who survive and have other challenges, we do rehabilitation. But you note that we have been mostly, and you will hear from what people have been talking, we need to detect very quickly. This is not the future. The future, we need actually to predict and prevent. Because by the time you detect, the victim may die. And behold, it is not you who will be the index case. So how do we predict? We have been used surveillance, and we will do surveillance for cholera, for malaria. They have talked about risk factor analysis, risk modeling, making forecasts. But we need to go there. And there are two cases here. This year, actually, the police in Germany managed to track people who were making ricin and cyanide. These are toxins which are very lethal. And they had to use intelligence methods. And you know, like 3 years back, somebody actually sent a mail to the then president of the US. And these things have come, and they may not go away. And now I want to challenge the program managers who are not necessarily in this room, but in this conference. You have been leading a program and it is 20 years old, but you are still doing the same outbreaks in the same area. Why don't you create a database for all of them and then predict and prevent? And I think this is something that we can move forward. Of course, what we have been predicting, the natural one, the avian flu is brought by birds, but birds take days to cross. And this is a bird which was tracked this year from South Africa to Finland. It took 42 days. Now, how long do they take? That slide shows you the density of global traffic. And you can see on the left, there is the air traffic density. And on the right, that's actually a screenshot of the first stages of COVID. So you would see that actually COVID followed the air density. And so it is critical that we need now to be thinking global. What about outbreaks from laboratories? So this slide shows you some outbreaks of Ebola. We know Ebola occurs in Africa, but maybe many of you are not aware that there have been outbreaks of Ebola in Europe. In 1976, there was one in UK. In 1996, there was one in Russia. In 2004, there was also one in Russia. And in 2018, which is 5 years ago, it was in Hungary. And as you know, one case of Ebola is an outbreak. And this is one of the outbreaks, but maybe that which can be seen in a public space. There may be others. So having high-level laboratories also is an opportunity to have those outbreaks. So when we talk about prediction, we should move from predicting the predictable to predicting the unpredictable. So we have to create partnerships with security organs. We have to enhance our laboratory capacities to analyze environmental samples. For example, be able to know that if there are anthrax spores in a certain place, we are waiting just in time for another outbreak. We have to increase our capabilities for using big data and artificial intelligence in surveillance. And we also have to increase our awareness of laboratory safety. For example, if we reflect back, how do we have our laboratories, be small, be big, dispose of their laboratory waste? And then maybe they are creating some place where we'll be getting the next outbreak. So, prevention. We are used to this, and when COVID came, that's where we went back to. But of course, we know that towards the end, we had to do vaccination. But what happened? In terms of vaccination, the countries that generate the vaccines started vaccinating themselves. And until when they got satisfied, then they released the vaccines. So you will find that in our countries, every vaccine came after the other ones were satisfied. And that's why the Africans have been asking, to generate their own vaccines. And you will see those cases. But manufacturing a vaccine is not a question of manufacturing a bottle of beer. And here, this is one, there are 9,000 different materials sourced from around 300 suppliers across around 30 different countries. So manufacturing vaccine is very complicated. However, the vaccine manufacturing also needs a trained workforce. And trained workforce, they are not somewhere where you go with the man and buy. You have to train them. So that is what we need to go through. We need to have the infrastructure. And this is a 2021 section about the BSL force in the world. And as you can see in Africa, at least from that source, there are 4. But where are they focused mostly? It is in Europe and America. Now, what is also said is that of the approximate 60 labs worldwide, at least 20 have been built in the last decade. So it's not only Africa which is fighting to build BSL-4 labs. It is also even other countries. And then most of these are located in urban centers where the virus could spread with ease. Now let's go to urbanization. I think you, from the previous speaker, you saw the population of the world. This is another way of depicting it. The population of the world in billions is increasing, and the less developed countries will be having a bigger share. On the right, that is the urbanization, but this slide gives you the urbanization in various areas of Africa. So you'd see that East Africa has been very constant in urbanization, but the gold medal goes to Central Africa. In the first years, it really urbanized heavily, and West Africa didn't urbanize that much, and South Africa, I think for them, they did it a lot, and they have been there. Now, this is a pictorial way of doing it. Let's see the figures. These are the estimated number of people in some of those selected countries. And if you want to know how urban centers have increased, just look at this. Within the last 70 years, Kinshasa has increased 113 times. It beats, of course, Dar es Salaam. Those people from Tanzania, sorry, you are not the best ones, but you are second best, 80. And then the others, of course, and this is just the towns. But if we include the environs, then you can see that maybe we need to take over and learn from Singapore, which we heard that is doing urban field epidemiology. Because in the next 20 years, we are really dealing with urban epidemiology. So what future are we imagining? The outbreaks we are having are shifting from the natural occurring ones to laboratory accidents, all possible sabotage. The accidents are now global. You cannot run away because this is a virus that has come from Wuhan. You have to be prepared not only for Ebola, which is coming from a forest, but also from another virus which you even don't know. And now it is faster for outbreaks to spread from one continent to another. So here we are. We have been focusing on the first 2 blocks, but now we need to get into the next section. And that's why we need to make sure IHR 2005 is very clear, dual use, the one coming from research, investigating toxins, environmental labs, big data, artificial intelligence, biosecurity, cybersecurity, and so forth. And if there is anything else that we need to pick is that we need to train our world field epidemiologists, and not just African field epidemiologists. So we cannot ignore the issue of intentional outbreaks. As we get into big labs, we have to get into that. And the increasing air travel in Africa is also linking us more. So the map for global density will be different in the next few days or a few months. Then the African countries also are vying to have these BCL forums. They come with opportunities, but also with the challenges. So looking ahead, we are not only disease detectors, but disease predictors and preventers. And this is the mentality we need to have for the future, because sometimes what you detect is already killing very many. We need to engage security organs, as we need active and continuous partnerships. We need not to wait for outbreaks to occur. When they are intentionally generated, we need to prevent them. And all these need laboratory capabilities. So our take-home message again, outbreaks go beyond the natural occurring ones. I need to prepare for all of them. We need to go beyond detecting, responding, and controlling to predicting and preventing. High mobility, rapid urbanization, and demand for such laboratories predisposes us, but now we need to train for that, and active engagement with biosecurity organs needs to be done. And I end with our quote again. So the future is with high population, high urbanized, with high connectivity. So we need to predict outbreaks and prevent them. And we execute that by increasing our laboratory capabilities and also being able to support generation of vaccines so that we are not at the tail end. So, Chair, I think we must imagine, design, and execute the future by linking field epidemiology to laboratory biosafety and biosecurity. And we do that when we go beyond the cause of outbreaks to the intention. So we need to move from predicting the predictable to predicting the unpredictable. And we need to train the world epidemiologists and not just African epidemiologists. And I thank AFENET so much. Dr. Simon and your team, you have shown. And you have helped us to grow many. I thank my teachers. Those of you who are here know that I'm thanking you. And I also thank my students, because every time I facilitate, I learn from you. Thank you very much.
Thank you so much, Prof. Eliseus. Okay, so I was informed that the third presenter is not online, so we'll move on to the question sessions. We have, it will be in video, sorry, I apologize. So the third presenter is Dr. Benjamin Park. Dr. Benjamin is the Global Fund Senior Specialist on Infection Prevention and Control and Antimicrobial Resistance on the Pandemic Preparedness and Response Team. At the Global Fund, he provides technical assistance to countries to request, program, and implement programs using the Global Fund financing for the pandemic preparedness and response and the health systems. Prior to this, he was the Chief of International Infections Control and the Healthcare Safety of the US CDC. He has over 20 years of experience at the CDC as an epidemiologist in both domestic and global programs. Dr. Benjamin will talk about the Global Fund Pandemic Preparedness Initiative, so we'll follow him virtually. Thank you.
Hello, everyone. My name is Ben Park. I am at the Global Fund as a senior specialist on infection prevention control and antimicrobial resistance. I work on the Pandemic Preparedness and Response Group. And I'm here to talk to you about the Global Fund's pandemic preparedness initiatives. So these are new initiatives by the Global Fund, and I think they're really exciting, and I'm really excited to be here to talk to you about them. I think there's a lot of tremendous opportunity that can result as of this. So apologies, I'm not on camera because I have some technical issues here with my camera, but I will be hopefully available on camera after this recorded session for some questions and answers. Okay, well, let's start talking about the Global Fund. Who is the Global Fund? I think many of you have heard of the Global Fund before, but the Global Fund is one of the largest donors and financing organizations for global public health. Primarily, it works in HIV, TB, and malaria, and it has a long track record collaborating with many countries on the African continent, and especially in the areas of HIV, TB, and malaria, as well as, of course, the PEPFAR program. Well, one thing that happened, as we can all remember, is the COVID-19 pandemic. This was something that really, in addition to affecting public health everywhere, affected the mission of the global health, the mission of the Global Fund, because the Global Fund realized that part of its core mandate of delivering HIV, TB, and malaria care was disrupted by the pandemic. So the Global Fund provided some critical assistance during the COVID-19 pandemic, particularly for health systems. About $4.4 billion have been approved for through the Global Fund's COVID-19 response, and those resources were programmed at over 100 countries. Over 75% was for reinforcing national COVID-19 response bodies and programs, and over 12% was for making urgent improvements to health and community systems to fight COVID-19. In addition, a fair amount of resources were targeted towards mitigating the COVID-19 impact on HIV, TB, and malaria programs. Well, the Global Fund, of course, realized that HIV, TB, malaria can be affected by pandemics, and it can be affected by health systems, and that in order to meet this challenge, that the Global Fund needs to adapt and adopt additional components that would be related to pandemic preparedness and response and health system strengthening. So the new fund, the new strategy for the fund for 2023 and 2028 emphasizes the importance of health systems in pandemic preparedness, The primary goal, of course, to end HIV, TB, and malaria is underpinned by maximizing resilient and sustainable systems for health, or RSSH. In addition, in the new strategy, there is a new evolving objective called supporting pandemic preparedness and response, or PPR. The Global Fund's pandemic preparedness and response investments will align with accepted normative frameworks such as the JEE and National Action Plans for Health Security, working towards measurable progress in these goals. So the good news is that funding for pandemic preparedness and response will be available and has been available this year through both two things called GC7 and what's called C19RM, or the COVID-19 response mechanism. So I'm going to talk about these two different buckets of funding because it's really important to understand. So GC7 is the Global Fund's core allocation that's aimed at HIV, TB, and malaria. This is the $15.7 billion that was approved for 2023 to 2025. And these grants are coordinated by something called a country coordinating mechanism, or CCM. And I'm going to talk about these CCMs, but they're very important to understand how the CCMs play a part in the overall financing structure. So that's GC7, that's the core allocation. The second piece, which is really exciting, is called C19RM. C19RM, as I mentioned, is the COVID-19 response mechanism. And that's emergency funding for the pandemic. That was the $4.4 billion that was initially approved for the COVID-19 response. But with the evolving need and the evolution of the pandemic, these funds have been extended until the end of 2025 with a shift towards health systems and pandemic preparedness. And I'm going to talk about that, what that looks like in a couple slides. Now, in addition, just like GC7, the CCMs, the country coordinating mechanisms, coordinate the C19RM funding requests. So this is important, obviously, in order to be able to access resources. So let's talk a little bit more about C19RM. So as I mentioned, C19RM, in C19RM, there has been a shift, whereas because of the evolving evolution of the pandemic and because of the recognition of the need to shift resources towards pandemic preparedness and response, C19RM has also been shifted towards health system strengthening, or RSSH, and pandemic preparedness. The deadline also has been extended for C19RM by board approval to the end of 2025, so about 2 more years of funding. Now, because there are significant uncertainties about the evolution of the pandemic, what's important is that C19RM remains flexible and agile. So while there remains to be resources to be programmed, it's important to remember that there's also flexibility and agility that's built into the system. So what that means specifically is that for something called reinvestment, there's approximately over $1.5 billion still to be programmed. And for portfolio optimization, about $320 million. So what do these terms mean? I'm going to talk about what these terms mean in a little bit. But suffice to say that combined, there's close to $2 billion still remaining to be programmed towards pandemic preparedness and health system strengthening. So that's great news. So that's excellent. What are the areas we're focusing? C19RM has 5 overall focus areas, and you can see them, they're listed here: surveillance system strengthening, laboratory and diagnostics, human resources for health and community system strengthening, medical oxygen respiratory care and therapeutics, and health product and waste management systems. Now, of course, FETP covers a lot of these different areas. So FETP, of course, there is a linkage between FETP and surveillance system, between laboratories, diagnostics, and of course, most importantly, human resources for health. Human resources for health and community system strengthening is probably the strongest way to link to FETP, and clearly FETP fits within many of these overall focus areas. So that's great news. Okay, so now that I know that there is money, and I know that there is an extension of C19RM, and I know that FETP can fit within a lot of those areas, which activities specifically can be funded? So these are some example activities, but the important thing to know is that the example activities are broad. And these are all outlined in something called a technical information note. And the link to that will be at the end of this presentation. But the example activities are broad, and there are many things that can fit within the funding envelope. So what's important is that countries and FETP programs or other funding requests need to be prioritized considering sustainability, especially linkage to normative structures like National Action Plans for Health Security and JEE and SPAR. So these are a couple of the different categories. As you remember, there are those 3 categories: surveillance, laboratory, and HRH, where FETP can fit very well in. And these are the different types of activities that would fit within some of these different lanes. So, of course, strategies, policies, guidelines, surveillance operations, analysis and interpretation of data, monitoring and evaluation systems, Sentinel laboratory capacity, improving laboratory capacity so that they can be engaged in Sentinel or other types of surveillance systems. Reference laboratories, whole genome sequencing, biorepositories. These, of course, are laboratory specific, but they can be very useful for FETP programs. Data systems linkages, either laboratory data systems or data linking laboratory to epidemiological data. These are all critical things that are in scope. And of course, FETP fits very well in human resources for health. And many of the activities in HRH can fit very well, including training, quality assurance, quality improvement. And I know, of course, mentorship and supervision is critical for FETP, and of course, that's included and is a main area in HRH. And of course, outbreak response. All these areas are things that can be funded. They just need to be elucidated in the funding request and aligned to the different types of technical information notes and the funding request. But then, of course, as I mentioned earlier, it's really important to align these different funding request activities to normative guidance, either through frameworks like the JEE or the SPARS, National Action Plans, or National Action Plans for Health Security. Okay, so that's what can be funded. How do you actually get funding requests in? Well, this is kind of the tricky part. As I mentioned before, there's something called a country coordinating mechanism. And that's really the Global Fund body in country, the Global Fund body that coordinates all of the Global Fund funding requests. And that body is really the responsible one that you need to engage with. The funding requests are prepared by these country coordinating mechanisms with, importantly, the support and input of key stakeholders throughout the country dialogue process. So this is an example timeline of what would happen in a typical funding request cycle. And you'll see here the area in green, which is during the period of the funding request development, there's something called the country dialogue process. This is where multiple different stakeholders are supposed to come together and inform the funding request that will eventually be included by the CCM. So there's an opportunity here to be engaged either through the country dialogue process or even engaging other partners, including the EPI directorates, laboratory directorates, other technical partners, even the private sector, and especially, of course, Ministry of Health. Then these funding requests will, of course, be reviewed by the Global Fund, and then grant making will ensue after that. Okay, so what are the funding priorities, and how do we define them? Well, as I mentioned, EPI directorates might be the best position to coordinate these priorities. But you can imagine that these priorities in the funding request will touch upon many different areas of the government and will include groups like the NPHIs, laboratory sectors, infection prevention control, human resources for health, and of course, HIV, TB, malaria groups. Now, the country dialogue process is really important because it does complement, but can also supplement the coordination. And this is really important. Country dialogue is also important because it allows the inclusion of different activities that may not be included in strategic plans. And that can be based off of the factors listed here by changing EPI context, lessons learned, or changing needs. But it's important, of course, to engage the CCM and engage the partners so that the funding request can reflect what the key priorities in country are. Okay, well, what's really important is that you get engaged now. If you're interested in accessing some of this funding, first, you need to understand what the Global Fund is prepared to fund. And of course, I talked about that, but you can also look at the resources on the website. The next thing is to engage in the country dialogue process. You need to express your interest in funding for FETP and collaboration with the different partners in country. And especially engaging key stakeholders to help take some of these priorities to the CCM so that the CCMs, these are the country coordinating mechanisms that help to develop the Global Fund funding request, they need to know about your request. They need to know about your priorities. This is oftentimes easier said than done, but it's really critical. You get in front of the CCMs and you get in front of the responsible bodies for those funding requests. Of course, your proposals need to be ambitious and realistic. And of course, they need to be done in collaboration with both the CCMs and another group called the principal recipient. The principal recipient is the group that actually receives the money and is responsible for implementation together with other partners. As I mentioned, it should be based on national action plans, national strategic plans, of course, aligned with the Global Fund priorities. And then, when in doubt, assume that activities are eligible if they're well justified and aligned with strategic plans. Well, okay, that's great, but is it too late? No, it's not too late. I know a lot of this process has been ongoing already. And if you look at some of the timelines, especially on the web, it might seem like you've missed the bus, but it's not true. Well, it's true that the Grant Cycle 7 is underway, but there are still opportunities, and the opportunities really are in the short, medium, and long term. In the short term, there is opportunity for reinvestment, refocusing, and reshaping the grants that have already been approved. In the medium term, there may be more waves of C19RM funding. Some of the funding that's been awarded might go unspent, and there might be an opportunity to request for some of that money in the future. And then in the long term, it's important to know that, these changes have been laid out in the Global Fund strategy, and that even though there may not be some short or medium term funding, there might be long-term opportunities for the next allocation period in GC8. So it's important for you to communicate the priorities to the CCM so that they know about. Okay, well, here are some key links for you to see. I think these hopefully will be available, and you can read about what they are and the links here. But I've run up now on time, so I'd like to take any questions. So I'm going to stop recording here, and then hopefully I'll be live. Thank you all very much.
Thank you so much, Dr. David, for this amazing explanation about the process of the Global Fund Preparedness Initiative grants. Now we are running out of time, and we can only have one question per panelist, unfortunately. So I would like to request we have 3 micros, but I see a lot of people standing up, but we will not be able to take all the questions. So please, we can start.
Thank you. My question is for Professor Eli. Thanks for your thoughts on the future epidemics or the future outbreaks. My question is, do we have a surveillance system that helps us to detect these accidental infections? Because, of course, accidental infections are what could become an accidental outbreak. So do we currently have a system that helps us with that? I know during COVID, there were some labs that probably 50% of the population got infected. So, but do we currently have a system?
One more question. Prof, you can answer.
Thank you very much. I think the answer is known by everybody in this room. We have a system and we don't have. We have a system because there are some rudimentary surveillance system, but those to get laboratory accidents, they are not there because partly, you know, the state of our laboratories, the standards are not good enough. In fact, it's not good enough, it's too good. They are very bad. The waste, as you saw, it is very poor. And that's why I have been appealing to our bosses that they need to rethink what they teach field epidemiology now. Otherwise, we are entering an area where we are not prepared. And thank you for bringing that up. We need to have a good system, and a good system of surveillance needs to have a good lab. Thank you very much.
Thank you very much. Is there any question for Professor Mbazeo? Yes.
Okay, thank you very much, Prof. Mbazeo, for that presentation. So I have a concern. There are so many interventions across the continent around the One Health you've talked about. How do we coordinate this so that we can synergize across board? It looks like there's a sense of promotion for nationalization of One Health, but at regional and continental level, how do we ensure that this approach is well coordinated? Thank you.
Thank you very much. In my presentation, you notice that I said AfroHorn covers now 11 African countries. And we've been trying to encourage other universities to apply. But what we have done and approved by the board is that these countries that are members, we have registered One Health AfroHorn country chapters. And what we want to do is that we use those country chapters to have members from those regions. For example, we have country chapter in Ethiopia. We expect that Ethiopia will have those countries that are near, and we start facilitating them through Ethiopia. We have a country chapter in Senegal, we are in Cameroon, we are in DRC. So our aim is not each country separated from the other. we are looking at the whole of Africa. Now, when you go in the program that we are going to run, the academy, we have used case studies from the different regions. That's why I said we have engaged with the East African community, we have engaged with the African Union, we have engaged with IGAD, and I'll be meeting the ECOWAS, so that it is not per country, but it covers the whole of Africa. This is something that we have planned over time, and I said part of it here. So the curriculum and the training will be both in French and English to cover all the countries, and we're encouraging other universities and other
So we are running out of the time. Unfortunately, we cannot take more questions. During these presentations, we see, for us it's clear that outbreaks spread very fast, and not only we need to have disease detectors, but we also need to have disease predictors. And Professor William brought us that we need to strengthen the One Health workforce. And also Professor Eliseus showed us that we need to link the field epidemiology to laboratory safety and biosecurity. And we also have Dr. David, who shows the mechanism how we can get more support through the Global Fund Pandemic Preparedness Initiative. And this was the session about the One Health and Laboratory Strengthening Initiative. I would like to request a round of applause for our dearest panelists, and thank you so much for this amazing presentation, and we'll continue with our program. Thank you.
Yeah, so we are running behind time, so let's quickly move to our respective rooms. The professors will be around, I'm sure, this evening for further engagement. And those of you who had questions that were not answered, feel free to approach them and have your questions answered. So one question, I have one announcement. We'll have a social event this evening in the same place here, starting at 7 p.m. Please come clad in anything that represents your country, your culture in your country, and be ready to make a presentation in that regard. 7 p.m., same, this plenary room. Be ready to register, and to register when you come as a country team, even if you are one, register that you have a presentation so that we are aware. Yeah, so come ready to represent your country, your culture, and to have a good time. Thank you.
Thank you. Bye. Are you one of the... Okay, thank you. All right, good afternoon. As people are getting situated, we're going to be starting in a few minutes a poster session. If you are one of the in the group of the first 4 poster presenters, if you can please. We're going to do the first 2 posters, and then we'll do questions and answers. Then we'll do the next sets of 4 posters. So we're going to start with Andani.
Good afternoon, everyone. I'll be presenting an investigation of multi-drug resistant Acinetobacter baumannii in KwaZulu-Natal province from July to August of 2022. Multi-drug resistant Acinetobacter baumannii is one of the leading causes of healthcare-associated infections. The crude case fatality rate due to MDR infection ranges.
I'm going to pause just one second. It's not popping up.
Okay. Oh, I should. Okay. It's okay.
That's yours.
Yes.
Okay, you will start all over, okay?
Is it showing? Oh, okay.
You can start from the beginning.
Okay. Good afternoon, everyone. I'll be presenting an investigation of multi-drug resistant Acinetobacter baumannii in KwaZulu-Natal province from July to August of 2022. Multi-drug resistant Acinetobacter baumannii is one of the leading causes of healthcare-associated infections in neonatal units. The crude case fatality rate due to MDR infection ranges from 33% to 60% among neonates. On the 31st of July 2022, the first case of MDR was confirmed in the neonatal unit, and by the 11th of August 2022, 5 culture-confirmed cases that occurred. The outbreak was only notified on the 16th of August to the National Institute for Communicable Diseases. An outbreak investigation commenced the same day of the notification. At the time of the outbreak notification, all neonates were admitted to a neonatal intensive care unit. So an investigation was undertaken with the following objectives, which were to verify and determine the extent of the outbreak, to describe the demographic and clinical characteristics of all the neonates with the infection, to determine the genetic relatedness of the isolates, and to investigate the possible drivers of the infection in the unit. So we conducted a cross-sectional study at a regional hospital in KwaZulu-Natal, as shown in the picture above. A case was defined as any patient admitted to the NICU with MDR cultured either from blood, cerebrospinal fluid, or any other sterile sites. We defined NDR-AB as an isolate that was resistant to at least 3 classes of antimicrobial agents. We also assessed the results of microbial cultures which were processed by the diagnostic laboratory between January 2022 and August of 2022. And we also described the clinical and demographic characteristics of the reported 5 neonates. And we calculated descriptive statistics and the case fatality rate. We performed whole genome sequencing of the isolates, and an observational assessment of the unit was conducted. We identified 16 culture-confirmed cases of MDR-AB infection with an apparent increase in August of 2022. As depicted in the epi curve, you can see that the NICU only experienced 1 case a month or 2, but in August of 2022, more than 2 cases occurred within a week. We described the clinical characteristics and demographic characteristics, and we found that the median age in days was 21 days, the median birth weight was 1,170 grams, and all of the 5 neonates reported had underlying conditions, which included low birth weight, congenital pneumonia, among the others. And it is also important to highlight that of the 3 CSF specimens that we received, 3 of them were blood-stained, which indicated a blood contamination. The case fatality rate in this outbreak was very high, which was 80%. That is 4 of the 5 neonates demised. All of the 5 isolates that were received were phenotypically resistant to most of the tested antimicrobial agent, which included carbapenems. All isolates, however, showed susceptibility to cholecystine and tigecycline. From the whole genome sequencing analysis, we found one major cluster with 4 closely related isolates of sequence type 2. And from the infection prevention and control edit that was done, we found that there was exceeding of bed occupancy in the unit, there was shortage of equipment, there was sharing of equipment between the hospital units, there was poor waste management and suboptimal staffing norms. As depicted in the pictures, we can see the suboptimal norms that were in the unit. Our key finding of one dominant strain indicates a propagated transmission from one point source. And this was possibly driven by inadequate infection control in the unit. However, as of the 26th of August 2022, no further cases of MDR-AB infections were reported. For the public health actions, control measures included closing of the unit, disinfection of equipment, reducing bed occupancy, and there was prevention of staff members from borrowing equipment from other units. The infection prevention and control measures, as well as the environmental measures, were strengthened in the unit. Our recommendation included strengthening of the existing surveillance system in the unit, reinforcing hand hygiene with emphasis on the IPC hand hygiene. We had clinical staff should always ensure that there is optimal cleaning in the unit. These are more pictures from the outbreak. Thank you very much.
Our next presenter will be Gabrielle Kotewas.
Well, good afternoon. It's with great pleasure once again to stand before you this afternoon to present to you assessing infection prevention and control governance structures and financing option in Rachonyo North Sub-County Health Facility, Homa Bay County, that is in Kenya. Effective infection and control is crucial towards preventing hospital-acquired infection and is integral to safe, effective, high-quality service delivery. The success and effectiveness of such a program requires adequate financing coupled with effective governance system. We assess the health facilities and governance structures for IPC implementation in health facilities of Rachonyo North Sub-County in Homa Bay County. This was a cross-sectional study which was implemented between December 2022 and January 2021, that is post-COVID, in both public and faith-based facilities in the Rachonyo North Sub-County. A questionnaire was developed to collect data on demographic, IPC health financing with focus on funding sources, and IPC governance structures with focus on existence of the IPC program in those facilities and policy guidelines if there was any. We targeted IPC focal persons in all the 52 facilities that are within the sub-county, and we described data using frequencies and percentages. What did we achieve? Out of the 52 health facilities we targeted, only 49 responded to our questionnaire. That 45 were government facilities and 2 were faith-based facilities. Among the respondents, 25 were males and 26 were female, and the age was between 31 to 40. Distribution per cadre of the IPC focal persons, laboratory officers were the majority at 26%, clinical officers 21%, nursing officers at 19%, and also other cadres contributed 34%. On the existence of IPC program, we found that 80% of the facilities had an IPC program in their facilities, of which 43, that is giving 91%, had IPC policy guidelines, and 37 also had job aids and job aids. When it comes to financing of the IPC program, 25, that is 53%, had IPC program in their annual work plan. However, only 13, that is giving 28%, had budgetary allocation for IPC program. 26, giving a percentage of 55, had donation and partner support as the main source of funding for IPC activities, whereas 11% relied on Facility Improvement Fund, FIF, for the finance of IPC program. 34% had mixed sources of funding for IPC program. In conclusion, we found that most facilities had IPC program and relied on budgetary allocation and partner support for funding. For sustainability of a robust IPC program, more facility-driven finance resourcing through Facility Improvement Fund will be of vital importance, especially in this era of declining donor support. Otherwise, we want to acknowledge Homa Bay County Department of Health, Rachuonyo North Sub-County Hospital, IPC focal person, and AFENET for providing this platform. Thank you very much.
Thank you so much. We've had two wonderful presentations. I just want to check one more time. Is Raja Alhami in the room or Sarah Mwira? So looking for Sarah Mwira and Raja Alhami. If not, then let's do the question and answers for these two presenters. We would like to have ideally one question for each presentation. So I'm going to start with Andani. Does someone have a question for Andani? Please come to the microphone. We have a functioning microphone, just waiting for someone to come and ask a question. Who wants to be that brave person to ask a question? There were no questions. Okay, well, I will take the liberty of asking a question. So my question is, if you could just, what would be one of the limitations that you may have had with your study design?
Thank you very much for the question. One of our limitations that we had was that the observational assessment, which is the infection and prevention control audit, was only done at a later stage primarily. So there were a lot of things that we missed from the outbreak which could have been predictors of the outbreak in the unit. So we could not have solid recommendations that could direct the possible drivers to prevent future outbreaks from occurring in that particular unit. Thank you.
Thank you so much. Let's move on to our next presenter, Gabrielle. Does anyone have a question for Gabrielle? You've had a couple of minutes now to think about your question. Can we have a question for Gabrielle, please? We have a very quiet audience this afternoon. I'm going to ask Gabrielle the same question. Could you please describe one of the limitations in your study?
Well, thank you very much for the question. One of the limitations maybe I would say maybe is the financial constraint that we could not evaluate all the aspect of health system strengthening as far as IPC program is concerned. So we could only look at the financing and maybe the governance. But there are all other aspects, maybe health information management, we could not look into that because of the finance constraint. Thank you, and the limited time. Thank you.
Thank you both. Let's thank our presenters. Thank you. Good job. Okay, we're going to do our next set of 4 posters now. If you are in the next set of 4, if you can please come to the front. So that would be Nestor, Fabrice, Eldred, and Edna. You can please make your way to the front.
You know stuff?
Oui. Benin, country Benin.
Yeah, it doesn't really matter. Mr. Sokopi, this is you.
C'est ça.
This one. All right. Okay. So just, she will call you.
All right, we have 4 presenters. So we're going to go ahead and start with Nestor. So that we're going to run this the same way. We'll do the 4 posters, and then we will do 1 question for each presenter. So as they're presenting, you can think of your question. Each presenter will have 5 minutes for their presentation. Great. So I'm going to go ahead and welcome Nestor.
Bonsoir.
Good evening, good afternoon. My name is Nestor Susupe. I come from Benin. I am here this afternoon to present to you the evaluation of the surveillance system of maternal death from July 2021 to June 2022 in the district of Kufu in Benin. As for an introduction, I can tell you that maternal death is something that occurs when a mother is pregnant and she dies. And there are various causes for this maternal death. And it can be an accident or something else. And I can tell you that maternal death is a reality in the world. And in Benin, the surveillance has been improved since 2017. The ratio passed from 347 to 207 maternal deaths in 2021. So in the department of the district of Kufo, there was a progress since 2018 from 143 to about 90. So the objective of our study was to assess the surveillance system for maternal death from July 2021 to June 2022. So what were the methods? We had a cross-cutting descriptive study in 2022 and sampling and data collection. The sampling was random and the interviews were with 8 agents that were intervening in the surveillance. And we worked with CDC Atlanta in 2021 to describe the functioning of the organization and to talk about attributes like simplicity, sensitivity, and representation. Data analysis was done with Info7, and we had about 80% that was there for the attributes, and the frequency measures were calculated as well. Here we can see the map of the district of Kufo, which is one of the 12 districts that Benin has. And now I'm going to talk about the results. As far as the organization and the operations of the system, we noted that the surveillance system for maternal death of Kufo has 3 levels. We have the periphery level, we have the intermediary level, and the national level. So the organigram on that pyramid has an audit of the death committee. And this audit committee for the death, and for simplicity, we wanted to have understanding of the case definition, and we've noted that 65% of the agents that were interviewed understood the case definition and could use it. As far as the understanding of the transmission, I can tell you that 84% understood the transmission of data. When we talk about acceptability, we saw some delays, but I can tell you that there was also an issue with notification. And to fill the various files, it was about 100%. Now for data quality, all the files of notifications were completely and correctly filled. We didn't have lacking data on this study period. And that's why we could have a good representation of that system that will enable us to describe the death in terms of persons, the place, and the time. And that's why we could come up with some analysis. Here we had the distribution of the maternal death as far as age is concerned. you can see the 34 years old and less that were the more affected. And here we have the distribution as far as the place is concerned. We have various sites of notification, and essentially it was the hospitals that notified the death during that period of the study. And we also have a distribution as far as the time is concerned. We have various deaths during the whole period, but especially September to December 2021, where we had very many notifications as far as death are concerned. So to conclude, we can say that the surveillance systems of maternal death for Kufo district is functional, and it's acceptable, and it's well represented with quality data. And that simplicity could be better if the case definition could be posted by the agents, and that was recommended in the various health area, and we could put that into place. And we couldn't finish that presentation without thanking the Ministry of Health of Benin, AFENET, and CDC. So in a nutshell, those are the reference of our work. Thank you very much.
I'm going to welcome Fabrice to the stage next.
Bonjour à tous.
Greetings all. This is Fabrice from DRC. I have the pleasure to present to you our assessment of surveillance on measles in Njili, Kinshasa, 2021-2022. Why did we choose this subject? Because in 2022, this region was most impacted after Beila region. 20% of the notified cases in Kinshasa came from Njili, this region. So we asked ourselves a question to know what could be the performance of the surveillance system between 2021-2022. How we are going to proceed? We used directives for surveillance systems as it's given by CDC and the standards of WHO. We did desk review on surveillance data 2021-2022, and we chose 5 centers in the region, from which we interviewed using a semi-structured questionnaire. Info 7.3 software was used to do the analysis. As a criteria, we said, and we have less than 50%, this is bad, between 50 and 67, this is okay, and for 90%, we could say that this is excellent. Here, you are able to see a map of Njili region, where you find this to the west of Kinshasa capital. After this assessment, just a reminder to have description of the actors. Here in this table, you are able to see that 87% of the actors that we interviewed were coming from the operational aspect, that is health center level. This graph shows the proportion of the actors who were trained in surveillance. This is a system which is integrated. 72% of the service providers were not trained in surveillance. The quality of data. We found out that the form was correctly filled. Completeness, 100%. However, the time aspect was not complete at 100%. This shows what we assessed as well. What you are able to see in the graph is that the representativeness of the system is at 80%. The other attributes, acceptability, 60%, reactivity, 67% of reactivity, simplicity, 74%, and 63% for the effectiveness. The conclusions through this data is that the system of surveillance in Injiri region allowed us to confirm the cases. This is okay, although it's not working very well. Why are we saying this? There is a lack of simplicity. Maybe the actors, you could remember that 95% of health centers here are private centers, and the system is not very reactive. So we realized that we need to improve this surveillance system. Public health actions, we spoke with those ones who are responsible, and we spoke to the health centers to improve all that they are doing. That's the end of my presentation. I thank you very much.
Thank you. I'm going to welcome Eldred up to the stage next.
As I've been introduced,
it's not showing.
Okay.
There we go.
Okay. As I've been introduced from the Sierra Leone Intermediate alumni, just to give a brief overview of my presentation, Sierra Leone currently have the weekly surveillance reporting system that is aggregated, then also the weekly ECBDS, electronic case-based disease surveillance system, that deals with individual cases. So in 2019, the Sierra Leone government introduced the electronic case-based disease surveillance system to enhance prompt data collection of individual cases, analysis, and dissemination of information. So the system aims to strengthen the capacity of all districts for early detection and response to potential disease outbreaks. So although this system has been effective at national level, its evaluation at district level has been limited. Therefore, we evaluated to determine if the system is meeting its objectives and assess its attributes in a district called Carine in Sierra Leone. To achieve that, we used mixed methods in assessing both qualitative and quantitative attributes, using the US CDC updated guidelines for evaluating public health systems. So 10 health facilities were randomly selected, and 15 study participants were purposively interviewed using a semi-structured questionnaire. And we also reviewed health facility registers and the ECBDS database to assess the system attributes from the period January to December 2022. So we calculated the average scores for each attribute by first determining the proportion of total respondents who answered each question correctly. We then scored the attributes. The system attributes as poor for less than 30%, average for 30 to 70%, and good for above 70%. And the findings were presented in text and tables. Results. The simplicity and stability were average with 66%, indicating the system was easy to operate and did not experience a major breakdown. Representativeness was rated average also at 65%, indicating the system captures all patients' social demographics. However, the acceptability was good, with 85% of healthcare workers showing willingness or commitment to participate in the system. Data quality was rated as good, with 97% of the records reviewed showed no missing variables. The system was 69% sensitive and at 83% the positive value predictive. Lastly, the system was found to be useful with an average score of 67%, indicating its ability to detect outbreaks over time. So this shows the overall data flow of the ECBDS system. Of course, it's a tracker program that is built on the District Health Information 2 platform. It has several stages. Data reporting starts at the health facility level, wherein health facilities notifies the case and fills the case-based reporting form, and then registers the case in the ECBDS system. A notification is then sent to the districts via emails and SMSs. At the district level, there are district surveillance officers that receives these SMSs and verifies the suspected cases with the health facilities, and then they conduct investigations and fills in the case investigation forms and the lab request form as well, and then update the data in the system. And the laboratory that the samples are sent to also captures the results and after analysis has been done. At the national level, there are surveillance officers there as well and other staff that follow up with the districts on investigations, and they also conduct data analysis for decision making. So in conclusion, the ECBDS system in the district called Karine was partially useful in meeting its surveillance objectives. Although majority of the surveillance attributes, including simplicity, stability, representativeness, and sensitivity, were performing on an average, the acceptability, positive predictive value, and data quality were good. We therefore recommended that the district health management team of Karine district to conduct refreshers training of healthcare workers on the use of the ECBDS platform to enhance the system's usefulness. So these are public health actions we took. We amended technical issues with tablets at some health facilities, and we also provided notification forms and case-based disease posters to some health facilities as well. Finally, we shared findings and recommendations with stakeholders for actions. These are pictorial evidences. I acknowledge these institutions and individuals. Thank you all. Asante sana.
Thank you. I'm going to welcome Edna Salat to the stage, please.
Good afternoon, everyone. I'm Edna Salat from Kenya FELTEP, advanced level, and I'm going to present an evaluation of rotavirus surveillance system at Kilifi County Hospital in Kenya for the period 2017 to 2021. So for introduction, rotavirus diarrheal disease is a vaccine-preventable disease caused by rotavirus. Diarrhea is the fifth leading cause of death among children under 5 years. And among these deaths, 90% occur in low-income countries in South Asia and Sub-Saharan Africa. In Kenya, rotavirus infection causes approximately 19% of hospitalization and 16% of clinic visits. So rotavirus sentinel surveillance system was established in Kenya in the year 2009 at Kilifi County Hospital. Evaluation at this sentinel site That is, Kilifi had not been done before. This was the first time. And the objective of our study was to describe the rotavirus cases and evaluate the surveillance system performance. For the methods, that is the Kilifi County, which is one of the counties in Kenya, and this is where Kilifi County Hospital is situated. The population in that county of under 5 is 154,681. So the cases, the case definition was defined as 3 or more children under 5 years presenting to the facility with loose stool within 24 hours period. And this diarrhea, it's acute and it should be less than 14 days. And it should be within that participating facility. So our study, we did a retrospective data review of the rotavirus cases, and we were able to interview stakeholders, which include the national surveillance officers, the county and sub-county, and the focal person in the facility. We formed a structured questionnaire based on the CDC updated guidelines. So we analyzed our data using, we did a descriptive data analysis using Excel, and we also used a 5-point Linger scale to rank the responses from the responder. So we ranked our responses, less than 60% we ranked poor. Average was between 60 and 80%, and good for above 80. So our results, we had a total of 1,184 records. The mean age was 12.7 months. The males were the most cases with 58.3%. For the clinical symptoms, all the suspected cases made the case definition of diarrhea. We also had vomiting, presented by 63%, sanguine eyes 27%, and dehydration at 21%. For the attributes, after analyzing the data, we found out that the system was able to pick cases across the years. As you can see, the red one, all the cases were able to be picked across the years, but there was an element of missing data, which was so prominent in our data. For the attribute simplicity, the staff were able to know the flow of data from the time the client comes to the facility all the way to the lab, the reporting system all the way back to the results going back to the facility. So the system was simple, and the users agreed that the system was simple and was able to use. We rated at 75%. For timeliness, we were not able to measure timeliness because 55% of the suspected cases had their stool sample collected and delivered to the laboratory. However, the time the results were released back to the ward was not indicated in the database. For data quality, completeness, data quality was poor. The key variables column in the database were missing. For example, the important variables like rotavirus vaccination, date of onset of symptoms, and others were incomplete. For example, lab test results, the age, the residence of the suspected cases. So for our conclusion, we conclude that rotavirus surveillance system is useful. The attribute which related to completeness was ranked poor at 43%, suggesting there is a possibility that some important variables might not have been entirely captured in the database, and the missing information potentially hindered the effectiveness of targeted intervention, decision-making processes, and program planning. So we recommended that the national and the county surveillance team to conduct mentorship on data collection and entry at the facility level, the county surveillance team to conduct data quality audits and reviews at the facility, and recommended that the disease surveillance unit at the national level to carry out a regular system evaluation. So our public action, we disseminated our findings to the Division of Disease Surveillance at the Ministry of Health. This led to the development of training materials for the clinicians on rotavirus surveillance, and also there were ongoing data review meetings at the facility. Thank you for listening to me.
Thank you so much. We've had 4 wonderful presentations. So we're going to do a question and answer session for these 4 posters. We would like to do 1 question for each presenter. So we're going to go in order. So start thinking about your question that you might have. We'll start with Nestor. So if you have a question for Nestor, please come to the microphone. Thank you. Please go ahead.
Hello. Hi, thank you. I'm Mohamed Esba from Sierra Leone. So Nestor, thank you very much for your presentation. It was insightful. So my question is, what were your public health actions taken after the surveillance system evaluation, and also your positive predictive value after the evaluation? Thank you.
Thank you, Mohamed, for that question. After the evaluation of the surveillance system in our department, we made a report to the competent authority, to the department authorities. There was also a departmental coordinator and of the hospitals we had there. And then we did the same thing in the 2 health districts. And the problem we had was the simplicity. There were new agents in the system. We had to brief them first. And sometimes the cases were not well defined. So that work was done. Thank you very much.
To Fabrice. Does anyone have a question for Fabrice? It's going to go to, okay, she beat you out. Okay, let's go ahead, please.
Yeah, in the question, you mentioned that those who implemented the surveillance system, most of them were not trained. So how would a surveillance system with most of its implementers not trained be effective in achieving its usefulness?
Merci beaucoup, madame, pour votre question.
Thank you very much for your question. I said that 72% of the people working in that zone were not trained in surveillance. And to inform you here, I would say that the country in general hasn't yet has complete training as regards surveillance in CMR3. I think 3 weeks ago, certain service providers were trained as regards surveillance. You are right to ask that question. When we face a very high proportion of personnel who are not trained, it's logical that the system can't be so performing. And the country is now taking that at hand. We are considering it.
Thank you. Question for Eldred now. You have a question for Eldred?
Yeah. Thank you. Thank you for the presentation. I had a question from the Sierra Leone community-based surveillance. Are you able to have a two-way feedback? Like the people who are picking up data, I'm assuming this includes like event-based surveillance, because one of the things we have found is a lot of times the community healthcare workers or healthcare workers pick data and report up, but there is minimal use at source. Also, if they have a question, they don't have a way of getting feedback from the district or regional. So do you have a two-way communication on that? And how much is the use of the surveillance data at source? Thank you.
Okay, thank you very much for that question. Yes, indeed, in Sierra Leone, it's not a different case, considering it's a low-income country. So during my evaluation, I picked that up. The system has provision for feedbacks, but actually it is a challenge from the district health management teams to the health facilities upon sending notifications. So say it is part of the system, but it is performing on an average. I captured it on the usefulness, but because it's a question on usefulness, and I'm giving the overall average of that particular attribute. But feedback is a challenge in the system. Thank you.
Thank you. We'll do a question for Edna. Who has a question for Edna? Don't everybody rush at the same time. We're looking for, oh, we have a question. Go ahead, please.
Merci. Thank you. As regards the data quality, we noted that you said in your presentation that the data quality was bad. Did you take any measures? What activities or what measures did you put in place to resolve that problem? Thank you.
Thank you so much for your question. Yeah, we had an issue with data quality, and from our recommendation, we recommended that the data quality, we concluded that the disease surveillance department in the national level will do support and mentorship on data entry, and we also recommended that quality data review in the facility be done regularly. Thank you.
Okay, thank you. Let's give some appreciation to our four presenters for very nice presentations. Thank you. Okay, we're going to move on to our final round of four. So we have 4 posters left in this session. If you are one of those 4 presenters, please come up to the stage. So the names are Wilbrod Mwanji, Nengoma Hamboti, Chriswell Kolomo, and Richard Sifunan. Great, we're going to go ahead and get started. I welcome Wilbrod Mwanji.
Okay. Yes, good afternoon. My name is Wilbrod Mwanji from Uganda. Allow me to share with you our work on acute flaccid paralysis surveillance system that was leveraged to enhance COVID-19 surveillance in 7 high-risk districts of Uganda in 2020. So as way of introduction, on March 21st, 2020, Uganda declared her COVID-19 outbreak and subsequently instituted a total lockdown. However, by May 2020, nearly 2 months down the road into the outbreak, only a few cases had been reported compared to the other countries in the East African region. This led to suspicion of low surveillance sensitivity. The lockdown had also interrupted routine immunization activities, and that risked resurgence of previously controlled vaccine-preventable diseases. So we used our national stop transmission of polio teams to investigate possible COVID-19 cases alongside their active search for acute flaccid paralysis cases in the high-risk districts of Uganda. So our method involved reviewing medical records and listing cases in health facilities in 7 high-risk districts. So this map shows the 7 high-risk districts where the intervention was conducted, mostly districts with international points of entry. These are also districts that formed the early hotspots in Uganda's COVID-19 outbreak. They are also located along major transit routes. So we defined missed AFP case as any patient below the age of 15 years with any of the following documented diagnoses: AFP, injection neuritis, paralysis, suspect polio, limb weakness or limpness, and within 30 days of their symptom onset, but without a completed case investigation form. A possible COVID-19 patient was any patient with any one of the following documented diagnoses. That is including severe acute respiratory illness, pneumonia or severe pneumonia, and within 14 days of their symptom onset, and without a field SARS-CoV-2 case investigation form. We collected samples for laboratory testing, and that included stools from the missed AFP cases, which was tested for wild polio virus. Nasopharyngeal swabs were taken from the possible COVID-19 cases that still had active symptoms. These were tested for SARS-CoV-2 virus. We completed disease-specific case investigation forms and submitted them via the ODK application that the polio teams culturally use in Uganda. So we analyzed our data by computing verification factors for the reported diseases. That is the SARI and AFP by month. And we also computed proportions of the scheduled active search visits by priority level of the surveillance sites. Okay. So our teams visited 140 sites, which was only 53% of the planned. And during the mission, we identified 4 cases, 2 of which were verified, and investigated with the collection of stool samples that all tested negative for wild polio virus. About 312, that is 86% possible COVID-19 cases were verified. 34 of these provided samples that all tested negative for the SARS-CoV-2 virus. We found a very low proportion of scheduled active search visits for acute flaccid paralysis conducted, as demonstrated in this table. For all the levels, the priority levels of active surveillance, none of them reached even 10 percentage points. That was during the lockdown. There was generally underreporting of both syndromes, that's AFP and SARI or pneumonia, as demonstrated in this table with very high verification factors comparing the cases recounted in the register to those that are reported on the form, all of them higher than 105. Yes, so the AFP surveillance system in Uganda was quite flexible at the time and allowed integration of possible COVID-19 surveillance. There are other countries that have demonstrated this. The example of Nigeria, which has integrated malaria surveillance into using the national stop transmission of polio teams. So there were no confirmed cases of COVID-19, probably because community transmission had not yet established at the time. The system was generating poor quality surveillance data, as demonstrated by the underreporting for both syndromes. And this was probably because health workers stayed away during the early phase of COVID-19, and there were challenges coming with the reporting. One of our limitations is that the possible COVID-19 cases we identified were not tested for other causes of acute respiratory symptoms, like influenza, which is known to cause a seasonal flu, and it tends to peak in the middle of the year, the same time we conducted this intervention. So in terms of actions taken, the Ministry of Health rolled out the enhanced health facility-based COVID-19 surveillance, and this was enabled by the coming of rapid diagnostic testing technologies. The Ministry of Health also rolled out the use of the ODK application to collect COVID-19 situation reports from over 140 districts in the country. This is a photo of teams sensitizing health workers on guidelines for AFP and COVID-19 surveillance. Okay, these are our references. I thank you.
I welcome Nangoma Hamboti to the stage. Thank you.
Good afternoon, everyone. So my name is Nangoma Hambote, and I'll be presenting my findings from the evaluation of the AFP surveillance system for Southern Province in Zambia from 2020 to 2022. So in introduction, Zambia has a threat of poliovirus. We're looking at our neighbors that have experienced polio. And a high-quality AFP surveillance system is essential for us to find any cases of polio. And for Southern Province, they have been performing below the national target of at least 2 polio non-AFP cases per 100,000 children below 15 years. And in Zambia, this is our current AFP surveillance system, which begins with the case definition of any child less than 15 years and ends with a follow-up exam after 60 days and also feedback to the health facility. So our objectives during our study was to evaluate this surveillance system for Southern Province and make recommendations based on our findings. So the methods that we used the CDC MMWR surveillance system, and for each attribute, anything less than 50% was poor, between 50 to 70% was good, was average, and anything above that was good. So we collected data at provincial and district levels, and interviews were conducted at to the focal point persons at these sites. So 4 districts were selected. In 2 districts were the good performing districts and 2 were the bad performing districts. And in each of these districts, 4 facilities were selected using probability proportional to catchment population size. So this is the map of Southern Province, and the highlighted areas are the districts that we went to. So for our analysis, we use descriptive analysis for quantitative data, and content analysis was used for qualitative data. So our findings for this study in this table, simplicity for the study was good at 79% of the respondents found it easy to use. However, only 58% of them had used it to detect a case. Acceptability also was fair, and most of them had integrated it well with their daily work schedules. Also, all the districts in Southern Province were also good, so representativeness as well was good. Flexibility was fair because 56% of them unwelcomed the introduction of a stool runner. Stability also was good as there were adequate supplies of all the materials needed for stool collection. However, when you look at the data quality as well, it was also good, but we had some discrepancies in the case investigation forms, which were at facility district and the virology lab. The positive predictive value was poor at 47%. So when we evaluated the knowledge of the key focal point persons, only 21% of them knew the entire flow of the AFP surveillance system, and knowledge of the full case definition of AFP was low at only 11%. And when you look at timeliness, the routine AFP surveillance system reports in the IDSR was poor at 64%, and the specimens arriving at the lab within 3 days was at 93%, which was good. However, the results were poor at 60%. So for Southern Province, when we calculated the non-polio AFP rate from 2020 to 2022, we found that it was very good, with it being above 2 for all the years. So in discussion, we can see that the AFP surveillance system for Southern Province is good, as it can detect a case of AFP, and it enables adequate investigation and reporting. However, there is a need for harmonization of the data from the lab, and surveillance, and also the immunization records are also important to assist in planning and implementation of appropriate interventions. Another thing also is we have a very low positive predictive value, so there's a low sensitivity and specificity of the surveillance system in Southern Province. In conclusion, we can see that even though the system is useful, there is need to increase training and mentorship of the focal point persons, especially since there was a low percentage of them who knew the AFP case definition. Apart from that, one of the recommendations is data quality audit meetings with all the key stakeholders to improve the data synchronization at facility and district levels. So this is just one of the images which was taken to see how there was training of some of the community health workers and facility during one of the campaigns on the case definition. Thank you so much for your attention.
Thank you. I'm going to welcome Criswell Coloma to the podium.
Okay, good afternoon, everyone. I'm Criswell Coloma, Zambia FETP. I'm going to give the results of the evaluation of the acute flaccid paralysis surveillance system in the Eastern Province, Zambia 2020-2022. Poliomyelitis is an infectious disease that affects mostly children under 15 years of age. About one per 200 of infected people develop some degree of paralysis, which is sudden and rapid, and often reach full development within a few hours, but usually within 3 days. In 2022, WHO declared an outbreak of world polio virus detected in Malawi, and 4 more cases were reported in Mozambique, Tete province. The 2 countries bordering Zambia in the Eastern Province. The quality of AFP surveillance is measured by using a standard definition for sensitivity and completeness. Therefore, we evaluated the AFP surveillance system for the Eastern Province because it was identified as at risk due to its proximity to Malawi and Mozambique. Figure 1 just shows how the data flows, as well as how feedback is given from the community health facility to the Zambia National Public Health Institute or Ministry of Health, WHO or CDC, as well as how information is given from the top to the community. And also how specimen flows after specimen collection, how it is transported to the virology laboratory, and as well as the results from the virology lab to the districts as well as to the national level. In terms of the methods, we use the CDC MMWR guidelines for evaluating public health surveillance system. That's usefulness, simplicity, acceptability, timeliness, representative, flexibility, stability, data quality, sensitivity, and positive predictive value. We visited 4 districts selected based on non-polio FP rate performance and 16 health facilities. And these were randomly selected using probability proportion to catchment population. Figure 2 just shows the map of the districts and the facilities where we visited. The ones which have been highlighted with yellow are the districts plus the red dots are the health facilities we visited. We conducted key informant interviews for 20 health care workers using a semi-structured questionnaire to collect qualitative data. And we reviewed OPD registered, patient case reports, physiotherapy registers, surveillance case investigation forms, and laboratory requisition forms from 2020 to 2022 to collect quantitative data. We conducted a descriptive analysis for quantitative data and a content analysis for qualitative data. And we summarized the data using frequencies and proportions. In terms of the results showed that the system was good in terms of acceptability, as 100% of the healthcare workers reported a positive attitude towards its use. In terms of representativeness, all the facilities in the province are participating in AFP activities. And stability, more than 80% of the supplies for specimen collection and packaging were available, as illustrated by this table. The supplies are the cotton wool, the ice pack, the biohazards, and the like. However, we noticed poor performance on timeliness, as most of the indicators were below 80%. In terms of simplicity, 25% of the healthcare workers were able to give a full case definition of the AFP. This graph just shows the completeness of the case investigation forms, As you can see, 90% of the investigation forms reviewed, phone numbers were missing, as well as the date of follow-up. The system had sensitivity of slightly less than 2% per 100,000 non-polio FP rate in children less than 15 years, as compared to equal to or more than 2 per 100,000 as the annualized target, as shown by this graph. The system had a positive predictive value of 53.5%. When we compared those which were identified FP cases that meet the case definition and those investigated, as well as the specimen collected. Discussion, FP surveillance system, the province was found to meet some of the attributes of a good surveillance system. And the data quality, completeness of reporting and timeliness were poor, as we noticed some gaps in most of the case investigation forms. The FP surveillance system was found to be less sensitive because of the non-polio rate was below the minimum WHO requirement. So in conclusion, overall the system was fair, but with improvements in attributes like sensitivity, data quality, and timeliness. It could be more effective and efficient in detecting and monitoring cases of FP. We therefore recommend training of healthcare workers and also implementing data validating and verification exercises and regular communication and feedback with healthcare workers. Thank you so much. That's the end of the presentation. Thank you.
Thank you. I'm going to welcome Richard Safanan to the podium.
Bonsoir, chers messieurs, dames.
Good evening, ladies and gentlemen. My name is Richard Safanan. I come from Benin. We have the honor to present to you our presentation on acute flaccid paralysis in the hills of Benin from the year 2020 to 2023. Introduction shall say that acute flaccid paralysis is a sudden weakness touching the muscles without any evident cause. And polio is a particular form, is a unique form. Polio, as you know, is caused by viruses, and it's very contagious. There's even a world resolution for the eradication of polio, and that resolution enabled us to go from 120 endemic countries in 1998 to 6 countries in 2021. And one of the objectives of that resolution was to strengthen and maintain sensibility and timeliness of surveillance of acute flaccid paralysis. And in that state that we proposed as an objective to determine the epidemiological profile of acute flaccid paralysis in the High Hill district of Benin in 2019 and one in 2021. What was the method that we used? We had made a descriptive study, and the data source was the epidemiological surveillance database of the district, and we looked at all the cases that were noted during the period, and we took on the variables of interest, that social demographic variable, vaccination state, district of origin, and laboratories. We looked at the result and 7 to analyze our results, and we calculated declarative characteristics with interval of trust. Here, you can see our region, the region that we're working in, which is in the center of Benin. What are the results that we received? In total, 104 results were counted during the period, and fatality was 1.04%. For 86% of the cases, extracts of blood were adequate, and the incidence, which was highest, was observed in 2019. It was 3 cases for 100,000 children. And in our study, the ratio of men to women was 1.06. According to sex, you see that 56.7% were men. As regards the origin of the cases, all communes declared cases. We have got 6 communes in that district, and 80.6% came from rural areas. As regards age brackets, the age bracket of 1 to 4 years was the most affected, with 60% of the cases. As regards the vaccination status, 116% of the cases were vaccinated. In conclusion, we shall say that the acute flaccid pulses continues to be detected in the district of the Hills in Benin. It comes mainly among children between 1 and 4 years, especially those ones living in rural areas. At the end of this study, we recommended that there be strengthening of the surveillance system of acute flaccid pulses at all levels of the sector, whether in communities or in hospitals. And children should be vaccinated so that we catch up with vaccination among the children that were missed. We cannot finish our presentation without thanking the institution that helped us to undertake this study, AFENET, Ministry of Health of Benin, among others. On the screen, you can see some references that we used to do our work. Thank you very much.
Thank you so much. We've had 4 nice poster presentations, so thank you to the presenters. I would like to do a question and answer session now. We'd like to have 1 question for each presenter, and we're going to go in order. So I would like to start with Wilbrod. If anyone has a question for Wilbrod, please come to the microphone. We'll take 1 question. Go ahead, please. Oh, I think it's not working.
Okay.
There we go.
Thank you so much, Wilbrod, for a good presentation. My name is Tebelo Kolube from Zambia Field Epidemiology Program. So in your results, you mentioned that you covered 86% of the facilities, if I'm correct, and from the planned. So I just want to know what could be the implications of your findings of that for not covering all the facilities, the facilities that you had planned to cover. Thank you.
Yeah, thank you. Yeah, just for the correction, it was 53% of the facilities, just about half. One implication is that the conclusions we could be making here, as community transmission having not established at that time, may not be really correct because we didn't reach all those sites where possible cases of COVID-19 possibly existed. Yeah.
Thank you. That was a good question. I actually had a very similar one. So our next question would be for Nangoma. Who has a question for Nangoma? Lady in the red? to turn on the mic.
Je tiens à remercier la présentatrice.
I wish to thank the presenter. My name is Mirai Elongo. I come from the DRC. My question is as follows. The presenter told us that during data collection, she found anomalies in different data collection documents. The question now is, what are the different anomalies that she detected in the documents when she was doing data collection? And also, I'd wish to know what were the measures taken against that situation to resolve it. Thank you.
Thank you so much for the questions. So the anomalies that we found was the discrepancies of data, especially in the case investigation forms. One of the things is we found that at facility levels, the facilities we visited, they had about 20 case investigation forms for the time period. And then when we got to the district, they had recorded about twice the number of case investigation forms for those facilities. Then when we got to the virology lab, that number was again greatly reduced for those case investigation forms. Apart from that also, we also looked at the data from the IDSR guide, the EIDSR, and also found that the data was not linking even with the one that we got from the virology lab and the facilities. So one of our actions was that there should be data quality review meetings to ensure that we reduce these discrepancies, because it means we're investigating cases and we're wasting resources as a country investigating these cases. Thank you.
Thank you. Let's move on to Chriswell. Let's have one question for Chriswell, please. Yes, go ahead, please.
Thank you. Thank you, Chriswell from Namibia. However, in your presentation, I didn't see anything on public health actions. So can you please tell us what were your public health actions you took? Thank you.
Okay, thank you so much for the question. In terms of the public health actions, just after the analysis of the results, we presented the report to different stakeholders, whereby some of the issues highlighted in the report were implemented. For your own information, Zambia have been conducted the FP, the polio campaign. So during the campaign, some of the issues which were highlighted in the report were being addressed, like the active case in finding for the FP cases, as well as there was also an issue to do with the reporting tools, whereby we also we were trying to brief the healthcare workers during on the same spot during the evaluation of the system. Thank you.
Thank you so much. And to close out, we'll just have one question for Richard, please. Who would like to ask a question for Richard? If not, I have a question. So I believe you mentioned that the incidence was highest among those that were aged 1 to 4 years. And I am wondering, why is the incidence higher among children aged 1 to 4 years?
Thank you very much for the question. The incidence was really high for the children to 1 to 4 years in the database that we've collected. That's what we've noted. The surveillance of polio was actually from 0 to the age that is inferior to 15 years in the countries. But the case that were actually notified for the acute flaccid paralysis, it was actually in that age group that we noted many things. And that's justified. When we have the polio campaign, it's that age group from 0 to 5 years that we really take into account. Thank you very much.
Much. Let's give a hand to our presenters for excellent presentations this afternoon. Thank you so much. We're going to be wrapping up this session, and there's going to be another session starting, I believe, in a few minutes. Thank you guys so much. Nice job. Congratulations. Good job. I tried to do my best. I mean, we started so late. I kept we had 12. 11. Yeah, I had 11 posters. I mean, we started late, so I tried to move it as fast as I could.
So all of them are there?
No, we may have to confirm whether they are here. Just we call it a name, but I just launched the first question.
Ladies and gentlemen, good evening. We are starting our next session after a few minutes, as in now. And I would like to invite Edward. Monsieur Edward, who is presenting Profil épidémiologique de la... I don't know how to pronounce the name, but it's... can I invite Edward Huto?
Okay. The first one. Elle appelle...
She's calling Edward Hunto Hotegbe, that is going to present on the epidemiological profile of the measles in the district of Mono in Benin from January 2016 to June 2022. The second person, if Edward is there, please come into the front. The second person is Mounier Boulaba. Mounier Boulaba, if you are here, please come to the podium. He's going to present on the epidemiological profile of AFP and polio that come from the vaccine in the health area of Nyunzu in 2022. The third presenter is Hamed Said Salem. Hamed Said Salem is going to present about the health profile of the students in primary schools in the health regions in Djibouti in December 2021 to May 2022. Lansine Keita. If Lansine Keita is there, please come to the podium. Epidemiological profile of COVID-19 in the district of Bokeh from 29th of March 2020 to 31st of December 2021. Lansine Keita.
Oh, 5. OK. La dernière personne, c'est...
The last person is
Mohamed
Adake Mohamed Adake.
Il va présenter sur
He's going to present on the investigation of COVID-19 cases in the health region of Tajura in Djibouti in January 2022.
Donc, on rappelle encore
So
Edouard.
we are calling upon Edward. Edward, are you there?
Donc, il y a 4 présentateurs qui sont
So
là.
we have
Donc, Edouard n'est
4
pas encore arrivé.
presenters that are there. Edward is not yet here.
Only this one is not.
Okay.
The first one is not. You have 4. They are 4.
You're supposed to be up to here.
Up to him?
Abdulrahman.
Okay. Okay. Comme la première personne n'est pas là, on va aller.
Because the first person is not there, we can go to Abdurrahman Balde. Abdurrahman Balde is going to present on investigation of the cluster of COVID-19 in the district hospital of Fria from Guinea, January 2022.
He's coming. If you need any help after, then let you know, then I can.
Thank you. Thank you. So, ladies and gentlemen, in an effort to hasten this process, we are taking the first 6 presentations. Monsieur Edouard.
Mr. Edward, if you are still there, please come to the podium.
So, without wasting a lot of time, I'm giving my presenters 5 minutes each. If you can do it in less than 5 minutes, wonderful. I would like to invite Monsieur Mounier.
Merci beaucoup pour la parole.
Thank you very much for the floor.
Moi, c'est Mounier Boulaba.
My name is Mounier Boulaba. I'm FETP, Advanced FETP. I'm going to present is entitled Epidemiological Profile of the AFP and polio that come from derived from vaccines during the outbreak in the health area of Nyunzu in DRC. As introduction, I would like to say that since 2017, with more than 700 cases that were notified positive of polio derived from vaccines, and 98% were coming from the AFP surveillance. DRC is actually in an outbreak situation of polio that is derived from vaccine. When we observe
I just will make it to us. It's already start. Not yet. It's not. Please. Individual. It will come. It will come. He will come. Okay. Okay, so it's coming, but okay. Can we try this again? Okay, thank you. Voilà, donc je disais que depuis 2017.
I was saying that since 2017, our country, the DRC, is actually facing an outbreak of polio derived from vaccine. And we had more than 700 cases since 2017. And among these 700 cases, 98% of these cases were coming from the surveillance in the AFP cases. When we observe all these cases since 2017 to 2022, we observed that in 2022 there was an increase, a great increase of the cases, an increase such as in 2022 the DRC observed about more than 4,000 cases of AFP with people who had symptoms of AFP, and 439 cases that were diagnosed positive of polio that derived from vaccine. And this increase started in 2022 and moved in the province of the eastern part of the DRC, where we have the Tanganyika province, that for Tanganyika we diagnosed 142 cases of polio derived from vaccine. And the province of Tanganyika is part of the health area of Nyunzu, where we did our study, and the health center of the health area of Nyunzu had about 10% of these 142 cases that were diagnosed in 2022.
The uniqueness of this Nyunzu area was that in 2021, the following year, the medical zone had not declared any case, and vaccination. Later, we had 12 cases. It was a big increase. So the objective of this study was to determine the epidemiological tendency of this, not only for acute flaccid paralysis, but also for polio coming from or derived from the vaccine. That's why we undertook this study. And the method we used, it was secondary data that we used. So it was a retrospective, descriptive study from investigation forms. The sampling was exhaustive. That means there was 96 cases of acute flaccid paralysis. And the data was analyzed using Microsoft Excel 2016 and R with 90% of confidence, trust. What were the results on that 96 cases? 13 were diagnosed positive to polio due to vaccines. And then we had type 1 and type 2. The PFA cases, that's people who were presented acute flaccid paralysis symptoms or signs, were those who had polio from vaccine. And they were, in majority, most of them were women, 51% for FP and AFP, and 49 for polio. They were aged from 12 to 69 years. I'm happy about my colleague who talked before me from Benin, who found the same results. What is striking, the results that we found is that all the polio cases derived from vaccines, they were of 0 dose. That means that we went beyond the definition of Gavi for 0 dose, because Gavi describes 0 dose people as being people who have not had access to vaccine until 1. So we sensitized so many people about definitions, and we defined 0 dose as people who have never been vaccinated at all by any antigen. So it's it's impressive because polio derived from vaccines, all the cases, 100% were of 0 dose. Yet, the people who presented, or the children who presented acute flaccid crisis symptoms, 41% were of 0 dose. When we take this group of people to and compare them to the poor as insufficiently vaccinated, that means those ones who started the vaccination calendar without completing it, we note that the case of AFP in 2021, 82% were insufficiently vaccinated. That means children had started the vaccination regime but did not complete it. Paralysis, also among people who had acute flaccid paralysis with the people with polio derived from the vaccine, concerned in general the lower legs, the lower members, lower limbs. So that explains the fact that we had many cases and the indicators were good, which explains the fact that we had many cases. In conclusion and recommendation, given these results, we recommended that we should intensify routine vaccination and also intensify supplementary vaccination in these zones, especially modify even health policy in the areas like this one, so that we may mainly favor periodical intensification of supplementary vaccination. So that is the summary of the work we did. I thank you.
Thank you very much, Monsieur. I would like to invite Monsieur Ahmed Said Salem. Welcome. You have 5 minutes.
Salem, yes. Yes. I can zoom, huh? Can zoom? Okay. Zoom it. Yes. No, it's not. Yes, just only one part. Then you can zoom like this. Come back like this. Okay. Merci pour la parole.
Thank you for giving me the floor. Good evening, everybody, and dear colleagues and the jury. My name is Ahmed Said Salem. I come from National Institute of Public Health in Djibouti. I'm also FATP frontline. So I'm here today to present to you the epidemiologic health profile of primary school children of a region in the center of Djibouti. I remind you that health and education are closely linked. When you talk about bad health, even the school results will be bad. The nutritional study undertaken in 2019 showed already predominance of malnutrition, which led us to undertake this study. And that was remarked absences in the colleges and schools. However, no study had been made, apart from the one we have done, that had been undertaken to determine the profile. We undertook a descriptive study which covered a number of months from December 2021 to May 2022, especially in the interior schools. To attain our objective, we undertook Thirdly, we would take 10 pupils from each class. To collect data, we used a form, and in order to analyze data, we used Excel. The proportions were calculated, the median was calculated, and I'll present to you the results in a short time. The mainly it was the men, or the masculine gender, that was most affected. And we noted that among the major symptoms, we had angina, cough, at a ratio of 16 and 17%. In total, we included about 94 children in this study. Their median age was 9 years, and the smallest were 3 to 5 years, and the men or boys were up to 56%, and 16% had that angina. In conclusion, our study determined that there were anemic cases and dengue fever cases. So on the field, we did TDR tests for dengue and for blood count. So we presented cases of moderate malnutrition to extreme cases. We recommend to the Minister of Health and Minister of Education to undertake a deeper study which will determine the state of school-going children in that state of Djibouti. I'd wish to thank the Minister of Health of Djibouti, AFENET, and all those who contributed to our study. Definitely, a balanced deworming will be one of the solutions to this problem. Thank you.
Thank you very much, Monsieur Ahmed. I will invite Monsieur Keita.
Merci, Monsieur le modérateur. Je m'appelle...
Thank you, Madam Moderator. I'm called Keita. I'm a graduate FLTP Intermediate, Republic of Guinea. Allow me to present to you the results of our work on the epidemiological profile of COVID-19 in the health district of Bokeh for the period of 29th March 2020 to December 31st, 2021. The Republic of Guinea registered its first case of COVID on the 12th of March 2020. 32,211 cases and 360 deaths were declared, among which 1,042 cases were in the district of Bokeh only. The profile of the cases was not known, and that was, therefore, to lead to this study. So the interest of this study was, the objective was to evaluate the quality of the data and categorize people, time, and places. In order to attain objectives, a incidence study was undertaken in the health district of Bokeh on the population of a prefecture of Bokeh. We included in this study all the resident cases of Bokeh. And in this study, we included even those who don't stay in Bokeh. The definition of the word WHO was adopted and operationalized. And our variable of interest was socio-demographic variables and risk factors, and the data was taken with DHSS-DO, and data was analyzed through AP-M4 and Excel 2016 programs, software. That enabled us to have the following results. From the 2,042 cases which are confirmed, the completeness was of 98% and 98.2%, and that quality of data was due to the support of the OMS, of the WHO in the ground. As regards clinical results, of 1,042 cases, 92% were asymptomatic and 36% were symptomatic. Among whom 92.4% were light symptoms. The median age was 44 years, and the age bracket of 39 were the most touched, were the most affected, and mainly it was women. The predominant community was diabetes, which had registered 56% of fatality rate. The weekly progress of the curve of the cases tested confirmed positivity, and it was noted that the first case, after the first case, we organized massive testing, which increased the number of cases and number of tests.
When we talk about this rate of attacks, we had the district that was the most affected. That's where we found the mining companies. In conclusion, majority of cases were symptomatic, and the male adults were the most affected, and they were like people who had 50 years and more, and they were diabetic. And as actions, we had a briefing of with various agents and the awareness of the various populations in terms of this disease, and we also did some vaccination campaign. We recommended to prioritize the vaccination of 50 years old and more, and people who had comorbidity. Thank you very much.
Thank you very much, Monsieur Ahmed, for taking little time or within your time. I would like to invite Monsieur Keita. No. Ahmed. Mohammed Adake. Thank you.
Je me présente.
Thank you very much, Madam Chair. Dear assessors, dear colleagues, my name is Adake Mohamed Adake. I come from Djibouti, from the Republic of Djibouti. I am someone who works on surveillance in the Tadjoura district, in the northern part of the Tadjoura district, and I'm FETP, a frontline for the Republic of Djibouti. I'm going to present to you the investigation of COVID-19 cases in the health region of Tadjoura in the Republic of Djibouti, January 2022. I'm going to remind you the history of COVID-19. COVID-19 appeared in 2019 in Wuhan region in China. Many cases were detected, and WHO said that it was actually a global pandemic in March 2020. And Djibouti got to the first case in 2020 because that case was coming from Paris in Europe. That person was tested, isolated, and all the other passengers were put in quarantine. The cases that were investigated in Tajora, it was actually a young person who was working the regional council of Tajora, and he went to be consulted, and he had some symptoms that were typical to COVID-19. So the first thing that we did, we asked to do a rapid test to confirm the case, and the case was positive, and that's why we had a rapid investigation, because the disease is very contagious. So the framework of study, the population of Djibouti is about 1 million inhabitants, and it has a border with Ethiopia, Somalia, and Eritrea, and we also have a maritime border with Yemen. Tajora is in the northern part of the country with 130,000 inhabitants, and we have 12 health centers that are actually in 11 and we also have various community workers. The method, we had a descriptive method on the 10th of January 2022 in Tajora. The various cases and the directive of WHO were used. The data collection was done in the health center of Tajora, and we consulted many register and labs, and we also work with various health workers, and we used molecular biology to do various things, and we calculated the median age, the proportion of ratio, men and women, and we did other things. So the results are, as you can see, we have various suspected cases per gender. We have 46% for women and 54% for men. And the results of TDR, out of 24 cases, we only had one positive case. It was actually a family contact, and they were living together. So after that, we assessed the vaccination anti-COVID-19 in Tajora, in the regional council of Tajora, and we had 17 people, 61% of people that were vaccinated and 7% that were not vaccinated. 7% that were not vaccinated, 29%. And 24 contacts were listed, and it was actually the cases that were in permanently, who had permanent contact with that young lady. The median age of the contacts was 40 years, and the ratio of the gender, it's 1 out of 18. And there were some positive cases. And 71% received the vaccine for COVID-19, and we had many women that were not vaccinated, and they were part of the regional council of Tajora. And additional cases were isolated, and we had a follow-up of 14 days for the other contacts. In conclusion, the investigation enabled us to list all the contacts and to find additional cases in the community. And that's why we limited the consequences of the contagion. And the actions of public health were undertaken, like washing hands, isolation of positive cases, and we also had awareness campaigns on the various measures, and some recommendations were given to the authorities and to also the health workers. Thank you very much, and I would like to thank UNSPD, the Ministry of Health, and AFENET Djibouti, and all the FETP. Thank you very much. Thank you, thank you, thank you.
Thank you very much, Monsieur Adake. I would like to invite the last presenter for this session, Monsieur Abdurrahman Balde. Thank you.
No. Yeah, Bashir. Yeah.
Thank you for giving me the floor. My name is Abdurrahman Balde, FETP in the Republic of Guinea. Thank you. Thank you very much, moderator, distinguished evaluators, dear guests. Allow me to present to you the content of my work that is about the investigation of the cases of COVID-19 in the health region of Fria in the Republic of Guinea. COVID-19 is a viral infectious disease that is caused by the SARS-CoV-2, and it was discovered in 2019. And Guinea had its first case the 12th of March 2020, and in December 2021, a nurse of the Fria hospital that talked about the cases were tested positive to COVID-19. And that's why we undertook an investigation, and we had the following objectives. The general objective was to determine how difficult that situation was and to have control measures and to test all the staff of the hospital and also to define all the demographic staff and also to see how many people have been affected by this disease or this virus. And to reach these objectives, we did a descriptive study from the period from 5th to 12th January 2022 and the definition of case, and we had some surveillance of COVID-19 in Guinea, and it was operationalized, and we also did some activities, and we tested all the staff, and the PCR test was done to all the staff. And we also have social demographic variables, and we also looked at all the risk factors, and we did investigation as far as SARS-CoV-2 is concerned. And our data was extracted from DHIS2, and it was aggregated with other softwares, and we calculated the median so that we could summarize our different variables. And during our investigation, 69 staff that were tested, 36 were tested positive. And among these positive cases, 55.6% were asymptomatic cases, and among these asymptomatic cases, 55% were light cases, and there was no severe cases that were observed. Cough, Cephale, and actually pulmonary issues were the dominant ones. And actually we had about 27 years old for the median age. And we also had 21 to 30 years, and female gender was actually the gender that was the most affected, and it was about 72%. And when we talk about the vaccination status, and 64% of the cases were vaccinated. And I can tell you that the services of surgery was actually the ones that were the most affected. In conclusion, more than half of the people or the staff were affected, and I can tell you that most of the cases were symptomatic. And there was like an age group to 21 to 30 years, and the most affected gender was the female gender. And I can tell you that the Department of Surgery was the most affected. At the end of our investigation, we undertook some public health actions. There was vaccination of all the contacts, the sensitization of all the staff, and all the people to follow the various measures to avoid transmission, and also to vaccinate all the medical staff. You can see the picture that is in front of you. That's how the medical staff was vaccinated in the hospital of Fria. And all these actions led us to reduce the transmission. And I can tell you that there was no more vague wave of COVID-19 that was done in the Fria hospital. Thank you very much for your kind attention.
Thank you very much, my panelists. You have pretty much presented within the given time. I would like to invite questions, one question for each presenter. So we have here Monsieur Bulaba. Question for Monsieur Bulaba? Yes. Make it precise, please.
Can I proceed or?
Please proceed.
Okay, thank you so much.
Because he presented in French, I'm going to ask the question in French. My question is to Ahmed. I'm sorry if I don't pronounce your name properly. You presented on the health profile of the students in the primary schools in Djibouti. Thank you very much for your presentation. It was a very good study. But in your study, you said that you found that there were some children that have anemia. So I would like to know, what were the type of anemia that you actually observed in those children? And what are those equipment from the lab that you've used, if you use them, of course? Thank you very much.
Thank you for your question. We have to understand that during the investigation, we did have some samples so that we can do tests in the lab in order to help us to have blood count. Am I answering to your question? Indeed. I hope I'm answering to your question. So the sampling that we got at the lab was to have the blood count and to understand which type of anemia was there.
And sir, that you interact with him and you can get your question answered later. In the interest of time, I will invite a question for either Keita or Bulaba.
No, it's not. It's just a better contribution for
Make
this
it
question.
very precise,
yeah.
please.
Okay. I'm the head of this department in PHI directors. Just to inform that, en fait, juste pour informer que il y a une étude.
I just want to say that we do have a study which should have assessed the health status. So we did assess tested water, and we did it at the rural area to find out why in the rural area the children were not successful. So for more information, we'll give you the protocol. Yes, just to complete on what my directors say, those was anemia where the pathogen was evaluated at 80.
Information. A question to another presenter, question to Bulaba, to Keita. Okay, I have a question for Monsieur Bulaba. You mentioned AF paralysis from vaccine-derived paralysis. To what extent does that affect trust within the region when it comes to vaccines. Could you tell us whether that has any impact on community trust in vaccines? Over.
Merci pour la question.
Thank you for your question.
En fait, le message que nous avons apporté à la
The message that we gave to the community, it was not in that direction. So we explained to the community that as long as the vaccine coverage is weak, if family are not bringing the children to be vaccinated, there will be a problem with the vaccine because in other places in the world, the vaccination was able to eliminate polio. So it wasn't a matter of confidence or trust, but they just understood that if they don't bring their children to be vaccinated, we are not going to reach the collective immunity. If we don't have 90 or 95% of the children vaccinated, we won't be able to achieve the community, the collective immunization, so that won't be good for them. That is why we launch sensitization to this community to convince them to bring the children to be vaccinated. So it's not about the trust for the vaccine, but they needed to understand that we have to have high coverage of that vaccine.
A question for another one of our panelists. Any question for Keita or for Abdurrahman? I know. Yes, I have a question for the last presenter on the hospital infection. When it comes to surgery, it becomes very challenging to avoid the proximity to the patient. So you say the surgical unit was the most affected. What measures did you take to ensure that even if they have to perform the surgeries, at least they are protected?
Allô? OK. Les mesures qu'on a prises, d'abord,
the measure that we had was barrier measures, washing hands, and then the vaccination of all the staff.
Thank you very much. I also have a question for Adake, Monsieur Adake. It seemed from your presentation that you were very successful in reducing the spread of COVID within Djibouti. I just wanted to get an indication of what was Djibouti's number of cases across the period of time, or was it in just that area?
Merci beaucoup pour votre question.
Thank you for your question. I was not talking about Djibouti. I was talking about the Tajora region. We didn't have a lot of cases. This was the only cases that we investigated. So we managed to isolate the case, and we were able to protect the population because of the investigation. So people have been isolated and receive treatment.
I was a bit confused. I thought it was it's just for that region. Okay. Gentlemen, I would like to thank you for this session, and a hand clap for the gentlemen for their presentations. As we move into the last round of poster presentations, I would beg that people don't leave, please, please. Let's allow our last presenters to present. I would like to invite Philippe, Kasonga, Obin. Philippe, Obin, Sudu. I think he has come. Balder, Monsieur Balder, Basiru, Amadi Ba, and Amatus Nambajira. Okay, so we are doing the last lap, and I will quickly invite Monsieur Kasonga to come give his presentation. You have 5 minutes, and it's going to be broadcast here. Thank you.
Bonsoir à tous.
Evening. I'm Dr. Philippe Kasonga, frontline doctor in the DRC. So we are trying to be brave on the investigation on measles epidemic in the Lubilanji in Kasai Oriental province in DRC from September 2022. As you may all know, measles is one of the heavy problem for country with feeble revenue. In fact, this is the 4th cause of mortality for children under 5. So the health center Lubilanji had an outbreak of measles from the 12 to 19 weeks. So we did launch a vaccine campaign, and then on the 37th week, there was we could contain the outbreak. So it just later on that we had some cases which has been reported about the measles outbreak. We did use a descriptive study. We use the review of data collection tools. We talk with the person in charge of those children who are affected in the community. So we came up with the definition of suspected cases of measles according to where it was coming from. And then we use the symptoms on the period from 12 September to 2 October 2022. So you can see the map of the health center. We had the 3 administrative cells. So in the middle we have Red Cross where the case has been signaled. Talking about our results, so you will note that from the definition of these cases, we had on the graph, you can see that within the 37 week that we have the peak, and then we did the investigation on the 38th week. So you can see from this health facility that there was a mortality of 5%, and it within the Mitutungulu region where they had 2 deaths. We want to say that the age group was from 12 to 59 months. So the female were more affected at 0.5. 96% of the children have been vaccinated. We took samples from 11 cases which we sent to Kinshasa within the NRB lab. So we had set positive cases.
Given what we have talked about, we compared our results with studies that have been undertaken before. As regards the age bracket of 12 to 59 months, it was noted that it was found in a study undertaken the DRC with VNH6 in 2021 in Chad and the Central African Republic in 2019. As regards the ratio, our ratio was 5M.25. That was what was found in Bamako in 2012, which was 1.08. As regards 96% of the children that were vaccinated who had measles, these results contradict what was found in Ibang in the DRC, where the proportion was 63%. In conclusion and recommendation, you note that this investigation enabled us to confirm the measles epidemic in the health district of Egude. And we looked at the children and the medicine they had taken, and looked at epidemic incidents, and we looked at the routine PEP, and we sensitized the communities as regards this measles epidemic. Some recommendations were drafted, were made. We should undertake an analytical study to determine the factors associated to the emergencies of this epidemic in this area, because we undertook a descriptive study. We thought that in the future, we must undertake an analytical study and also do advocacy to obtain refrigerators in this health district. That's a photo. We are now in the Red Cross health facility undertaking a first station. There are some mothers who brought their children. Thank you very much.
Thank you very much, Dr. Kasonga. Ladies and gentlemen, I'm going to beg your indulgence. I have just been informed that this room is needed urgently for a greater purpose. I want to request all of us to move downstairs to room 2 so that we can give these gentlemen a chance to complete their presentations. As you all know, we are running late. We have a big function this evening, and this room is needed. So kindly indulge us. Let's move quickly to room 2. Please do not run away. We need you. Thank you. They might.